the first ever approved ACR education partner. Brought to you by the Emirates Rheumatology Academy. This activity is included in the ACR's Education Partner Program. Don't miss the chance to attend the best rheumatology hybrid meeting in 2021. Meet our top-notch expert speakers: Dan Baruch, Gerd Burmester, John J. Cush, Megan E. Klaus, Doric Erkin, Laura Gossick, Arthur Kavanaugh, Peter Nash, Christopher Richland, Philip Seo, Joseph Smolin, and Richard M. Silver. They will present hot topics selected from the best of ACR Convergence 2020. Benefit from free registration. For more information, visit our website at www.era-rheumatology.org. See you all there.
Dr. Imad Jassim, Consultant Rheumatologist, Head of Department at Tawam Hospital, Abu Dhabi, UAE. Dr. Rajay Namaz is a Section Head of Rheumatology at the Medical Subspecialties Institute at Cleveland Clinic Abu Dhabi. Prior to joining Cleveland Clinic Abu Dhabi, Dr. Namaz served at the University of Michigan as a clinical lecturer for 2 years, and was supported by the National Institute of Arthritis, Musculoskeletal and Skin Diseases. He was then promoted to clinical assistant professor at the University of Michigan. Dr. Namaz received his medical degree from the University of Tripoli, Libya. He completed his postdoctoral training at the University of Pittsburgh, Pennsylvania, U.S., followed by his residency in internal medicine at Hurley Medical Center, Michigan State University in Flint, Michigan, U.S. Dr. Namaz completed his clinical and research fellowship in rheumatology at the Wayne State University/Henry Ford Hospital in Detroit, Michigan, U.S. Dr. Namaz is currently active in numerous research projects focused on treatment strategies, measures of outcome, and translational studies of potential laboratory markers of disease activity. He has multiple publications and awards in the field of rheumatology, and is a reviewer on multiple peer-reviewed journals. Dr. Namaz is a member and fellow of the American College of Rheumatology and American College of Physicians. Doctors, the floor is yours.
Good afternoon, everyone. Good afternoon to all who are attending in the Raffles Hotel and those who are on virtual. It's a pleasure to be here in the Best of ACR conference organized by the Emirates Rheumatology Academy. And it's a pleasure also to join you today, me and my colleague, Dr. Namaz, thanking AbbVie for inviting us to give this talk. The talk will concentrate about the JAK inhibitors profile through the lens of real-world clinical practice. We will share with you some local data and some cases. Hopefully you will enjoy it, and feel free to ask, please, through the questions on the virtual, or we will receive them and we will be happy to answer them. So today I will start with the talk, and then between us, me and Dr. Namas, will try and make it more enjoyable for you. Okay, so my first, I'm going to start. As you know, rheumatoid arthritis has a lot of burden on people, and it's not only a disabled disease, it's actually a delay, or it reduces the lifespan of patients with rheumatoid arthritis by about 10 years. And the most causes of death are cardiovascular disease. The malignancies are higher than the normal population by about 21%. And they usually also have respiratory diseases. You all know about the ILD, UIP, organizing pneumonia, which will lead to the lung failure and death. The disability is very high, about 6.1 million disability adjusted life years. This, of course, due to the radiographic progression of the disease causing damage. And this damage, it's irreversible when it happens. And we all know that we have now medications which stop the damage. In addition to that, patients will suffer from depression, GI disease, from medications, as well as from complications. Those with asthma, ischemic heart disease. Also, patients may have hepatitis on the top of the RA, which make it difficult for us to treat. Now, we all know the EULAR guidelines and the targets, so treat to targets. And our targets as physician is achieving remission or a low disease activity, which still delay the progression of the disease and the damage. So this is our target. But not only that's the beginning of the target. We need to sustain remission. So that means every visit, in about 6 months, these patients are still in remission or still in low disease activity, so we can continue medication. And that's the most important. We can achieve remission, but maybe after 2 or 3 months or 6 months, the patient is having flare, which means that the patient is not in a sustained remission. That's the major targets. And of course, we have other targets, the patient-reported outcomes, like pain and fatigue, which we shared with the patient and treat to target. Having said that, very small numbers are reaching these targets. We still have unmet needs. Patients still having pain, they still have fatigue, they're still depressed, they still lose their jobs. And one of the reasons here is that commitments of the patient to have injections plus methotrexate, and which we will show in our talk, is something which is difficult for a patient, preferably, or to comply with it. So the history of management of RA, you all know as rheumatologists, has changed from the beginning of the last century, and especially from the 90s and the beginning of this century, where we moved from tablets, a few tablets and gold injection, to a lot of biologics therapy and recently JAK inhibitors. And those medications helped us to achieve remission. And the goal is here from the, let's say, 90s, is to step up the regime, diagnose early, treat aggressively using maybe high doses of steroid, like in the COBRA study, with biologics starting as soon as possible to achieve remission. And as we said, we now deal with treat to targets. Having said that, how many of those patients get in remission? And this is from a registry, a big registry, showing that with all the medications we have, and this is really published 2018, we still have, that by the DAS score, which is easy to monitor, only achieving 41 or 42%. And if you use the CDI, 22%. And if you use more joint investigations or examinations using the Boolean remission score, only 17.5% of our patients are achieving remission using the Boolean. So it is a small number, although we have so many medications, which means we still have unmet need. We still need more medications. We still need more aggressive management. So now I would like to ask my colleague, Dr. Rajai, does he have a local data showing us the burden of the disease in UAE? The floor is yours. The microphone is yours, Dr. Rajai.
Yes, indeed, Dr. Imad. So in 2019, we had this. We were curious about understanding the burden of the disease in the UAE, and we looked into our registry, and there was about 415 patients, Emirati patients. So we just sought to look into a focused population, an Emirati population, and we were astonished when we did this exercise, looking at the point prevalence of the disease in the UAE in a single center. We found out that the prevalence was higher than what we expected. It was 2.72. And of course, in females, it was higher than males. There's a lot of, I think this is to verify this further. We need a national registry to look further into this. But this is more a point prevalence in a single center, a tertiary centers. But we learned multiple points from this study that which reflects what we see globally, that the disease burden is in a middle-aged population. And most of these patients, as we know, they have their life, they work, and I'm sure because of the burden of the disease, as you mentioned, results in loss of jobs or taking more off days. And also, we learned other points that similar to what we saw, that there's a lot of comorbidities that we see with rheumatoid arthritis, including the highest that we saw in our cohort was dyslipidemia, hypertension, and diabetes. And most of those patients were on methotrexate. Next. And if we look at the comorbidities of the disease, as shown by Dr. Imad, we see a similar trend. The most reportable or the proportion of comorbidities, as mentioned, were dyslipidemia, hypertension, diabetes. Just want to focus a point here about depression. Most of the patients, they feel shy to report this, but I think if these days I'm asking more patients about depression, as Dr. Imad mentioned, depression was one of the highest in the international cohorts. I think most of patients are depressed due to pain, and still, this in that paper we didn't show it, but still we are not doing a good job with achieving sustained remission of our. And this is, due to multiple factors, patient preference, doctor's preference, education, and other. So, Dr. Imad, why do you think locally, or what are the reasons globally that result behind not delaying the remission rates?
Thank you, Dr. Rajai. That was interesting. This study actually has shown that the preference of patient in the treatment is taking a pill rather than an injection, showing in this study comparing between IV treatment or injections compared to oral treatment. And you can see they're significantly preferable to the oral injection. And when they have been asked about whether using combination or a single or monotherapy, you can see again that those patients would prefer monotherapy rather than using two medications. We see that with our patients here. All of us know who lives in the Arab world or working here, that patients are preferring more tablets, and also they like to take one medication rather than two. And in this study by Paul Emery team has shown in those patients being given methotrexate and being told to take it like 20 milligram or whatever, 8 tablets of the 2.5 or 6 tablets of the 15 as they use in UK, 2.5 milligram, only about 42% reported not taking methotrexate exactly the way they've been asked to do it. And actually, when they looked also on those who are using biologic as a combination with methotrexate, which is better than a monotherapy, when you use like anti-TNF and other biologics, 30% of patients taking biologic use them as a monotherapy. So they drop the methotrexate by themselves, which is an interesting. We looked at our JAK inhibitors from 2019 to 2020, the prescription, collected about 42 patients on tofacitinib, and you can see out of the 42%, only 14 being on combination, and the others on monotherapy. And the same with baricitinib. We have 14 patients. I have about like 13 out of those patients. And 8 of these patients is on combination, while nearly half of them on monotherapy, as they prefer to be on monotherapy. So I'll be back to you, Dr. Rajai. Do you think that it's the same in a local practice?
So what we did to answer this question, we looked at, we did this exercise. So we applied for an IRB to assess the awareness of the disease in the community. And I think it's important whenever to understand how patients approach the disease and what are the preferences of the patients. So we recruited 300 patients. 200 were patients with an established diagnosis of an autoimmune disease, and they are currently commenced on a DMARD. And we looked also on the other arm, on 100 patients we gave them attending the clinic to be screened for an autoimmune disease. So those patients did not have any underlying autoimmune condition. Next. So, and most of our patients, as you know, are from the Emirates. About 78% were local, and we gave it to other citizenship just in the future if you want to compare, different countries or different citizenships. Most of them were rheumatoid arthritis and lupus, and there was a couple from other diagnoses. Next. And about 50% of those were, or more even, 60% were on a conventional synthetic DMARD. The most frequent was Plaquenil, Arava, sulfasalazine, and methotrexate. And we were, as expected, as Dr. Imad mentioned, about 70% of the patients preferred an oral drug versus a subcut or IV. And the patients who were screened for an autoimmune disease, the number even was higher. There was about 85%. And just an off-label, I didn't mention it, show it here, but most even the patients that were on a subcut or an IV, they wrote a note that we would like to discuss further with our doctor what are the other oral preferred options. Next. So coming back to Dr. Imad, what's your experience with upadacitinib in the UAE?
Okay, not a lot, but I do have this case which I would like to share with you, with the listeners. This is a lady who was a 51-year-old lady, Emirati, originally, I think, from another country. I saw her first 2017. She was diagnosed seronegative RA by one of our colleagues. And when I saw her, she has already tried methotrexate, hydroxychloroquine, and sulfasalazine with failure. She used infliximab, tocilizumab, and when I saw her, she was on golimumab plus methotrexate. And I did for her a couple of times a refill of golimumab. But when I saw her, probably the end of 2017, she came saying, I don't want to use golimumab. When I said, why, you've been doing well, she said she had infection. So I reviewed the dermatology, and she was seen a few times with an abscess at the site of the injections, and she had a history of cellulitis. So she was adamant she doesn't want any more injections whatsoever. So I started her on tofacitinib, which was the only JAK inhibitor available in Tawam, plus methotrexate. But then by around January, I think she admitted that she's not taking methotrexate. She was only on monotherapy. So she disappeared. There's an echo. What's happened here? So she disappeared. I think somebody's opened their microphone. Disappeared as she went to Abu Dhabi. And she was treated by another colleague in one of the hospitals in Abu Dhabi. And she dropped everything. She stopped everything. She wanted only to take hydroxychloroquine. And I think this is mainly when the coronavirus pandemic started. But she came back to me last November with a bad flare, multiple joint swelling, and high DAS score. And again, she wanted tablets rather than injection. And so I offered to put her back on tofacitinib. She said no. Actually, she never felt much better when she was using it as a monotherapy. So I thought we'll give her upadacitinib as a monotherapy, and the studies of OPA and monotherapy was very good. And we waited because it's non-formulary for about a few weeks, like about 4 weeks to get it. Amazingly, this lady, I have to say, is not a compliance lady who usually really complained a lot about medications. But when she came to me end of January, she said, "This drug is brilliant." That's her words. And I hope she will continue on it, and I hope she will be in remission, as I showed in her last visit. And of course, I'm showing here her ESR is dropping after the use. The studies of the upadacitinib, they have the select monotherapy and select compare. The compare, they compared against adalimumab and placebo. The hash here is the showing statistically significant comparing methotrexate and upadacitinib, or upadacitinib, and methotrexate compared to adalimumab. So the stars are comparing to placebo, but the hash compared to adalimumab. And you can see that the remission of both in all DAS, CDI, SDI, and Boolean, they used the Boolean showing significantly better than adalimumab. And when they looked at monotherapy in those patients with methotrexate responders, so those patients never had biologics, and they are on monotherapy compared to the methotrexate placebo arm, showing nearly the same numbers. You can argue that the population different here, and of course, I have probably more early patients, but the numbers here, you can see 28, 13, 14, and 9, showing using monotherapy was working and achieving remission, not needing methotrexate. The same in patient reported outcome and pain, which one of the main reasons we treat the patient want to get rid of, showing a much better and statistically significant comparing methotrexate to adalimumab. And in the monotherapy arm, again, about 26% compared to 32% using methotrexate. This study is really interesting. This study looked at switching or cycling between the same mode of action. So they looked at these patients, nearly 300 patients, and made it two arms. An arm which failed one TNF, and they moved between TNFs like adalimumab, certolizumab, etanercept, or infliximab, called cycling group, or another arm using another mode of action, another biologics like abatacept, rituximab, tocilizumab. There is no JAK inhibitors here, as they're non-biologic, as you know. And interestingly, the switching showed a better good response. Maybe the moderate response was nearly the same, but a good response was higher in the group, in the switching, which we all know that switching may be better to another mode of action. But again, you can look at this study both ways, that cycling is between same medication for those patients who want to stay on the same mode of action, like tablets. You can still use it, although this is not a JAK study, as I explained. Or you can switch to another mode of action. So that's why the ULR and the ACR guidelines gives you an opportunity of moving between drugs. Back to Dr. Rajai, can you share with us your experience in using upadacitinib, please?
Thank you, Dr. Ahmad. So this is just an overview of our short experience with Rinvoq. And you can see just just a snapshot that most of the patients were on multiple drugs. I mean, this gives you how much the burden of the disease and how much there's switching or cycling between medications in the region. So, so I'll share with you the one that's highlighted, number 7. So this is a very nice Emirati lady, 60 years old, multiple comorbidities, obesity, obstructive sleep apnea, hyperuricemia. And at the age of 55, she presented with in an external facility with symptoms suggestive of an inflammatory joint pain. She was seen by a rheumatologist, diagnosed with rheumatoid arthritis, and she was a seropositive rheumatoid arthritis. She was initially commenced on a subcut methotrexate. In 2015, well tolerated. She was doing well until 2018. In 2018, her symptoms flared, and she had multiple flares. And at that time, she received only 1 dose of Actemra. She didn't like. She wasn't happy with the notion of receiving an IV drug. She was concerned about the side effects, and she was switched back to an oral methotrexate because she wasn't keen to be on a subcut drug. In July 2018, and then she decided, to switch care to Abu Dhabi. When I saw her first time in 2018, her DAS score was elevated. She had a high disease activity. Next, Dr. Iman. And she was having a dry cough. Even her primary rheumatologist was concerned about lung disease and associated with wheezing. We did a CT, and there was some the chest X-ray. There was some basilar interstitial markings. We did the CT. There was concern about the possibility of an interstitial lung disease. There was minimal fibrosis, less than 20%. Pulmonary gave us a green light to continue methotrexate. We informed her about alternative medications. She decided to continue the same medication. We increased the dose to 20. And at that time, the COVID era came, the pandemic. And each time you call her, she say, I'm fine. And I think most of our patients during the pandemic, they forgot their pains and they were more concerned about COVID. And whenever, how much you're paying, it's zero, zero. But then, after 3 visits, she came to the clinic. Next. And she was in high disease activity. And this was about in September. And at that time, in August, and at that time, we decided to put her on a monotherapy. And after risks and benefits were discussed, she agreed to be in Rinvoq. We at that time I was curious to build experience with this drug, and shortly after, a couple of weeks, her, as you can see here, her DAS score and CRP dropped from high disease activity to a very low disease activity. So this is one of the patients that you can say that they are methotrexate inadequate responders, even though she received 1 dose of Actemra. Dr. Imad, what's your experience? Any other thoughts?
So thank you, Dr. Ajay. Very interesting case. Again, back to the JAK inhibitors we have. As I said, I have at the moment 1 OPA, and we have another colleague who used it. So looking at the TOFA here, interestingly, that using tofacitinib, we have 42 patients. Looking at those 42 patients, half of them stopped the drug. And actually, when I looked at the XR compared to the 5 milligram BID, more of the patient, like we had 20, I think, on XR, 10 of them stopped the XR failure, especially those who moved from 5 milligram BID to the XR and continued. The other half is still taking the tofacitinib. Those that looked at the prescription 2019. We have baricitinib, about 14 patients, still 13 on it. And the one who stopped it, actually, the one who stopped was a patient who was on it, but when they came to Tawam, end of 2018, we didn't have the drug, so moved to tofacitinib. Now, when we look at those patients changing from one medication from tofa to the others, we can see 7 patients baricitinib and 2 went to upadacitinib. So nearly half of them went to another JAK, so cycling between the medications. Others went to tocilizumab, and the rest were one ixekizumab because it was psoriatic arthritis, did not respond well to tofa. And the others lost to follow-up so lost to follow-up or 2 sadly died. We looked also, I looked at the patients who are, sorry, I'm just trying to see, used previously biologics. So looking at the tofacitinib, we can see nearly half of them used previous biologic, and nearly 10, which is quarter of those, had more than 1 biologic before moving tofa. Similarly, nearly on baricitinib, that's 10 out of 14 used previous biologic, and more than 1 biologic, they had 6 used 1 more biologics. And this has reflected in the studies by the Rinvoq, by AbbVie, looking at select early, those with methotrexate naive, select compare, comparing it to the adalimumab in methotrexate responders. There's the monotherapy I talked about. There is select next, looking at patient who had conventional DMARDs and responders to conventional DMARDs. And Dr. Ajay will talk more about select beyond, looking at those who used biologics before and moved to Rinvoq. So back to you, Dr. Ajay, to share some cases with us, please, and the studies. Thank you.
Thank you, Dr. Ahmad. So this is a very challenging case, and I'm sure all of us have one such case that you scratch your head at the end of the clinic and say, I'm doing the right job, or maybe there's something different that you need to do. And this is a 31 years old pleasant lady from the UK, diagnosed with seropositive rheumatoid arthritis in 2006 and 7. At that time, she was presenting with joint pain and swelling suggestive of an inflammatory arthritis, was initially commenced on a methotrexate weekly as per guidelines. She couldn't tolerate it in the beginning. She had GI upset, and she was switched to subcut, which was well tolerated. Hydroxychloroquine was added. And this was all, managed in the UK at that time. She was on sulfasalazine. She said that she developed visual disturbance, was stopped, methotrexate and Enbrel for almost a year. She was doing well. After a year, she was labeled as a primary failure. She was switched to infliximab again after a year. So she does well in the beginning for a couple of months, for 2-3 months, and then things start to flare. Switched to rituximab in 2011, but due to profound late onset neutropenia and recurrent infections, she used to get a lot of Bartholin infections in the vaginal region, and at that time it was stopped. She was fed up. She decided to stop everything, went into holistic approach in 2014 and was doing well. Next. In 2014, 15, things worsened. She's a nurse. She works, and she started having more symptoms interfering with her jobs. She went back to her primary rheumatologist in the UK. He gave her depot shot. He did an ultrasound at that time and found to have findings consistent with an inflammatory process. And she was restarted again on methotrexate, multiple painkillers, Voltaren, paracetamol. Then, switched to tocilizumab, methotrexate with toci, subcut. And of course, during that period, also she received multiple intra-articular injections, MCPs, PIPs, and knees. Next. And, this was my first encounter with her in 2017. And after reviewing her chart, she had a big chart. She has a historical diagnosis of seropositive, multiple DMARDs. And at that time, we didn't have subcut tocilizumab. So we had only IV, and we switched her to IV tocilizumab. Next. A baseline X-ray showed, as you can see here, there's sclerosis and narrowing of the joint space in the wrist, indicating a very aggressive and ongoing disease. We did a baseline MRI just to confirm that is this a real disease or not, and there was bilateral chronic active inflammatory arthritis, which is more severe in the left wrist. Next. In 2017, she was on methotrexate and toci, which she had been previously on, but before that she was on subcut. She received her first dose in 2017. However, during that time, she developed a lot of infections, mainly Bartholin cyst infections, and requiring multiple incision drainage and antibiotics. We gave her about 9 infusions. She was still, active, joint pain, swelling, stiffness. And there was this concern about a possible immune mediated response from Actemra, which is reported. She started developing malar rash, joint pain, and the drop in her complement, C3, C4. And I was concerned about the drug-induced process. There was a negative double-stranded DNA and antihistone. So we decided to switch to a different disease-modifying drug. Next. An ultrasound was done, and it was again suggestive of synovitis. We gave her multiple intra-articular injections. She was not keen to be on a subcut methotrexate. She was okay with being on oral, even though previously she couldn't tolerate it. At that time, we started her on Xeljanz. She did well, follow-up 6 weeks from high to moderate disease activity. We decided, on the subsequent to achieve more sustained remission or to achieve remission at that time to increase the dose of methotrexate to 20. Next. And she was on Arcoxia on daily basis. After 5 months, we couldn't go below 5 milligrams of prednisolone, and at that time we agreed, okay, let's switch to a different drug. She was still in that perception of continuing oral medication. She refused to be on a subcut, and she didn't have that much, options. And we say, let's try baricitinib. And at that time, this was the first experience cycling between JAKs. I told her there's no studies, but she was fine with going to a different JAK. We tried. She was doing well. She went into a low disease activity, remission state. We titrated the methotrexate from 20 to 15, and in June she was planning to conceive, to get pregnant, and she wants to be off methotrexate for at least 3 months prior to pregnancy, and we decided baricitinib at least 10 days or 2 weeks before trying to conceive. Next. And you can see with baricitinib in March, there was a clinically meaningful decline in the DAS28, and ESR and CRP from about 4.5 to 1.25 and 0.8. Next. So she came after a couple of weeks, and after stopping methotrexate, and again, things went back to zero. She couldn't be off methotrexate, and she was in a very high disease activity state, joint pain, swelling, hands, feet, wrists. And again, we say, let's postpone a little bit pregnancy and let's increase the dose of methotrexate to 20 milligrams, and we gave her a depot shot. Next. We did an MRI at that time, just again to confirm the burden of the disease, or the progression of the disease, and there was persistent active bilateral inflammatory arthritis with erosive changes. And next, Dr. Imad, sorry for the time, we're running out of time. And we went again over all the drugs that are available: Rinvoq, Subcut, Cimzia, Subcut, Symphony, IV abatacept, and or going back to rituximab. And again, this was a learning process or a learning curve, and there was no data, and we decided to switch to Rinvoq. Next. And again, at that time, her disease was in a moderate disease activity state. Next. And as you can see, just a follow-up after about 6 weeks, there was a clinically meaningful decline of her disease activity score. She was off steroids, she was off arcoxia, or arcoxia as needed, and methotrexate. Now we are trying to titrate it. Next, from 20 to 15. And you can see in the picture, this was pre-UPA, and at 6 weeks of UPA, you can see a clear change in there was diffuse swelling at the MCPs, PIPs, even the wrists, and even the dorsum of the hands. And you can see now there was a nice improvement of her clinical symptoms, clinically and serologically. Next. So just go quickly over just the Select Beyond, which is one of the the drug development programs, and they looked into patients who were TNF or biologic DMARD inadequate responders. And you can see here, most of the patients enrolled in the study were either received a 1 or 2 or 3, more than 3 biologic DMARDs. And most of them were more than 80% were at least more than 1 failure to an anti-TNF. Next. And clearly, as you see here, so it was a very nice, as you see, statistical analysis at week 1, even as early as week 1, you can see a statistical significant improvement in the ACR 20 compared. So the yellow bar is the approved dose, it's the 15 milligrams, compared to the placebo, which is the orange bar. And this was also consistent with the other ACR 50, 70, and ACR 50 and 70 at week 12. Next. And you can see among all the disease activity scores, even the stringent ones such as the Boolean and the SDI, there was a clinically meaningful improvement in the disease activity scores in patients who received upadacitinib versus placebo, whom were on conventional synthetic DMARD. Next. And so I will end here by Dr. Imad. What's your final verdict about the final study?
Yeah, I mean, thank you. So this study has shown that people using JAK inhibitors compared to those using other biologics, anti-TNF, abatacept, and interleukin-6 inhibitors, that those who discontinue the JAK inhibitors were less than those who are using biologics. Patients on JAK inhibitors were treated more often as monotherapy, had a higher CRP on starting of the medication at baseline, and had experienced more previous biologic and target DMARDs, maybe similar to our patients whom I showed, and the case Dr. Rajai shared with us. It just said overall drug retention of JAK inhibitors tended to be higher than anti-TNF, as we see here, the purple line here on the patients staying on the JAK inhibitors. So the questions maybe to answer about these studies shared with you is that can we achieve improvement versus a standard of care? Upadacitinib and methotrexate demonstrates significantly higher rates of remission compared to adalimumab and methotrexate. Can we demonstrate consistent efficacy with and without methotrexate? Upadacitinib has shown, as we showed to you in the select monotherapy, that its efficacy with or without methotrexate as a monotherapy. Can we
Dr.
achieve
Imad,
consistent outcome across different?
I'm really sorry
Yes,
to interrupt. It's such an interesting discussion going on, but sorry to interrupt. I think we're running late, and
we
may have to
started
hurry
late,
up.
Bhavna, because of the Friday prayer. That's why. But we are hopefully this is the last 2 slides. If you can let me finish, is that okay?
I think we are already 5 minutes beyond our time.
So we started 10 minutes beyond because I told Walid that whoever put the program doesn't have a common sense.
Okay.
So if we can just finish this.
Yeah.
So this is the last slide. There you are, conclusion. So what we discussed here is that we showed in our presentation that you can cycle between medication, you can change the switching. We showed that monotherapy is preferred by patients, and they prefer also oral medications. We have to diagnose early and treat early, intensively, and monitor early to achieve remission and sustain remission. Thank you very much. Can I stop sharing here? I'm happy to take questions if there are any questions.
Yeah, I don't see any questions, but I think we're running out of time. Sorry for being quick.
Sorry, but yeah, it's just because of the...
Again, thank you very much, and thanks for AbbVie for this kind invitation. Thank you, Dr. Imad.
Thank you, Doctor. Yeah, thank you. Thanks to the listeners.
Thanks to all the audience, and happy Friday to everybody.
Thank you.
However, if I just mentioned, when we talk about celebrities quite often have more than one talent, like singing, dancing, acting, could be painting, poetry, anything like that. So I'm amazed that we could have something similar in the rheumatology field. We have a person with multi-talent leading in the imaging stage, leading in the JAK stage, and now talk about some new topic, which is radiosynovitis, arthritis, and its local treatment. So I'm prepared, I'm ready to welcome Dr. Bhavna Khan, who is well known to us, graduated in UK, had a PhD in Manchester about pain and functional neuroimaging score, worked there as a consultant, and then moved to Dubai, and now currently working in the King's College Hospital in Dubai, as well as integrated arthritis care. And she is one of the leading rheumatologists, as I said, rheumatology celebrity, put it in between brackets, that she can talk on so many different topics. The stage is yours, Bhavna.
Thank you. Thanks, Atir. Thank you so much for that kind introduction. One thing I'm really excited about this afternoon is to talk about a topic which has no complex statistics, no complicated graphs, and no pharma, interest, and no major drug trials. And that's what makes me very, excited about. So the topic I've been asked to talk about today is radiosynovectomy, also known as radiosynovioarthresis. So again, it's a little tongue twister, but radiosynovectomy is an easy one to use. So what I'm going to review today is, in this era of biologics, new molecules, new exciting discoveries in the field of inflammatory arthritis, do we need to step back and think if there are some simple therapeutic areas that we can implement in clinical practice? So, well, first of all, thanks to Dr. Walid to suggest me to talk about this topic, and also I think by popular demand, some of my colleagues on our group requested to talk about this. So when I started preparing for this, I realized I had done a similar talk 4 or 5 years ago. There hasn't been much in this field, and that is really sad. What I'm going to start with is a simple couple of case scenarios, just to put everybody into the perspective and to see where this simple procedure stands in the treatment algorithms of inflammatory arthritis. So the first case is a 52-year-old Canadian lady I saw in 2016. When she had moved to Dubai, she was suffering from a polyarticular flare of her inflammatory arthritis. Prior to that, 2 years ago, she had developed a painful swelling of her knee with polyarthralgias in Canada and was treated with an intra-articular steroid injection in that knee joint, which had temporarily settled it. However, on moving to Dubai, she started experiencing more flares and hence consulted me for further management. So when I saw her, she certainly had polyarticular disease, but her bilateral knees were persistently synovitic. And keeping in with the treatment guidelines, after a short course of steroids, I put her on conventional DMARDs that included methotrexate, hydroxychloroquine, and for the 3 months, no real improvement. And we went through the routine exercise of changing her oral DMARDs to leflunomide, sulfasalazine. Again, these were ineffective. And once she had failed 3 DMARDs and she was progressing, at the end of 6 to 7 months, we started her on anti-TNF, and Enbrel was started. She responded very well, except for her right knee. And she continued to have flares, and she would come back to clinic every now and then. She already had about 2-3 aspirations within the span of 5-6 months, and we had to do something about it. So you can clearly see the MRI scan, which showed fusion, but also quite thickened synovium, and there is already some erosive changes there. So she had an established inflammatory arthritis and worse in her knee that was not responding to conventional treatment. So at this point in time, what are the treatment options we have? And I'm sure we all come across these cases very routinely in the clinical practice. So if I may just stop and ask my colleagues here, what treatment options you would have chosen without getting biased by the topic of discussion today. Would you change her biologics? I mean, she's on Enbrel, all her joints are fine, except that particular knee. You would send her to your orthopedic colleagues to get an opinion regarding synovectomy and or maybe even a knee replacement. I didn't show her plain X-ray, but she did have quite established osteoarthritic changes in that. And I wasn't convinced that we should change her biologics because from the start of her disease, Enbrel was working really well for her. And because of this one particular knee joint, I didn't want to change the whole treatment for her. And as we would all do, I sent her to see my orthopedic colleagues. She saw 2 of them, and I think that she had a mixed advice. Somebody suggested arthroscopic synovectomy, and somebody said, oh, your knee is pretty bad, and you need a new knee replacement. And this is when, for some reason, I thought, why don't we try our old method of treating monoarthritis? And I'm sure those who were trained in the UK, all of us have gone through this procedure as a part of our training. So I thought, there is possibly a role for this because she was really not keen on going through the surgical intervention. And this was a time when we had a nuclear medicine consultant at City Hospital. I just consulted him and I said, is there any way we can get yttrium in this country? So he said, yeah, we can get it because we're getting other isotopes, so maybe we can get yttrium. So I discussed with her, she was very keen to try this. So we went ahead and actually did it in April 2016. It took us almost 2 months to get her to do this procedure, a lot of logistics issues. I had to go through my own radiation protection course and get a license for administering radiopharmaceutical agent through the DHCC. So it took an insurance approval because insurance companies had never heard of this terminology. And so finally she had it. And 4 weeks later when I saw, there was complete resolution of her knee swelling and pain. Prior to this, whenever she'd had steroid injections, they had lasted only about 2 to 3 weeks. And I thought maybe this is early, but let's give her a little more time. And she continued to see me for further 2 years, absolutely no problem in her knee joint. Of course, she had some mechanical pain, but no recurrence of synovial effusion or inflammation. And 2018, she relocated to Canada. And after that, I didn't see her for follow-up. Now, when I agreed to do this talk, I managed to get her old email and just dropped her a line to see how she's doing. And very surprised to get a response from her yesterday. She apparently failed Enbrel a year later. She went through her own, switches, etc. She's on a JAK inhibitor now. But she did comment that the one joint which never troubled her in the last few years is this right knee. And she said, my left knee is bothering now intermittently, and I'm planning to come to Dubai to get that stuff injected in my knee. So I think it was one of the success stories I can share with everybody. So quickly going to another different aspect of this procedure, 34-year-old male, Indian origin. He came with, yep. Sorry, am I echoing? I can hear you.
No. Was there any head-to-head trials between arthroscopy versus RSO?
Oh, yeah. Yeah.
You will get into this later.
Yes,
Thank you.
later. This is just setting the scene. A quick second case, 4-month history of knee pain and swelling, a background history of PVNS, and he had arthroscopic synovectomy in India, but 2 years later he's developed a recurrence. And he was again advised to repeat synovectomy, and surprisingly one of my orthopedic colleagues thought about this procedure and referred him to me because he'd heard of the possibility of doing this procedure. So we went ahead and did it in 2016, and again, this guy remains in complete resolution of knee pain and swelling. Again, this guy has moved to Australia. I have lost contact, but while he was here for nearly 8 months or 9 months, he didn't have any recurrence. So coming to Dr. Waleed's question, there are some limited case reports and data where surgical synovectomy followed by radiosynovectomy seems to have a better outcome in people who have recurrence, especially in PVNS. Very limited data, but there are case reports and small case series. So I'll come to the data maybe towards the other half. So with that background, we're talking about some very selected clinical scenarios. We're not claiming that this procedure should be considered as a first-line treatment or this is one of the established treatments, but this is something one should just think when you have one of those troublesome patients where everything else is fine, but maybe 1 or 2 troublesome joints are persistently active. Again, just to share success stories, I'm not going to go into the details of this. A seropositive arthritis, multiple DMARD failure, switched to oral JAK inhibitor with excellent response, but persistent synovitis in her right wrist. I almost sent her to see Dr. Lucia, who's here now, and this was around the same time that I started doing more and more of these radiosynovectomies, and I thought I'll try this on her. Till today, she's seeing me for follow-up, absolutely no problem in that wrist, and she's done really well. But I must admit that I was extremely anxious injecting this joint. It's a very superficial joint, and she had multiple joint fusions, so technically it was a difficult procedure. Behçet syndrome, recurrent bilateral knee fusions, and very thick synovium on MRI scan. This guy went to India, got some stem cell treatments and multiple steroid injections, injected in 2019, October, has remained in remission in those joints. And so on and so forth. So what you can see is predominantly patients who have failed multiple biologic treatments or DMARDs where 1 or 2 joints are active. I think one should consider this. However, a lot of data is there in patients with hemophilia and hemophilic hemorrhagic arthritis. They seem to get benefit from this procedure as well. So going into the procedure itself, so we know that some of the radioisotopes have a property to sort of limit inflammation in the tissue where they are injected. And similar concept is used in many cancer therapies, and one of them is radioembolization that is commonly used for hepatocellular carcinomas. So I think based on that concept, people try to use radioisotopes. And the first report goes as far back as 1924, the very first time the radioisotope was injected in an inflamed joint with some good results. And nothing is available in terms of literature until 1954. For nearly 30 years, there seems to be nothing documented. But in Germany, from mid-50s, 1950s, I think this was getting more popularity. And so is in Spain as well. I think there are a number of publications from Spain where radioisotope introduction in the joint has become more popular. The common ones used, without getting into the details, the common radioisotopes we use in synovitis are yttrium, rhenium, and erbium. And the choice of these radioisotopes depends on the joint that you want to inject and the degree of damage that is already there. So for instance, yttrium, as you can see, has a penetration depth of about 11 millimeters. So the deeper joints like knee and hip, you can use yttrium as compared to erbium, which has only 0.3% penetration. Now the risk here is if you inject a deeper joint with a low penetration isotope, then it just sits in the subcutaneous area and causes more of a soft tissue damage and doesn't get into the area of interest. As opposed to that, if you put yttrium in a smaller joint, you have more risk of radiation necrosis. So these are some of the factors taken into consideration. So essentially, this is a well-established non-surgical therapeutic option, as we saw earlier, in various forms of arthritis. And interestingly, more than 40,000 joints are treated per year in Europe, and more so in Austria and Germany and UK. As mentioned, hemophilic arthrosis seems to respond very well to this. Although in the last few years, the indications have widened in rheumatology practice as well. And again, simple, articular introduction of a small amount of radioisotope into medium or large joint is the procedure, and commonly used is yttrium-90. So indications, we covered that, and contraindications, we need to know. It's a radioisotope, so you want to avoid pregnant women, to get this, and women who are breastfeeding. Ruptured Baker cyst, obviously with the risk of isotope getting into the soft tissue in calf muscles, you want to avoid that. Massive hemarthrosis, so hemophiliac patients, you cannot do this when they have an active bleed in the joint. So you want to wait until they stabilize and sometimes give them fresh frozen plasma or stop the bleeding and then inject it. And of course, you want to avoid a joint that is locally infected, or even skin infection at the area of injection should be avoided. How does it work? Very simple. That's a joint which has got rheumatoid arthritis with synovial proliferation. You can see a lot of macrophage infiltration. And now the radioisotope, these yellow amber-colored particles, these are the radiocolloids that are injected, and they enter the synovial tissue and engulfed by the phagocytosis, and these macrophages and the phagocyzed cells cause shrinkage of the synovium, eventually gets replaced by fibrosis and scarring, and that causes the synovium to shrink. So I had this nice video. For some reason, it doesn't seem to work. So introduction of the isotope in the joint, and these are the macrophages that engulf the radioisotope particle and then get eventually frozen. I found this interestingly on a veterinary website. Apparently, it's one of the common method of treating canine arthritis, and in dogs, that's a dog elbow. So it seems to be commonly used in veterinary medicine as well. So I'm not going to go into the details, but it's very important to know that patients have to be primed and educated before the procedure. You want to make sure that they have no contact with pregnant women. So at least for 48 hours, they need to stay alone or away from pregnant women and children. We often administer a low molecular weight heparin, especially for the lower limb procedure, because they need to be immobilized for a couple of days. It's usually associated with a small dose of steroid, one to prevent reactive arthritis, and also steroid works as a flush once you've injected the radioisotope so that there's no leakage or radiation necrosis of the skin around it. Post-procedure, usually the scintigrams are obtained just to ensure that isotope is in the right place, but also medico-legally, you know that you've injected it in the right place. It's always better to inject in a joint that is that has some effusion, because you know that the needle placement is in the accurate place. So follow-up after 4 to 6 weeks, we do usually an ultrasound of the joint to assess if there's any residual synovial effusion. Risks, it actually has very minimal risks if it is done in an appropriate setting. Radiation risk is something that patients always get worried about, but the amount of radiation is very low. Yttrium-90 predominantly emits beta rays, beta emission, which has no radiation hazards. Of course, pregnancy test, as I mentioned earlier, and patients should be counseled about the post-radiation hygiene, etc. And sometimes if they get a reactive synovitis, that is usually treated with anti-inflammatories and it usually settles. Extremely rare risk of radiation necrosis at the skin puncture site. And of course, if they're immobilized, high risk of thromboembolism. That's why we use low molecular weight heparin. So that's the procedure. And again, we use, obviously, the risk is also to the healthcare professional who's doing it, the doctor who's doing it, because one of the dreaded complication is the finger pulp radiation necrosis if you don't use gloves. And that's why never touch the syringe. It always goes with the shield. But even if a couple of drops do leak from while detaching the syringe, you can get pulp radiation necrosis. So use the proper equipment. That's important. So after that, we go through some of the efficacy data. It's very surprising that there's not much data in this. There are no trials. Of course, there's nobody to conduct trials. There's no sponsorship for this particular procedure. So whatever is there is just small case reports, small case series, and there are only about 2 or 3 meta-analyses. So again, no evidence doesn't necessarily mean negative evidence. So I think this is one of the scenarios where there's not much published, but seems to have a good effect. Knee and shoulder seem to have the best effect compared to the smaller joints. And one of these studies looking at effect in more than 2,000 treated joints reports nearly an average response of 73%. The highest response was seen in hemophilic patients, but probably because they are the ones who have had maximum data published. In early rheumatoid arthritis, a response is better compared to an established disease because you need an inflamed tissue to see the effect of the radioisotope. If it's a dry joint with absolutely no cartilage and multiple erosions without synovial inflammation, you're not going to get response as expected. So osteoarthritis tends to have the least response. So again, small joints compared to larger joints have less response. And in this particular study, they found that a wide variation of 40 to 85% response in patients with rheumatoid arthritis, but you look at the details, these were mostly the secondary osteoarthritis patients who didn't really respond very well. I think the main limitation is lack of gold standard for evaluation. So for our biologics, we have methotrexate to compare. Here, there is no comparison. And clearly, the patients who get this procedure are the ones who have failed steroids. So there aren't proper controlled trials to look at the response. The most recent data from within the last decade comes from the study where they looked at, it's a retrospective study of almost 160 patients who were treated with this procedure. Clinical responses, complication rates in wide indications were noted. It was determined at 3 months, and patients who responded well were followed until 36 weeks. So what you could see from the study is those who responded at the end of 3 months had a longer sustained response up to 3 months. So in a way, clinically, it is quite a good indicator. You inject, you see the patient in 3 months. If they've responded, you know that it's going to last for at least 3 years. Those who didn't respond within 3 months' time are likely to not respond. So in a way, you don't really need a biomarker here. You don't really need complicated blood tests or imaging. So your patient has responded at the end of 3 months. You can assure the patient and say, you're going to do well. And that's what I saw in my clinical practice as well. The conclusion of the study is it's safe because less than 1% complication. People responded well. Nearly 85% of response. Which biologic gives you 85 to 90% of response sustained for 3 years? I think it's quite interesting data here. I think in the interest of time, I don't know how we're doing. Yeah, so I'm okay. So this is actually the most recent data. So when the rest of the world was fighting with COVID pandemic, these guys have published this paper in November 2020. So they have looked at 79 joints. This is a Canadian study. In Canada, this is not one of the approved methods of treating patients with inflammatory arthritis. So they have managed to look at a prospective study, a single arm, obviously no comparator arm. Both large and medium-sized joints were injected. They had to fail at least 2 intra-articular injections with steroids. And these patients were followed up at 3 months, 6 months, and 12 months. So last November, they published it. Outcome measures, very simple. At the end of 3, 6, and 12 months, if the patient still had swelling, effusion, and joint function. And they also actually did joint scans to see if there was any residual synovitis. So total of 79 joints were included. Majority of them were knee joints. And you can see the indications: SPA, rheumatoid, JIA, and other such as PVNS and osteoarthritis were included as well. And interestingly, these patients were on non-biological DMARDs as well as biologic DMARDs. So nearly 60% of them were on conventional DMARDs, 30% on biologics. Now, out of all these 79 joints, there were 5 adverse events, but there was only 1 serious adverse event, which was a radiation necrosis. But other 4 were just mild reactive arthritis. So what they see is at the end of 3 months, significant improvement was seen in the joint effusion, pain, as well as function. The p-value of less than 0.001. And this was maintained until 12 months. 92% of patients actually did not show any radiographic progression at the end of 12 months. I think that's quite incredible to see. And joint function also was assessed. In 90% of the joints, the joint function was maintained. So I think that is quite encouraging, knowing the fact that many of us face this scenario in the clinical practice, and quite often there is jumping and switching biologics, sometimes for 1 or 2 joints. So my conclusions from this is it's safe, it's fast, patient-friendly, and can be used for various indications. It's a reasonable treatment option in persistent monoarthritis, despite optimum DMARD therapy. So I think point to think and consider is the fact that patients who are otherwise well on their particular DMARDs, it might allow us to actually step down and reduce their biologic and DMARD treatment. I think the main limitation still remains access is a problem. We need a nuclear medicine department which is well equipped, and you need to have access to yttrium. You need a person who can perform the procedure, and from practice I can tell you it takes a long time. I mean, for one patient, chasing up the insurance payments, etc., is a hassle. And even if I have to do one procedure, it takes me at least 2 hours to prepare, get everything together in the department. So, I mean, yes, of course, it's not time effective, but I think the more we have, I think this is a service that can be established in the region. Maybe one center where they can do it. So I think that brings to the conclusion. Yeah.
Thank you very much. You left us with a good time for, I know, many questions. I have 3 questions already, but I'll ask Professor Mirabacha first to start, okay?
Very nice presentation. Is my mic working?
Yeah.
Anyway, it's so small.
That's better.
Hardly any of us here. So we've been using as an alternative PRP, as you discussed this, and we published case reports of patients with persistent synovitis on whom we've used similar cases with really good response, but not lasting as long. They last about 1 year or so, in 1 to 2 years. And I had discussed a case with you, Bhavna, of a patient. She had failed multiple biologicals. All her joints were fine except her wrist. And we talked about yttrium, and we were sort of worried. It's a super.
Yeah.
So then we finally did inject her with PRP, and we switched her biologic. Of that, we went to an IV Actemra. And we have a couple of hemophiliacs where it's done fantastically with PRP.
Yeah.
Like 1 dose, and that's all it took, and that man is just completely fine 1 year later. He came before the pandemic, and now he came for follow-up. He's done really well. So PRP, I think, is an easy and safe and cheaper option, probably easier to do.
Agreed.
But hats off for these. It's really great case.
No, I think over the last 4 years, I've had about 25 patients. And I think recently Amal has had 1 patient as well. Dr. Carl at Mediclinic City Hospital is doing it routinely now. I think it's important that these age-old, I mean, what I call as old wine in a new bottle, I think we need to re-explore these simple methods. I think post-COVID times are going to be challenging, and how many of our patients can actually sustain, high-cost medication is a question. Certainly, I get very anxious injecting small joints. So, Dr. Lucia, I think you're fine. So, small joints I've never done, but wrists with great reluctance, I've done a couple of them. I think Bina had referred a patient, and they've all done well. But I think that the important thing is if there is enough inflamed tissue, the procedure is simple. Yes, Geeta.
Yes, I just wanted to thank you for this excellent presentation, and thank you for reminding us of one of the therapeutic options that can be sometimes in some, reluctant and refractory monoarthritis, one of the only options that we have, especially those who have failed even PRP and other. Just one remark I wanted to add. When you say those patients have failed steroids, I don't think that even in the studies they specify what kind of steroids. Because in most of the countries, most of the countries where in most of the countries where radiosynoviotasis or synovectomy is kind of a routine and done routinely, most of the time, those patients are offered radiosynovectomy only when they have failed hexacetonide and triamcinolone. And by hexacetonide and triamcinolone, I mean here hexatrione, and not quinacort, not the acetonide, the hexatrione, which is considered as a kind of steroid synoviotasis. Yeah. And it's indeed, in my previous practice at least, those patients who have failed the hexatrione once or twice were actually referred for synoviotasis. This is for inflammatory synovitis. When we talk about PVNS, when we talk about hemophilic hematosis, I think that there's no brainer. The radiosynovectomy remains the best option, but I think that for inflammatory synovitis, there is a place sometimes for hexatrione is not available here. I don't know if if probably in Abu Dhabi.
We had it in the UK though. We had them in the UK.
I actually most of my French patients bring it from France, and I still use it.
Sure.
And I do see a lot of. There was a trial. And with this, there was, I think, a randomized trial comparing hexacetonide, triamcinolone, and atrium actually, 90, and it was a 6-year randomized trial, and it seems that there was no difference.
I know there were a couple of negative studies as well.
So I think that it's very important to be specific about the steroid. If we're talking about dipomedrol, diprostin, and all of these kind of light steroids, then definitely radiosynovectomy is better.
But I think there's a difference here, Geeta, is the fact that when you have a patient with significant thickened synovium, synovial proliferation versus recurrent effusion, that's the difference.
Absolutely. But I mean, what I mean is the hexatrione, actually, this is the difference between hexatrione and the acetonide that we have here. It has an effect on the synovial hypertrophy, and we do see it, and I have patients actually that I follow with ultrasound. You do see the synovial hypertrophy shrinking over time after hexatrione.
That's interesting,
And
that's
those patients, but some of them, sorry.
But that's a good comment. I think we need to look into the details of that.
Still of your talk, but if you want just to comment quickly.
I mean, these are the patients we're talking about who have failed everything. Failed oral steroids, failed intraarticular.
And I don't think hyaluronic acid here is of much help as a steroid. Dr. Jamal.
Thanks, Bhavna. That's very interesting, actually, presentation. But have you ever tried injecting anti-TNF into the joint or methotrexate?
I haven't personally, but I know there are certain case reports, and I think Dr. Walid has had a few patients, and yes, Ahmed as well. I personally haven't done it, simply because I think they're not well established yet for routine clinical use. That's another debate. Okay, next time.
Right, next time,
Amal, I think.
Perhaps, Dr. Amal, and then I'll put my last comment. Okay, Dr. Amal.
Thank you. Can you hear me? Thank you, Bhavna. That's a very, very nice, presentation and about these synovectomies that we used to do. You're right. I mean, those who trained in the UK, they have done this. I've done the yttrium, and I've done the other one is the osmic acid synovectomy, the chemical synovectomy. I'm sure Harun also used to do that, a lot of that. It is done by Dr. Carl in City Hospital together with Dr. Banzin. And in fact, I've sent patients to them. One of them is one of your patients who you have referred to me after, and because she wanted to continue to be followed up in City. And in fact, she was on golimumab. She did very well, except her knee. And 2 years ago, they did the the yttrium synovectomy to the knee. And till date, you are right, till date, she has had no issues with that. If you remember that troublesome knee, and she is doing extremely well on that knee. So in general, yes, it works. It probably is persistent, and I think it's just the logistics of doing the whole procedure.
Yeah.
My question is, previously we were told that if there is damage to the joint, you should not do it. And I don't know whether it still stands true, or in your literature search that has been done in damaged joints.
Yeah. I mean, that's a valid question. There is not so much of a cannot do it. I think it's ineffective. There is a debate about whether it causes any cartilage loss, further cartilage damage, but it hasn't been proven. But in general, if there is no synovial inflammation, and if there is established damage or extensive damage, probably the person is not going to respond very well. I think that's the consensus, yeah.
Yeah, okay, let's finish here, because Dr. Jamal and Amal, they took my point and they say it, so I'm not going to ask you. So I would say thank you. Well, I was about debating this cartilage damage issue, but we'll leave it for later, part of the debate. Thank you very much, Dr. Babna, and I'm going to invite a person I saw for the first time, Dr. Lucia Eras, that's how it should be pronounced. She's from Spain, from Madrid in particular, not Barcelona. She has graduated. She's also adding to our service, she's a surgeon, and she graduated in Madrid and trained there, and then moved to a substantive job in London, a Newham Hospital, and then she specialized in hand surgery and established hand unit, and she has that special interest with the hand surgery. And she has also moved to Dubai 6 years ago, or more than that, and she established the unit here 6 years ago, which is the hand surgery, and I believe many of the rheumatologists seeking for help from her to do some difficult work in terms of hand surgery. She involved in many webinars, publications, workshops, and she is kind of leading us in what to do about the hands of our rheumatoid or other patients. Dr. Eras, the stage is yours. Thank you.
Thank you very much. I don't know if you can listen. I thank you for the invitation. They asked me to talk about the surgery, past and present. I agree with Dr. Bana that this era is the era of the biotechnology, and I believe the future of rheumatoid arthritis and the solution will be the biotechnology. But so far, still you need the surgeon. So the objective of this talk is to give you a brief classification we use, basic in the natural history and the biomechanical progression of the disease, and then we will focus in the treatment of the wrist, MCP, PIP, and thumb. The rheumatoid arthritis affecting the hand is the more disabled part of the body. Patient with knees arthritis can get a more normal life than the one affecting the hand. Epidemiology, we know that it's 6 million of people affected in the world, more typically in women than in men. 5.4 cases in 10,000 women and 2.4 in 10,000 men. The existing data that the prevalence of rheumatoid arthritis in Middle East and Africa is the same compared to the other parts of the world. So before years ago, I was thinking that it was mainly affecting some part of the world, but it's not true, it's all over. For our results in surgery, the main things we always say that the long-term results of the surgery mainly depends on how well responds to the treatment. The medical treatment is very basic. Early referral to the hand surgeon is maintain function in long run. Do we face some problems in Asian countries and in this country also? The amazing family support and play a role in discouraging patients to go for surgery, mainly in more elderly patients. Patients have changed from past to the present time. So we're talking about rheumatoid arthritis related to two parts. It's a combination of systemic symptoms associated with inflammation and articular symptoms associated with the reversible synovitis or the damage done by the synovium tissue in the structure. So we're talking about a medical treatment for the inflammatory process, a mechanical or surgical treatment for the lesions. Lancer give it this 5-stage of development of rheumatoid arthritis in 1977, checking just the radiologic images. So checking the amount of space in the joints, bone deterioration, malalignment, and joint erosion. And they have 5 stages of this classification. But we have noticed also that approximately 8% of patients who develop rheumatoid arthritis have normal X-rays. So the X-rays tend to give a picture later than when the disease started. Even ultrasound scan detect early erosion 7 times more in more patients than the X-rays. MRI scan also shows the changes. The synovial hypertrophy appears in the MRI 4 months after the onset of the disease, so very early. So I think we need to start using more those kind of tests better than fixing just with the X-ray. How is the patient today? The patient today had changed from the patient years ago. The patient years ago was ladies that was not working at home, and not very demanding. Now, again, there's still more women than men, normally younger. They're socially active. They are working, have a family, and have a leisure activity, and they want to maintain these sport activities. They are under therapy, in clinical remission, or no responder, or with intolerance to the treatment. We have all these procedures we can offer to the rheumatoid patients, but in our operative workload of an enhanced surgery, we only have 8% of those surgeries. Very rare we have to do it because of all the problem with referral, and the operation is mainly arthroplasties, tendon surgery, or implants. The deformity is never isolated. Are results of mechanical unbalance acting in a diseased joint. Start normally in the wrist with the dorsal subluxation of the ulnar head and appears a dislocation of the extensor carpus ulnaris volarly. The carpal goes ulnar-wise, dislocate ulnar-wise, and as a compensation, the carpometacarpal joint deviate radial-wise. Then there appear a carpal supination and a clearly volar carpal subluxation. Then all this soft tissue damage, ligament destruction. You can see in the big gap between the scaphoid and the lunate, and you can see in the patient the gap with no rest of the ligaments. And also the tendon rupture. Tendon rupture because we talking about this dorsal dislocation of the ulnar head, and if it's not treated adequately, rupture the tendons, and most of the time rupture more than one tendon, making the operation even more complicated. And then a progression with articular destruction, bone cyst, and the completely erosion of the whole joint. So we are talking about 3 types of natural history. The monocyclic patient that have one episode, then that lasts or ending 2 to 5 years later after the initial diagnosis, and can be because the diagnosis was made early or because the aggressive treatment done at the beginning. Hold on a minute, went backwards. Or both together. Then we have the monocyclic, is the patient, the remittent is the patient, then the disease has fluctuation during the course of the condition, and the progressive is the rheumatoid patient that increases severity and not responding to any treatment. We classify as a matter of algorithm for the treatment as a biomechanical prognosis. Type 1 is ankylosis, mainly juvenile type. Type 2 is osteoarthrosis, and the type 3 is osteolysis, which is ligament destruction and soft tissue destruction. So we talking about stable forms and unstable form. The stable form are the type 1 and 2, and the unstable form is the type 3. And in this type is when we can see all these radiocarpal severe dislocations. So this is important. Why is important? To prevent cases like this. This is a 36 years old with very aggressive and progressive disease. Then somebody did a carpal procedure, which you stabilize the distal radio-ulnar joint, but the whole carpal dislocated ulnarly because there was no stability between the radius and the carpal. Those operations should have been done in these cases. So we've seen that the way they're affecting is the radial carpal, distal radio-ulnar, MCP, thumb, and then the production of this typical zeta deformity of the hand. What we used to do, we used to do open synovectomies years ago for those wrists. Those days we don't do this open synovectomy. Those open synovectomy now is just a step during a more complex procedure for reconstructive surgery of the wrist. It's contraindicated in patients who has a rapid progression or joint destruction. If this is obvious, then it's not indicated as synovectomy. Those days, we go more for arthroscopy on the rheumatoid arthritis. It shows that it produces long-term good results, pain control with synovitis that not responding to treatment in 75% of cases, and with less intervention. For the MCP joint, we're still doing open synovectomy. It's indicated when the joint is still intact, when there's no destructive arthritis and no instability. Carpal ulnar resection, that has to be prior to any rupture of tendons. As soon as we've seen this ulnar head dorsal dislocation and start producing some crepitus on the movement of the patient before the tendons are ruptured, it's better to remove the ulnar head because normally the rupture, as I said, involves more than one tendon. That's the repair. We shouldn't forget also the flexor tendons. We have a critical corner in the distal pole of the scaphoid, which produce a lot of arthritis, and this spike of arthritis very often produce a rupture of the flexor pollicis longus tendon. What we're doing with the joint is completely destroyed. Swanson in 1960 started doing elastic or silicone joint implants, started in the metacarpophalangeal joint, and in 1973 developed the one on the wrist. But it's been a lot of controversy. The duration and longevity of this prosthesis is not very long. We've seen progression in the X-rays of deterioration due to the synovitis produced by this silicone. There's a lot of papers about this erosive synovitis produced by the silicone in the wrist. So those days, we don't do this implant anymore, and we're doing those kind of surgeries. So the main aim of all the hand surgery is to maintain function as much as possible. So if we think that the patient has only involved the radiocarpal joint, we offer this kind of procedure. This is the radioscapholunate fusion. So we mobilize the patient from the mid-carpal joint. The patient still keeps some movement, and they can do a lot of more activities. This is a patient before the operation. That was 4 months after surgery with the radioscapholunate arthrodesis. And this is very good treatment for this case we saw before. This ulnar carpal translocation, which dislocates from the carpal, you can fuse it to the radius and then make a good alignment in the wrist, which are functional and strong wrists for the patient. What happens when we have also involvement of the mid-carpal joint? In that case, when both joints are involved, there's no chances we can get some movement, and the only way to get movement is with these implants. This prosthesis is the universal type 2, which is the more often done those days, which are very good results. It gives you a good range of motion of 20 degrees previous to the surgery to 91 after surgery, and even they can hold 13 kilograms of weight. Patients normally are happy with the results of this implant. But again, ongoing disease. If the process is not stopping, patient not responding to the medication, the implant will fail. The implant will dislocate, and that will be a big problem for the patient. Cases like this one, a mutilated destructive osteolysis with a gross destruction, you can see in the severe radiocarpal dislocation, you cannot offer a joint replacement. That is out of question. Those are unstable by definition, and they will do very badly because the no ligaments support those joints. What we do in that case, then we do the wing operation, which is an arthrodesis. The arthrodesis gives you a good, strong wrist, and then they can start functioning with the hand easily. Then we go to the MCP joint. We are still doing synovectomies. When the patient and the severity of the damage of the joint still preserve articular surface, we try to do a synovectomy. At that time, you can repair the radial collateral ligament and relocate the extensor tendon, which always are dislocated ulnarly, and this is the cause of this ulnar drift. If the joint are damaged, then we go for the elastic implant. Different than the rest, the elastic implant in the MCP and PIP joint, there's no recollection of synovitis or reactive synovitis producing erosion of the joint. So that's why we still continue doing this. This is a 59-year-old woman affecting all the fingers, and this is a month after the MCP was changed with elastic implants. This is another lady that came first of all with the rheumatoid arthritis affecting both hands. She has a previous operation in the right index finger where they put this metal implant and produced a severe metallosis and synovitis reactive in the joint. So that's why the approach to the hands was different, and I had to change it both for elastic implant. We see in those days also Larsen type 3. The Larsen type 3 is a halfway of the disease. The normally younger ladies, this is a 38 years woman with bilateral hand involvement, mainly the MCP joint, and gradually loss of hand function. The alignment of the wrist was pretty good, very minimal deviation with a minimal metacarpal drift, and only subluxation affecting the second and the third metacarpal phalangeal joint. We can see in early stages of swan neck deformities affecting the fingers, those ones, and started the subluxation dorsally of the ulnar head. This was due to the synovitis rupture the TFCC. This was her hand. You can see in the synovitis affecting mainly the second and the third with some intrinsic contraction, tendon imbalance, and subluxation, and she has a very unstable first metacarpal phalangeal joint. She couldn't extend completely the hand. She was unable to open the hand completely, and it has no synovitis or very minimal affecting the wrist, and this swan neck deformity is already established, and the boutonniere deformity, unstable thumb. So in this case, we can do half-half. So you can replace the second and the third metacarpal for joint replacement and do only synovectomies of the other joint. We're trying to preserve the joint for as long as possible. At that time, you can do the ulnar intrinsic release and repair the radial collateral ligament and relocate the extensor tendon. For the thumb, in that case, we did just an arthrodesis of the first metacarpal phalangeal joint. Celastic, this is one of the papers we collect a lot of big number of celastic cases and follow for 14 years. It was 208 celastic cases in 53 hands. You can see in the range of motion. We're not expecting a great amount of range of motions with celastic. So previous to the operation was 30, after the operation was 46. These are the different types, the old one and the new one. Even with the new one, the range of motion has improved, but very minimal. Ending with a little bit of extension gap of 11 degrees and some ulnar desviation, ulnar drift of about 5 degrees. You can see in the appears bone erosion in 29% of cases after 14 years, but you can see that 63% of cases were broken. The satisfaction is low, 38, but it's still the gold standard for rheumatoid arthritis. This is my experience, similar with a extension gap of 5 to 10 degrees and a bit ulnar drift. And again, that's the change. Years ago, that is the kind of splintage we put to the patient. Patients were coping very badly with those splints, with all this metal and all this cord attachment to the finger. Difficult to get dressed, difficult and not happy to go outside for social activities, and patients stopped using it. Those days we use something like this. More comfortable, patient can do the normal activity, even go back to work with no reduction of movement or problems with cosmetic. Right. As you remember, we discussed different types. This is for type 1 and 2. This is for stable joints. When you have a stable joint, then you're doing this kind of joint replacement. This came to the market many years ago. It's a metal and a plastic device. And you can see the big difference in range of motion. 27 previous to a surgery, 60 degrees after the surgery. The arc of motion improved a lot. Disability reduced, 70% disabled the patient to only 9%. So improve a lot, but those kind of prosthesis you cannot do in an unstable, progressive rheumatoid arthritis because it will fail, it will dislocate always. This is one of the things work against us. Books. The books are talking about how you gardening with fingers, with arthritic fingers, and patients are happy with this, and how to cook with arthritic finger, and then they don't go for the surgery or don't agree for surgery, and which is a big problem. Then we go for the PIP, which is also a big problem. What we used to do, arthrodesis, we used to fuse them. And fuse the PIP, reduce the function of the hand by 50%. How we fuse it? We start with the index finger in 20 degrees, and we increase the degrees of flexion up to the little finger, which is flexed at 40 degrees, to help it with the grip. We have problems with that, with 10% of non-union. Most of the patients present cold intolerance. Some of them present skin necrosis and prominent metal work. And those days is only indicated as a salvage procedure. What we can do before the PIP become affected is synovectomy. We can just open the joint and remove all the synovial tissue. We're helping with the mobility, but also will prevent the rupture of the central slip of the extensor tendon. Because if the central slip of the extensor tendon rupture, this produces a severe boutonniere deformity. This is a catastrophic result. Why? It can be operated, but it's long process of rehabilitation. We're talking about a year and a half or 2 years. Patients fed up, they don't follow the physiotherapy, and then the situation goes back. So we're trying to prevent this boutonniere deformity to occur. When the joint is damaged completely, for the arthritis, then joint replacement is elastic in the PRP, doing very well. This is a case of an arthrodesis of the PIP joint. Patient was doing very badly, was arthrodesis when he was younger, and he converted to a joint replacement with elastic implant. Then again, we have new joints. New joints, this pyrocarbon came to the market in 1960. As a collaboration of the French Commission of Atomic Energy and the General Atomic, just to fuel or coat the nuclear fuel. In 1970, it was first used as a heart valve, and in 1990, it started using it as a carpal implant. We have a lot of carpal implants made by this pyrocarbon. Why? Because this material has the nearest joint module to bone. And this means that doesn't produce reaction to the bone close to this. So this cyst we've seen and bone reaction we've seen with the metal, you cannot see it with the pyrocarbon. And again, this is for stable cases. This is a guy with both ring fingers affected. One was a year and the other was 2 months after the surgery. Those stable when you can, you have the collateral ligament or you can replace, and you have the central slip of the extensor tendon, those doing very well. They recover full flexion and they're very happy. They can have maximum 75 to 85 of arc of motion, pain relief in 70 to 90% of cases. Important, again, collateral ligaments. So aggressive, erosive rheumatoid arthritis will do very badly with those kind of implant. We noticed that a patient who has swan neck deformity previous to the operation, they tends to have a residual hyperextension and some deficit in flexion. But apart of that, the results are very good of this implant. Again, type 1 and 2, stable joints. We go into the other, swan neck deformities. Swan neck deformity is the hyperextension of the PIP joint with the flexion of the DIP joint. And it happens for, again, synovitis, but this time affecting the flexor tendons. So the flexor tendons becomes inflamed with the tenosynovitis and then damage the volar plate gradually, and the whole thing goes in hyperextension. Then also sometimes associated intrinsic contraction. The first line of treatment for this one neck deformity is that kind of a splint. It's splint and physiotherapy. Most of the patient, we can control the hyperextension and with the physio, even blocking and get to neutral extension without the deficit. Intervention is only indicating when the hyperextension is fixed, when the patient cannot actively flex the finger. In that case, then we need to do the surgery. There's two surgeries we're doing. One is the modification of the little reconstruction of lamella retinacular ligament with palmaris tendon graft, or a sling of the superficialis to block in flexion the PIP joint. And then we go into the thumb as a last. The thumb can have the same similar damage than the other fingers, boutonniere, swan neck deformity. They have also a gamekeeper thumb, which is the damage of the ulnar collateral ligament due to the synovitis and produce the rupture of the ligament, or we can see sometimes a contraction of the first web space. This is a very good surgery. The extensor pollicis is along with rerouting. We're doing for a boutonniere deformity. The boutonniere deformity in the thumb is completely different than in the finger because there's only two joints. It's much easier to control the pulling of the tendons and restore the function of the thumb. So we're doing with this, we take part of the tendon, pass from the part of the fascia, and restructure back so the thumb has a nice extension position. This is only indicated when we can reduce the deformity. If it's impossible to reduce passively the deformity, then this surgery is not indicated. So when the damage is, the joint is more severe, the winning operation is the same than the other, arthrodesis. Why? Because the thumb is very important for the pinching. All the movements of the four fingers opposite to the thumb are very important for most of our daily activities, and we need a strong thumb to be able to do those kind of activities. On conclusion, we have two types of procedures we can do and help the rheumatoid arthritis. One, prophylactic, which are mainly synovectomy and tenosynovectomies. We normally recommend to do it after 3 to 6 months of persisting synovitis, which is not responding to the treatment. Second thing is the ulnar neck, the ulnar head scission. We not expecting to go and rupture the tendons. As soon as the ulnar head is obviously dislocated dorsally and start producing this crepitus, then it has to be resected. And then the therapeutic treatment is arthrodesis. We arthrodese the thumb, as you're saying, the MCP joint, the distal interphalangeal joint, there's nothing else except arthrodesis. The wrist or limited or total depends on the mid-carpal joint. Then arthroplasties, tendon transfer procedure when the tendons are ruptured, more than one, and the reconstruction surgery for the swan neck deformity when there's a fixed deformity. In conclusion, is a hand surgery, a hand approach to the rheumatoid. It has to be combine medical and surgical. The idea will be to have a team with medical surgeons and physiotherapy together to work on rehabilitate those hands. They are very difficult, they're long-standing, and they are very disabled for the patients. And it's very important when choosing doctors which procedure to go for. Remember the biomechanical imbalance of the joint that can produce the operation that you choose to fail. Okay, that references. Thank you very much. Questions?
Excellent. Thank you very much. A very
welcome.
insightful talk and a lot of learning. And we have the first question coming from Dr. Walid. We are waiting for a microphone. Yes.
Yeah, thank you very much for an excellent talk. I really enjoyed it. In regards to deviations, ulnar deviations, like the little finger, is it tendon or is it pulley involvement, and what pulleys are involved? Number one, number two, A, B. Thank you.
Yeah, the normally not the pulleys. The normal is the dislocation ulnarly of the extensor tendon. The extensor tendon have a little tendon connecting the tendons together and make the tendons run in the middle of the MCP joint. When those little tendons rupture because of the synovitis, the tendon gradually go to ulnar deviation. The pulleys are intact. Or they have, or at least they have some tenosynovitis. Even if you have tenosynovitis affecting the flexor tendon, most of the pulleys are intact. It's mainly the dislocation gradually of the extensor tendon combined later with the rupture of the radial collateral ligament. Most of them, when you open, the radial collateral is completely gone.
All right. Other question for stage? I might ask you a general question. You take a lot of consideration which operation you do for particular patient with deformity or the synovectomy. That's for straightforward rheumatoid arthritis. But we have a situation when there is comorbidities, like people with Raynaud's, psoriasis, or even thick skin like in scleroderma. How you face these situations and what do you do about them? They are difficult patients for us and maybe also difficult patients for you.
You're talking about medical?
Yeah, I mean someone with Raynaud's and still have one of these ongoing problems. Do you go the same way or you have special consideration?
You need to check the patient, first of all, to see if the joint are stable or not stable, and then you know what to offer. And secondly, to see if the joint are preserved. If the joint are preserved, we tend to preserve the joint as long as possible. So if it's only just the synovitis, which has damaged all the soft tissue around, then you can do the synovectomy and repair all the soft tissue back to normal. If it's just the joint involved, then you have to do more serious surgery. But we do those cases as block anesthesia. Even patients with a lot of medical problem go home the same day with block anesthesia. You don't need to go for general. There's no that problematic for patient who has a lot of medical problem.
Right. Any other question, Dr. Amal?
Thank you very much. Can you hear me? My question is about osteoarthritis, actually, and Heberden nodes. Usually patients come to us with the distal interpharyngeal Heberden nodes and asking, it's quite deforming, and they want something to be done about it. I mean, is there a role for surgery in the Heberden nodes?
For osteoarthritis, yeah, it depends again of the series of the disease. I'm doing a lot of technology now. I'm doing PRP injection a lot. If the damage is very small, then PRP is doing really, really well. Even sometimes with tendon TFCC rupture partially, it responds fantastically well. But if the damage is very severe, before it progresses and damage more joints, then we tend to do some surgery. Because the idea is to keep the function as much as possible for as long as possible. If we wait until all the joints are involved in the wrist, then forget it. It's gone for arthrodesis. So we're trying to stop him before progressing.
If there are no, we are okay within time, but if there are no other questions, I would like to say thank you, Dr. Riaz, for this very good lecture. And thank you again. Okay. I'm going to pass the moderation stage to my friend and colleague, Professor Ahmed Abu Jamal, to supervise what's going to be a very heated debate. Moderate, yeah, but moderate. It's going to be very heated debate, and he is going to be difficult judge between two opinions, two different opinions, and God knows how it's going to end. And he is my friend, consultant in the Saudi General Hospital, and he is well known to everyone in UAE and outside UAE. Prof. Ahmed, please.
Welcome all of us ready for the great debate session. Actually, I'm very proud to present the next session about a great debate regarding the two common prescribed and the most important prescribed medications for inflammatory arthritis and rheumatoid arthritis, the JAK inhibitors and anti-NFs, between two big speakers and two, actually glad to have these two friends, Dr. Humaira Bacha and Dr. Walid Shahi. So we'll start with Dr. Humaira Bacha. Dr. Humaira Bacha is well-known rheumatology consultant. He's a consultant rheumatologist and the medical director of the Humaira Bacha Medical Center, Dubai, and also a consultant rheumatologist at Emirates Hospital. She's well-known and trained in University of California, Los Angeles, and she's holding the American Board Certified Member of Internal Medicine. She's very certified in musculoskeletal ultrasound by the American College of Rheumatology. She has over 2 decades of experience in rheumatology as a rheumatologist across 3 countries in US, Singapore, and UAE. So without further delay, Dr. Humaira, the floor is yours. Good luck.
Thank you, Dr. Ahmed. And so we have the great debate. It's the JAK inhibitors versus the anti-TNF. With my good friend, Dr. Walid. So there I am, the JAK, Miss JAK, and that's Dr. Walid. And he's already pointing out as to who is the winner, I think, there to the debate. Yeah. So we all know that Dr. Walid is a big Real Madrid fan. And so we can consider this a Real Madrid versus Barcelona debate today. Okay? And we know how that will go towards the end. So I'm going to just focus. It's going to be quick, so don't worry. I'm going to focus on these areas: efficacy, safety, the preference of patients for monotherapy, the preference of patients for oral drugs, the efficacy in overlap syndromes, and cost, which I know Dr. Walid will be focusing on as well. So for us, what are our key goals to manage patients? Is we want to achieve low disease activity, we want to achieve remission, we want to achieve these days Boolean remission, we want the most effective drugs possible. So from our database with Dr. Harifi, Dr. Bhavna Khan, we have collected data to show us how we are doing in our local practice. We collected data on 573 patients. These patients were mostly South Asian, reflecting the demographics of the UAE. And using the DAS28 scores, 35% of the patients were in remission and 15% were in low disease activity. So roughly over 50% of our patients are doing well. I know people will also talk about CDI because ESR and CRP sometimes are not so reflective. Using CDI scores, even lesser, fewer patients were in remission, only 18%, and 41% were in low disease activity. So we're talking about roughly a little bit over half of our patients are doing well, which is not great. So male gender, Caucasian patients who are working full-time, which was associated with having health insurance, were in remission or low disease activity. Patients who got either biological JAK inhibitor and methotrexate in combination with biologicals seemed to be in low disease activity. Patients who had a longer lag time to diagnosis, higher body mass index, and high blood pressure were unfortunately in moderate disease activity or high disease activity. So let us focus on efficacy. First of all, we don't need to guess. We have head-to-head studies. So it's easy to just go through the head-to-head studies. We're going to talk first about baricitinib. And in the baricitinib BEAM study, as you're all aware, we have a head-to-head look at bari 4 milligrams with methotrexate versus adalimumab with methotrexate. 1,305 patients. We see here the ACR 20 responses are superior in Barry, and over time, the red is the Barry group, the blue is the dark blue is the adalimumab group. You see over time sustained response and efficacy with improved DAS28 CRP in the Barry group as compared to adalimumab. Now, a lot of people will argue that JAK inhibitors, they exert some of the influence through IL-6 pathways, and hence CRP is down, and hence the DAS28 CRP is low compared. But we are seeing these responses across the board in all parameters, this efficacy, not just in DAS28 CRP. We see here ACR 50, ACR 70. Again, you can see the response rate. This is the Barry group. Sorry, why does that do that funny thing? Okay. Okay. I think I'll just use the normal. Okay. So we see here the ACR 20 responses. The red is the Barry. ACR 50, ACR 70 responses in the RA Beam study is superior. And also we're seeing here, people may argue that the 4 milligram of Barry dose is not good or not safe. We do see that you have quite similar responses between the Barry 2 and the 4 milligrams in the RA Build and the RA Beacon. So we can extrapolate to saying that these doses are also effective, whichever dose you're using, whether it be the 2 or the 4 milligrams. So when you're coming to maintaining low disease activity, whether it is by CDAI or DAS28 CRP. So again, when you're using the argument that it's because the CRP is artifactually decreased, we also have CDAI data that DAS20 low disease activity and remission is much higher on patients treated with baricitinib as compared to adalimumab. And you see here that even the CDAI low disease activity is 40% in the Barry group as compared to 33%. So when our goals, these are our goals, this is what we want to be using. Structural damage, that's important to us. It's quite similar between two groups. These were not powered enough to look at structural damage. But pain and disability, this is so important to our patients that we control pain, and this is becoming more and more apparent that even patients in low disease activity seem to have continued pain, and we see this as a problem in our clinic, but Barry patients do better in pain and physical function as well. And also working significantly faster. Median time to improvement 50% or 70% pain improvement is much faster with Barry as compared with adalimumab or placebo. So it works well, it works fast, it works significantly across all of the parameters which are being tested. Now, let's talk about UPA also, because again here we have head-to-head. I'm restricting myself to head-to-head. So here we have select compare study where where adalimumab was compared to UPA, and can UPA improve outcomes versus adalimumab? So this was the sort of way that this study went, where patients on 15 milligrams of UPA were then randomized either to continue UPA or the adalimumab. Rescue was their arm, had a rescue arm as well, where they could be changed over to UPA. So besides the ACR 20, the other areas which were looked at were ACR 50, DAS28 scores, and also other patient assessments and PROs. So here we see that UPA versus adalimumab. Here UPA is the green one and adalimumab is the purple one. So here actually quite significant differences. ACR 50 responses in UPA patients is 45% versus 29% in the ADA patients. And again, pain was also significantly better as well as functional outcomes. And we similarly see this in a long term. It's the maintenance of these effects continues up to week 48. ACR 70 response similar is much, much better. At week 48, you see 36% have ACR 70 responses versus 23%. And then you're looking here at the changes in DAS28. Again, very fast responses in the UPA, the green line here, a less fast response of the adalimumab, and these responses are sustained over time in long-term extension studies. So comparison of remission at week 28, again you see superiority of UPA, and I want you to pay attention at week 48, Boolean remission.
We're seeing Boolean remission in 20% of UPA patients versus 14 patients of adalimumab patients. So inhibition of radiographic progression was quite similar in both groups. They could not really show these improvements, and also minimal disease activity in HAC as far as HAC. Let's come to safety. Lots has been said about safety, and this is Waleed's, his points of safety. So we have a lot of long-term safety trials, many patient years of the any phase 3. We had more than 4,565 patient years for UPA 15 milligram dose. UPA 30 milligram, which we don't use, has also been included here, and we have also used adalimumab here. So you're going to look at total patient exposure years, methotrexate, ADA, UPA 15 mg, and UPA 30 mg. And all of these patients had risk factors at baseline for cardiovascular events, diabetes, similar risk factors, smoking, and other issues. So most of the side effects seen in the UPA trials were non-serious upper respiratory infections, nasopharyngitis, herpes zoster. There's a consistent 3% herpes zoster rate, and that's what we're seeing with the JAKs. So let's talk about serious adverse events. The numerically, UPA 30 mg had more serious adverse events compared to UPA 15 or ADA 40 or methotrexate monotherapy, but this was not statistically significant. But UPA 15 mg did not have more serious adverse events. Let's talk about adverse events leading to discontinuation. Again, UPA 15 mg was similar to methotrexate monotherapy or adalimumab plus methotrexate. Let's talk about deaths. Again, no differences in the groups. Serious infections, no difference in the groups. Serious infections were numerically higher in 30 mg patients, but similar with the 15 mg adalimumab and methotrexate monotherapy. Let's talk about herpes zoster. Yes, herpes zoster was higher among patients who received 30 mg of UPA compared with 15 mg, but both doses had a higher rate of herpes zoster as compared to adalimumab. But let's talk about this difference. It's about 3% versus 1.5% in the adalimumab. The majority of the herpes zoster cases seen in the UPA group were non-serious. 95% of them were non-serious and restricted to a single dermatome, and most of them had full resolution. All of these herpes zoster, most of them occurred in the Japanese and Asian patients, which is again seeming that they seem to have some increased predisposition to herpes zoster. In our own personal clinical practices, I'm not sure that we're seeing that JAK inhibitors, we've seen more herpes zoster as compared with steroid-treated patients or Humira patients. Long-term safety indication as far as TB, there's again no signal of higher TB incidence between the UPA 15 mg, 40 mg, or even the UPA 30 mg did not have any other serious things. This is very important, is the major adverse cardiovascular events. There was no difference despite so many patient years of exposure. There was no difference between the UPA 15 mg, 30 mg, adalimumab or methotrexate groups. As well as very important here, similar rates of venous thromboembolic events were seen. And finally, 30 mg seems to have a numerically lower incidence of VTEs, but there was no difference between the 15 mg and adalimumab over time. So risk of malignancy, similarly, we did not see any difference. I'm going through this in detail because, we seem to think that apart from herpes zoster, we haven't shown a higher rate of any adverse events with the JAK so far. So non-melanoma skin cancer, again, there wasn't an increased signal here. And there were some signals as far as increased LFTs, but again, it was much more in the methotrexate monotherapy patients as compared to UPA 30-50 or 30-15 or adalimumab. Elevated CPK was seen in the 30 mg group and numerically higher in both groups, again, not statistically significant. Similarly, with baricitinib also, we have long-term data. This is the long-term data, which is up to 8.4 years, looking at long-term data. There was no increase signal for DVT, PE, or major adverse cardiovascular events. Herpes zoster was increased, again, at the 3% rate, which we are talking about. So when we look at real-world effectiveness of baricitinib in the Swiss Rheumatoid Arthritis Register, We look at here, this is baricitinib is the red line, and the non-Bari drugs, TNF and other biological DMARDs. Baricitinib tends to survive. There's a better survival over the drug over time. These are over more than 1.5 years here. And if you look at baricitinib versus TNF, again, better drug survival, both for reasons of efficacy and safety. Okay, let's talk about monotherapy. So the SELECT monotherapy study, we have here that UPA monotherapy compared to continuous methotrexate. We have UPA 15, 30 mg and methotrexate doses. The methotrexate doses were over 15 mg on average. And you see here, we have similar baseline characteristics of the patients. And these were the patients who were switched to methotrexate, switched from methotrexate to UPA 30 mg, that's the blue, or to UPA 15 mg, which is the green, or they started from the beginning with UPA 15 or 30. And the ACR 20 responses, and you have excellent ACR 50 responses even when they are on monotherapy. So the patients who were switched did not seem to have any major differences between patients who started from the beginning. ACR 70 responses were equally excellent, and this was sustained over time at week 84. So we have a lot of evidence for monotherapy. This is really something which we have not seen with the TNFs, with such excellent responses for monotherapy. You look at DAS28 remission. This is really something remarkable. At week 84, 46% of patients, let's not take the UPA 30 mg dose where you see 60% in DAS28 remission. Let's look at the UPA 15 mg, which is what we're using. 46% of patients are in DAS28 remission at week 84. What about CDI remission? If you want to counter me by saying that it's because of this effect on the CRP, CDI remission too. So at week 84, for 25% of patients to be in CDI remission, that's quite remarkable compared to real-world data and what we're seeing. And low disease activity is seen in about 60% of our patients overall, which is again quite remarkable. So monotherapy, and this is Boolean remission. Again, a lot of patients can achieve Boolean remission. 20% of patients achieve Boolean remissions, and this is sustained over time. So again, here we can see that upadacitinib has consistent low rates of disease activity, whether it had methotrexate added or not. You had low rates of, so sorry, let me just go over this. This is patients in combination with methotrexate and patients in monotherapy, and the CDI remission, low disease activity did not change whether you added methotrexate to these patients or not in these trials. Okay, so again, when we looked at the same real world data, one of the reasons for discontinuation here were patients who needed to take methotrexate. Many of the patients discontinued methotrexate over time, and this is something which we're seeing in real world as well. Also, we've gone through this. Everyone has seen this slide before. Patients' route of administration is very, very important to them. Patients prefer oral administration. IV is the least preferred, and self-injection is also not preferred as much. So patients, this is where they prefer a pill. IV is disliked. Again, frequency is something which does count. These are daily pills, but all of them are a single pill, so that's useful. And not requiring combination therapy. Most of them do not want to take methotrexate. Very strong preference not to take methotrexate. So we have a drug here which is efficacious, it can work by itself, it fulfills the patient's preference, and it's as safe as the other drugs. What about overlap syndromes? I don't want to take too much time. We have this lady who was a Lebanese lady and just all she had was synovitis in both knees, and she did not have any other issues. She started off with anti-TNFs. I'm going to just go through her case quickly. She's the one who had breast implants. She removed her breast implants. She improved for some time and then developed a full-blown polyarthritis. She was negative for HLA-B27, did not have sacroiliitis. She was more like a seronegative RA, but had some sort of enthesial features as well, no psoriasis. And she started on Xeljanz, but did really well on Rinvoq and had very rapid resolution of arthritis. And her DAS28 is 2.2. She's still doing well. She's moved to Australia. Also, lots of you would know this lady, this Korean patient of mine whom I've been seeing for 15 years now. She started off as a polymyositis treated with methotrexate in the United States. Then she developed a CCP positive rheumatoid arthritis. Then she developed sicca, leukopenia, enlarged lymph nodes, a very high ROLA, Sjogren's overlap. She's treated with various drugs, including rituximab, Actemra, abatacept. She has a really bad inflammatory arthritis. And finally, she has done really well on Rinvoq, 15 milligrams daily. So we know we have seen some studies of the efficacy of Barry in lupus as well. So it's very useful for our overlap syndromes or where the diagnosis is not so clear. So Dr. Waleed standing up there, he's going to be here saying cost and use biosimilars. But we are seeing the cost of the JAK inhibitors coming down. We do have the generic versions, as we've seen recently in India. And I think I've said everything on what all these different categories, on the preference for JAK versus anti-TNF. And this is my final slide, Waleed. So Waleed has now shifted over to Barcelona, and I think he agrees with me already. I have some rebuttal slides, but we'll go through after.
Humaira?
Well done, well done.
Let's move to the second talk by Dr. Waleed Shahi. Dr. Waleed is the head of rheumatology department at Saudi Al Sulaiman Al Habib Hospital, Dubai Healthcare City, Secretary General of ARLAR, founding member and former president of the Emirates Rheumatology Society from 2008, 2010, 2016, 2008. Dr. Shahi has obtained a medical school degree and rheumatology subspecialty.
Let's skip that, okay.
Okay.
We will stay friends after this, Humaira. So, yeah, so, I mean, this slide, I mean, says it all. Okay, so, my middle name is anti-TNF. So, think about this, guys. You have something with 23 years experience. You know the good and bad about this drug, but you don't know the full story about a new tablet that could replace methotrexate. Okay, so my talk is not really scientific like Humaira, no. I'm not taking the scientific road here. So maybe the first two slides, we need to understand that TNF-alpha has both immunostimulatory and immunosuppressive functions. So it activates certain pathways. It's important in shock and also in cytokine induction. And as an immunosuppressive, it inhibits T cells, promotes apoptosis, lymphopenia, but in disease. So a lot of cells are involved. Target cells include endothelial cells, macrophage cells, effector T cells, fibroblasts, osteoclasts, and chondrocytes. And thusly, increasing adhesion molecules, VEGF, cytokines, chemokines, MMP synthesis, and osteoclast activation. So that leads to more cell proliferation, neovascularization, inflammation that can lead to joint damage, bone resorption, and even psoriasis. You know that there are 5 in the market, and they are different in structure. They are not identical. And that plays an impact on biological activity and pharmacokinetics. So there are multiple indications, and it is worldwide. So almost every country in the world has TNF inhibitors. But how many countries have JAK inhibitors? Well, I mean, maybe 50 or 60? Okay, so what specialties do you use them? Dermatologists use them. Gastroenterologists do. ophthalmologists do, pediatric rheumatologists do, even there are some obstetrics gynecology data that it can be used prior to induction of pregnancy and others. So what are the multiple indications? Rheumatoid arthritis, psoriasis, psoriatic arthritis, AS, both radiographic and non-radiographic, uveitis, Crohn's disease, ulcerative colitis, JIA, HS, sarcoidosis, and off-label indications. How did the anti-TNFs impact our practice? We had more connect meetings with other colleagues across the board that have felt more ease in the use of anti-TNFs in their patients. We had more power. Anti-TNFs come in sub-Q and IV, 2 formulations. So we can offer the patient subcut injections or IV, and we can go back and forth. We had more rooms in the office because of the infusion rooms. Thus more power, thus more follow-ups. We felt empowered. We can control our patients' disease even when they are family planning. We had a huge rise in head-to-head comparing apples to apples, not apples to peanuts. So it taught us a lot about basic science. We weren't basic science people, well, I mean, in the late 90s, and the cytokines involved. So we became better immunologists. Maybe remove the whole mic from the... So we became Einsteins of medicine. We knew everything. So that's what anti-TNFs made rheumatologists become. What else? We have a lot of experience on using anti-TNFs during pregnancy. We have an answer for our patients that no other DMARD has with impressive control. We continue them even while breastfeeding. Now, we can't do that with other agents. Now, let me scare you. Are you prepared to be scared? Okay. So, this is the other side, the JAK inhibitors. Less than 10 years clinical experience. Now, do you trust somebody with less than 10 years clinical experience? Do you trust this guy? No. Do you trust the previous guy? Yes. So, this was presented during the ACR convergence. JAK inhibitors are recommended in third-line therapy, not after failure of methotrexate. This is the ACR, not me, and you can look it up. Failure of conventional DMARD in first-line therapy in certain patients, but it is used in a failure of combination of both conventional synthetic DMARDs or an anti-TNF. So it is used in established rheumatoids, not in early rheumatoids. You can use TNFs in early rheumatoids, but you can't use them in established rheumatoids. So now, let me even scare you even more. How about adverse events? Adverse events in balance 1 and 2 were dose-dependent and were mostly mild and include infections. Most common events were nausea, headache, transient increases in serum transaminases, and lipid levels, and decrease in hemoglobin levels. Serious infections occurred in the UPA 30 milligrams arms of Select Next and Select Beyond trials. We all know about herpes zoster now. We didn't know anything about herpes zoster prior to the JAK inhibitors era. An increased incidence of herpes zoster reactivation was observed in all UPA. I'm not only attacking UPA here. Was across the 5 trials, all of the 5 trials, with 2 serious cases in the UPA 30 group in the Select Beyond study. Malignancies. 2 malignancies and 1 major MACE occurred in the UPA 30 arm of the Select Next trial, whereas 4 malignancies and 2 MACE were reported in the Select Beyond trial in the all UPA arms, PE and CPK. So I don't know if you guys do know about PE, but this is nothing that we need to brush. It's not a VTE, it's a dangerous VTE. And herpes zoster, I don't know if any of you have seen herpes zoster or heard about herpes zoster reactivation prior to JAK inhibitors. Certain companies are trying to say, well, it happens with anti-TNFs. I haven't seen any. So how about added value initiatives that anti-TNFs? We had musculoskeletal ultrasound programs and ultrasound machines, JAK inhibitor companies, hands-off, nursing programs. So those companies supported our patients by nursing programs. JAK inhibitors, no. They kick-started access programs which had helped tens of thousands of patients across the world over the years. Nurse education programs, they've educated our patients, our nurses. Our nurses know a lot about anti-TNFs than JAK inhibitors, definitely. Biosimilars, enormous worldwide savings, more patients to be treated more cost effectively. They had made a big change and huge impact. How can rheumatologists prescribe JAK inhibitor biosimilars cost 1.5 months worth of a JAK inhibitor a year? Now, I'm not going to talk about the last one because I'm going to extrapolate even more about this. So, just to talk you through about biosimilars, originators, and generics. How much does it cost to make a generic? 2 to 3 million. About making a biologic, 800 million. Which means that it will be very easy to make generics for JAK inhibitors. And that will make only required pharmacovigilance trials. There will be no phase 4 trials, risk management plan, or including pharmacovigilance. So this is scary. It is available in biosimilars, it's available in biologics, but not in the generics. I don't know if I'm going to take that risk. So making a biosimilar, it's like making somebody with an exact fingerprint. But when making generics, let me shock you. I think that some people know about this. Yeah? Really? Okay. Now, you know about this? Hitting the market at 100th of the cost. Now, you know about this as well. Now, medico-legal, are you ready for medico-legal? No, I'm not. The biologics, the anti-TNFs, the biosimilars are regulated. But when it comes to JAK inhibitors, generics, it's not regulated. I'm not going to go through this path. This is from one of my patients. She was taking those three. Every month, one JAK inhibitor. And it was one of many bad days in my clinic. How? Now, Mr. JAKs, 3 indications only. It comes only in oral. It doesn't have this IV subcut daily. I don't know about compliance here.
taught us more about herpes zoster and VTEs did not strengthen our connection with other specialities. We didn't have any connect meetings through the JAK inhibitors. Maybe with the dermatologist, maybe not. There will never be head-to-head JAK to JAK. There are anti-TNFs versus anti-TNFs, but there will never be. So we will never know. We don't have any real-world data on dose tapering. Monotherapy? Really? Look at his mouth. So you are ignoring all of the complications that I have just mentioned, and you're looking at that tooth only? So that is your take? That is your trump card? In how many patients is that possible? Okay, let me impress you even more about anti-TNFs. This was published in 2020 during the COVID pandemic by none other than Professor Brewmister, which was speaking yesterday, with just one publication. This guy published on 30,000 adult patients from global clinical trials across multiple indications. Now, what did he find? I don't know if you can read this. So, like, since 2003 until 2020, no new safety signals or tolerability issues were identified, and the risk of mortality was not increased compared with the general population. So our take here is that 17 years we can. Dose reduction flexibility. Almost all multiple trials showed that we can either dose reduce or extend the intervals between each of the anti-TNFs. We managed to feel more comfortable taking patients of all therapy through the past year. That is called confidence. We don't have that with the JAK inhibitors. We're still not confident about Mr. JAKs. We can restart any anti-TNF after pregnancy. We can't do that for breastfeeding mothers with the JAK inhibitors. Unanswered side effect profile that which is the expensive cortisone, basically. You're talking about pain, fatigue. Cortisone is the best in that. So we have no data about male infertility with the JAK inhibitors. Nobody answered that question. So 10 reasons, make that 11. Colonic perforation. I don't know how can you live with that, but with the increasing use of JAK inhibitors, we will be seeing more of this. So watch out for this. So VTEs. Yesterday we heard Kush talking about our patients are at a higher risk already. So are we ready to augment the risk of VTEs in our patients? Do you want this patient on the left to be on the back of your mind with the JAK inhibitors? No. So the toxic JAKs. I think Ahmed understands the lesson now. Unanswered questions like fertility, I covered colonic perforation. Cancer risk assessment, you can't come up with an answer for the cancer that related to JAK inhibitors with the current data. Anti-TNFs, we have long data so that we can be more confident, not JAK inhibitors. Should we be monitoring for lipids? Nobody answered that. So VTEs means a large cohort of our patients won't be able to have it. A lot of our patients are already at risk. If they are really different, the 4 JAK inhibitors, would their side effects eventually be different? We don't know. It is not dose dependent, they say. Is it? Or is it not? different risk between different agents from the same class. One agent is supposedly going to be registered for SLE, who are at higher risk of VTEs. Really? You want to use a JAK inhibitor in such patients? Good luck. So this is part two, which is the rebuttal. I leave the floor for Himera for her rebuttal for now. Thank you.
So I'm not going to use my rebuttal slides because what I thought Waleed will talk about, he will talk about. So hats off, you win for humor. I win for efficacy and safety, so I think we can say that. Well, just jokes apart, we have used, I agree completely and endorse Waleed's view. We have long-term data and long-term experience with the anti-TNFs. The JAKs are the new kid on the block. We have taken to it. Initially, we didn't use them at all, and as we use them more and got more experience, we've seen we've got personal real-world data and real-world experience with it. We've seen that it's effective. We're not really seeing that many side effects despite all the scary data. But because we've also had that long experience with anti-TNFs, we have seen scary side effects. The only patient who ever had ophthalmic zoster on, very bad ophthalmic zoster, was on adalimumab. TB with the anti-TNFs. So because we've had this long-term experience, I had a patient who developed multiple sclerosis on anti-TNF. So we have seen these kind of side effects, but it's only time before we start seeing side effects with the JAK inhibitors. So if we have an agent which is effective, which is in fact more effective than the older agent, if we have an agent which is safe, or at least the data so far tells us it's as safe as the older agents, we have it, as we said, patients prefer monotherapy. They prefer an oral agent, and we use it in some sort of overlap syndromes as well. But you're right, it is all about the individual patient and how we select the patient. A morbidly obese person at a high risk for VTE. And I can tell you that I had a patient, I didn't see her. She was somebody who did an online consultation with me from Pakistan. She's been absolutely immobile. And she's tried anti-TNF, she's failed them, she's tried methotrexate, has very bad RA. So I was speaking to her and I said, there is this drug called tofacitinib, it's available in Pakistan, etc. So she bought it from Pakistan. She traveled to the UAE to see me during this pandemic. And while she was waiting to see me, she started it only for 4 or 5 days, actually, and she developed a pulmonary embolism. So, of course, the pulmonary embolism was not probably related to the drug, but probably related to her immobility and the travel combined, and she was obese as well. But we have to do, as we do, we are rheumatologists, we carefully select patients, we exclude patients with cancer from taking anti-TNFs, we screen for TB. We're so careful with all of these drugs. So patient selection is important. We have to get the appropriate patient. But for a vast majority of our otherwise healthy patients, I think I will conclude that my preference would be for a JAK inhibitor. That's my rebuttal.
Thank you, Himera. Waleed, you have to reply.
So the first thing is a question for Himera and for the audience. So this is a true story. Well, maybe. So a 27-year-old Pakistani male who has mild psoriasis, swollen knee, has high inflammatory markers. All UAE rheumatologists have seen him and have diagnosed him with psoriatic arthritis. He has failed 2 conventional synthetic DMARDs. So this is for Himera. What are you gonna prescribe him? This is for the audience. Anybody can raise their hands and select. Number 1, number 2, 3, 4, 5, 6. So what is your choice, drug of choice here? Mild psoriasis, knee effusion, failed conventional synthetic DMARDs 2. What is your choice? Okay, so let's include number 6 and stick to the top 5. Dr. Ahmed?
Number 5.
Number 5. He's already convinced. Okay. Anyone would go for a JAK inhibitor? Nobody. Really? Okay. Now, you see him as a second opinion, Humera. He now has inflammatory back pain and bilateral sacroiliitis. Again, what are you prescribing him? Number 5. So even Humera has been convinced. Anybody that would go for IL-17? Come on. It's a good drug. Okay. Yeah, okay. Now, you order more labs, 2 weeks later, you get P27, and he develops uveitis. So, what have I tried to tell you here? In spondyloarthritis, for example, anti-TNFs offer more than whatever JAK inhibitors or any other agent in the market. So, now, when we talk about JAKs versus biologics, when we talk about comparing Cimzia to adalimumab, we are comparing apples to apples. But when you compare adalimumab to JAK inhibitors or the other way around, no, you're comparing apples to peanuts. Oral, subcut, anti-TNF. So unless you have a JAK versus JAK, we cannot say anything. Otherwise, compare methotrexate to JAK inhibitors, and that ends my talk. Thank you very much.
Thanks, Dr. Walid. So now time to vote now for, let's start with Dr. Humera. Please raise your hand if you are voting to Dr. Humera presentation. One, 2, 3, 4, 5, 6.
Ita, you are fired.
Okay, so we have final 6 votes for Dr. Humera. Okay, how many will vote for Dr. Walid Shahi? Against him 5?
Thank you very much.
Okay, so I think we have the same result. Thanks for the both speakers for very interesting covering of very interesting topic. Actually, we appreciate all mechanism of action to help our patients more and more. And it's very nice to present all the aspects, the side effects, the drawbacks, efficacy, and safety of our medication to help our patients. By this talk, actually, we are closing this session.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23p19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.
Good evening, everyone. We're now going to move on to the next session, which is a symposium sponsored by Janssen's. And this is a non-CME talk, and it gives me a great pleasure to invite my friend and our very well-known rheumatologist in the region, Professor Ahmed Abu Jamal. He needs no introduction because he has been here in the region for the past 2 years and already established his mark as one of the well-known rheumatologists, highly experienced and skilled and passionate about his ultrasound scans modality. He's been a EULAR trainer in ultrasound and a fantastic clinician. So I think with very little time, he has established his own mark in the region. And I think this is incredible, and he's a big asset to UAE. So without any delay, I'm going to let Ahmed carry on with his talk. And I must emphasize about his excellent skills in the slides and presentations. So I'd like to welcome Professor Ahmed Abu Jamal.
Okay, thank you, Dr. Bahavna, for a nice introduction, and thanks, Janssen, for inviting me to present this talk. My presentation will be about the Tremfya and interleukin-23 inhibitor towards better management of psoriatic arthritis. This is my disclosure, and this talk already sponsored by Janssen. The agenda of my talk will include a brief introduction about the psoriatic arthritis lesions, what's the definition of these lesions and how it occurs. The second objective will be about which therapeutic targets are valid to treat psoriatic arthritis and why these targets are valid. And the final segment regarding interleukin-23 inhibition in psoriatic arthritis patients. Starting from psoriasis, is almost affecting 2 to 3% of the general populations, and 1/3 of this percent supposed to develop psoriatic arthritis. And in fact, the extent of psoriatic skin lesions associated with more risk to developing psoriatic arthritis, especially in some areas like the scalp areas, intergluteal areas, and the palmoplantar psoriasis and nail psoriasis also have a higher risk of developing psoriatic arthritis. Among other rheumatic syndromes, psoriatic arthritis is very heterogeneous. It can be presenting just inflammation of peripheral incisors and dactylitis or soft tissue inflammation, up to axial disease with similarity to ankylosing spondylitis with typical sacroiliitis and spinal dysmotility or limitation of movement, to polyarticular symmetrical arthritis, looks like rheumatoid arthritis, and could have, by long-standing cases, to have arthritis mutilans. So the presentation of Psoriatic arthritis is very heterogeneous, not following only as one domain of joint lesions. Outside the articular manifestation of psoriatic arthritis, we have a higher risk of association between some diseases or some complication could have it in the systemic level, including the cardiovascular system, hypertension, obesity, diabetes, and even Crohn's disease, with high prevalence of depression among patients with psoriasis and psoriatic arthritis, with anemia, malignancy, or nephrotoxicity or hepatotoxicity due to long-standing medications. So the psoriatic syndrome is a better term to describe the whole disease from the articular and extra-articular manifestations of the psoriatic arthritis and psoriasis. When we speak about the psoriatic arthritis as a domain, it's better to summarize lesion according to the pathological classifications to synovitis, enthesitis, and dactylitis. And synovitis in psoriatic arthritis is very unique, especially in the imaging modality. You can see the joint space narrowing plus a very unique characteristics of combination of joint erosions and bone formations, the same picture I was seeing here, the X-ray of the foot. We can notice the bone resorption and bone formation in the same image with a characteristic finding in conventional X-ray. And as well as in ultrasound finding, we can define the extensive Doppler signal, which is in most cases of synovitis in psoriatic arthritis, showing a higher Doppler signal in comparison to other imaging, other synovitis like rheumatoid arthritis. Going to the second lesion, which is enthesitis, representing inflammation of the fibrocartilaginous incisions, usually affecting over 50% of patients with psoriatic arthritis, and usually present a very little or minor inflammatory signs and swelling due to the hypovascularity or low density of blood vessels at the subcortical bone site of insertional incisions, and also the lack of adaptive hyperplasia that could happen at these areas. So usually enthesitis not showing too much inflammatory signs. That's why it's always needed to have some careful clinical assessment and adding some imaging modality to define the inflammation, like ultrasound or MRI, to find the exact inflammation and quantify the progression. Enthesitis usually affecting the lower limb, especially the tendo Achilles, and the plantar insertion or plantar aponeurosis is the common site to be involved in patient with psoriatic arthritis. Coming to the third pathological lesion, which is dactylitis, representing inflammation of the whole digit from the subcutaneous tissue to the tendon covering, involving the DIB or interphalangeal joint, so we cannot palpate the joint swelling. From here, the name coming, the sausage digit or dactylitis is already representing a very high inflammatory signs like redness, tenderness, and swelling, usually occurring in the dominant hand, including the index finger, and if occurring, the foot usually involves the fourth, fifth, and first toes, the commonest site according to the registers published for psoriatic arthritis. So we have defined the targets in the lesion in psoriatic arthritis. What about the targets in psoriatic arthritis and why it occurs? Starting from the enthesial site. Enthesial site, usually it is believed to be the primary site of inflammation in psoriatic arthritis, and from that site, the inflammation progressed to involve the synovial site. So psoriatic arthritis is always believed to be an enthesitis-driven inflammatory arthritis. Here is the commonest site of inflammation and the most famous fibrocartilaginous incisions, showing the insertion of the Achilles tendon to the posterior surface of the calcaneus, which usually defined as a clear line, which can be seen simply in an ultrasound image, plus the persa related in the calcaneus surface. At this site, there is some subsets of inert T lymphocytes called gamma delta T cells, which is inert at that site of attachments. And these types of cells, under some mechanical stress in predisposed patient with psoriasis, can develop and secrete inflammatory cytokines, starting by interleukin-17, and then in some series that also can secrete interleukin-23, which was the initial step for inflammation responding to a mechanical loads and into inflammation of the incisions. After that, following the inflammation, the second cytokine is the cascade coming, which is the TNF cytokine, resulting in inflammation of the synovial part and inflammation of the tendon inflammations,
with increased the blood vessels in the subcortical bone and infiltration by the inflammatory cells, and finally ending by activation of the osteoclast, starting by the first lesion in the bone, which is the bone erosions. Coming to the third and the final step from activation of interleukin 22 cytokine under the effect of interleukin 17 and interleukin 23, resulting in activation of the osteoblast and causing the bone formation. So completing the typical picture of the interstitial inflammation in psoriatic arthritis, combination of bone erosion from osteoclast activation and osteoblast activation leading to bone formation or bone spares. This occurs actually in a downstream site. What about the upstreams? In the upstream, the main cells working in psoriatic arthritis and psoriasis in general, which is the dendritic cells. Dendritic cells under the effects of two subsets of different inflammatory cytokines, interleukin 12 and 23. Both of them activates differentially the inner T cells to different lineage of differentiation. Interleukin 12 differentiate T cells to T helper 1, and interleukin 23 activates the T helper 17 pathway, resulting in secretion of a wide spectrum of inflammatory cytokines, mainly interleukin 17A and alpha, and interleukin 22 TNF alpha, resulting in the final picture of interstitial inflammation of bone irregularities, bone formation spares, and bone erosion with extensive new angiogenesis and increased blood flow with thickening and inflammation of the soft tissue as an interstitial attachment. This is a dual pathway for inflammation in psoriatic arthritis. And from that side, we have a potential targets that could be valid as a therapeutic target to manage psoriatic arthritis. The first one, which is the T cell, which controlling the T cell could also decrease the inflammation. And we have a spectrum of cytokines starting from the TNF, interleukin 12, 23, interleukin 17, and interleukin 23. Starting from the first one, the first approved cytokine, anti-TNF, the first medication, biologic, approved for the management of psoriatic arthritis, and all of them starting from infliximab to cetrozumab showing efficacy over placebo with different trial. It's not a head-to-head comparison. Coming to ustekinumab, which was the first non-TNF biologic approved for treatment of psoriatic arthritis, showing also superiority over ustekinumab in the B-Summit 1, Summit 2 trial, to the unique Eclipse trial, which was comparing the ustekinumab to TNF and showing superiority of ustekinumab to clearing enthesitis and dactylitis over the anti-TNF inhibition in patients with psoriatic arthritis. Ending by the interleukin 17 blocker, starting by secukinumab, which also show a superiority in future 2 trials over placebo in achieving ACR 20 and 50, to the exekizumab, which also show a superiority in Spirit 1, Spirit 2 over the placebo in improving patient ACR 20, 50, and 70. Coming to the last one, which is the tofacitinib, approved for the management of psoriatic arthritis almost in 2017 in OPAL PRODEN and OPAL Beyond trial, showing superiority over placebo in achieving ACR 20 after 3 months of the application of tofacitinib. So we have psoriatic arthritis lesions and we have targets which could be already used and most of them approved in the management of psoriatic arthritis, but still we have the interleukin 23 inhibition. Binding of interleukin 23 cytokine to its corresponding receptor over the surface of the T helper 17 results in activation of what is called the T helper 17 signaling pathway, ending by secreting inflammatory cytokines from ranging from interleukin 6, 17, and 22, which leads all the pathological lesions of psoriatic arthritis from destruction of the bone, from bone resorption or bone proliferation and spares formation to soft tissue and even synovitis cirrhosis activation. Interleukin 23 is composed of 2 main subunits, B40 and B19. B40 was the target in ustekinumab, which is already approved before for the management of psoriatic arthritis, but B19 already have the monoclonal antibody to control it and prevent the interaction between interleukin 23 and its corresponding receptor. And actually, this is already what's happening with gozelkumab, which is the first and only approved interleukin 23 in our region till now for the management of psoriatic arthritis. It's already a human monoclonal antibodies that bind and neutralize the soluble part of the interleukin 23 and prevents the bridging or binding to its receptors, which ending by inhibition of STAT phosphorylation and cytokine production. Gozelkumab or Tremfya gets approval through two big phase 3 trials, which is Discover-1 and Discover-2. Discover-1 was dedicated mainly to assess the efficacy of Tremfya in patients with or without previous experience to TNF blockers, and Discover-2 for already patients to assess the efficacy of Tremfya in patients with biologic naive with psoriatic arthritis. Starting with Discover-1, which is designed about three parallel arms. 2 arms was for treatments arm was 2 different treatment regimen, and the third arm was for placebo. The treatment arm regimen is starting from gozelkumab at week 0 and then 4, then every 4 weeks, and the second arm was at week 0, 4, and then every 8 weeks, continue up to week 52, and the placebo arm continue for week 0 and 4 as a placebo injection up to week 24, then switch it to active treatment on the every 4 weeks injection of 100 milligram gozelkumab. The trial was already some medication allowed to be taken at this trial, which is the concomitant medications, including NSAIDs and steroids, and already conventional DMARDs like methotrexate, lazoparine, hydroxychloroquine, and leflunomide, with the primary endpoint was assessing the percentage of patients achieving ACR 20 at week 24, and secondary outcome including the ACR 20-50 at week 16, ACR 50-70, and skin assessments with assessment for pain and fatigue with enthesitis dactylitis at week 24. For the inclusion criteria, the major one already is the age of the patient at least 18 years with 6 months diagnosis of psoriatic arthritis based on Casper criteria, and the patient have at least 1 domain of active psoriatic arthritis, defined as 3 tender or 3 swollen joints with CRB equal or above 0.3 milligram per deciliter, and already have at least 1 domain affected, including the polyarthritis or asymmetrical arthritis, arthritis multilans, or even axial spondylitis with peripheral arthritis. Patients have already failed the conventional therapy or failed 1 or 2, maximum 2 of TNF blockers. For patient exclusion, patients already who failed more than 2 TNF blockers or have experience with other biologics or other JAK inhibitors. At week 24, the primary endpoint was achieved as the percentage of patients achieving ACR 20 as the 2 different treatments arm was superior to the placebo arm, and also for the ACR 50 and ACR 70 at week 24. And this efficacy actually maintained to the week 52. But we can notice here the increase in the placebo columns in both graphs here for ACR 20, 50, and 70. This actually occurs after switching from the placebo treatment to active treatment after week 24. So which means that the patient on placebo already catches the treatment response comparable to patients on the treatment arms. For ACR 20 over 52 weeks, you can notice here the patient already achieved the primary endpoint at week 24, and the percentage of patients achieving the ACR 20 numerically improved at week 52, and the patient on the placebo group, when shifted to active treatment, respond well and catching already the response of the treatment group. Also, we can notice from here the early response happening almost after 4 weeks from starting the medication, which actually was very strange for a medication working on the upstream cytokine treatment. Was expected to have some delayed response, but according to this graph, we can notice a splitting of the curve starting from the 4 weeks, which means actually after 1 dose of gozelkumab or Tremfya, we start to notice a significant or some response, numerically better, and start to have a significance from week 8, which means after 2 doses only of gozelkumab versus the placebo side. As regards the ACR 20 response with according the TNF exposure, we can notice also here the response between the TNF exposure, no prior exposure with TNF exposure before, the response rate almost similar regardless the TNF exposure, which are actually a good data for our patient. Already most of them are failing TNF inhibition before. Again, for the TNF inhibition for 52 weeks, you can notice the same phenomena that patient on placebo arm start to have a higher response based on the switching from a placebo treatment to active treatment. As regards disease activity for the joint in DAS28-CRB, we have a significant reduction in DAS28-CRB in both treatment arms in comparison to placebo arm. And for the minimal disease activity, we have a significant higher response among the two treatment arms in comparison to placebo. For the HAQ-DI, which is important to assess the function, we have in the 24 weeks and 52 weeks, you can see a significant improvement in the HAQ-DI and in both treatment groups, and also in the placebo after 52 weeks from switching to placebo to active treatment. About the FACIT score for fatigue, which is very important, we have almost 54% of patients on Tremfya compared to 35% on patients on placebo have achieved a significant 4-point reduction in FACIT score, which indicates that fatigue is significantly improved in patients with in Tremfya treatment group. And also we can notice here the fatigue itself is start to have a significance starting from 8 weeks over the placebo and maintains up to week 24. We have a clear increasing with each dose to have a significant reduction in fatigue in patients with psoriatic arthritis. For the skin response, there is a marvelous skin response comparing to placebo, have improvement in PASI score, PASI 75, PASI 90, and PASI 100 at week 24 and week 52. And again, patients on placebo arm start to catch the treatment response based on the switching between placebo to active treatment arm. As regards the safety, there is a good safety signal from the drug. That's no clinical meaningful difference between observed guselkumab every 4 weeks and every 8 weeks dose. And there is no alarming signal regarding the infections, malignancy, TB, and IBD with overall safety comparable to the psoriasis published data. And from here, actually, in this red box, we can see the adverse events, actually the discontinuation rate due to side effects almost similar between the treatment arms and the placebo arm, and serious infection almost zero in the post-treatment arm. You have 2 in the placebo arm, which already a good safety signal for a treatment with biologic inhibitor or monoclonal antibodies. The summary of from Discover-1 at week 52 for safety signals, we have almost 4% reported serious side effects. And we have 1 reported serious infections, no guselkumab-related cases of death, inflammatory bowel disease, opportunistic infections, or active TB or anaphylactic serum sickness. Coming to the second trial, which aimed to assess the response in biologic-naive patients, already have the same design of treatment with 3 treatment arms. The same design like Discover-1, we have one arm treated with guselkumab every 4 weeks and 1 arm treated with guselkumab every 8 weeks, and the placebo arm continue up to week 24, then switch it to active treatment by guselkumab every 4 weeks. The primary endpoint was assessing ACR 20 at week 24, with concomitant medication allowed, including NSAIDs, steroids, and conventional DMARDs like methotrexate, leflunomide, and clozapine hydroxychloroquine. The second endpoints, including the ACR 20 and 50 at week 16, and at week 24, assessing ACR 50, 70, skin assessment scores, DAS-CRB, and FACIT for fatigue, and dactylitis assessment and encephalitis assessment scores. For the inclusion criteria was similar to Discover-1, with one major change regarding the experience to TNF blockers. Patient here should be a biologic naive, and exclusion including patients have experience with any biologic before or small molecule like apremilast or JAK inhibitor. At week 24, the study achieved its primary endpoint as the patient achieving ACR 20 was superior to placebo at week 24. Also the same for ACR 50 and 70 at week 24, which indicates already a very early response to achieving a higher percentage of ACR 70, 50, and 20 over placebo. At week 52, we can notice again the same phenomena which is seen in Discover 1 regarding the response of the patient on placebo after switching, and already maintained the response achieved over 24 weeks to 52 weeks. Again, we can notice here the start of splitting, and early after the first and second dose, we start to have a significance after second dose of guselkumab, and the patient already achieved the ACR 20, start to improve numerically at week 52, and the patients from placebo, once switched to treatment arm, start to catch up the treatment arm at week 52. For the minimal disease activity at week 24 and 52, we have the similar response to in Discover 1. Patient achieving the MDA was significantly superior in the treatment arms, and the patient on placebo already have a significant improvement after switching to active treatment. The most important outcome from Discover 2, which is radiographic progression, as we can see here, the modified SHARP score. There is a great significant reduction in the both treatment arm in comparison to placebo after week 24, after only 3 months of application, 6 months of application of the of guselkumab. And the structure damage and the progression already diminished using the assessment score modified SHARP score. And again, the treatment arm or placebo arm respond well, and we can catching the similar response to the treatment arm after switching to active treatment. Safety signal was almost similar to Discover 1, no serious infections, no active TB, and no cases of serum sickness or anaphylactic shocks. The percentage here was 4.2 after 1 year of application of the guselkumab, and 1.2 reported serious infections, no reported deaths, IBD, opportunistic infection, or active tuberculosis, or anaphylactic or serum sickness-like reaction. For the conclusion from the both trial, guselkumab 100 milligram either every 4 weeks or every 8 weeks demonstrate efficacy for joint and skin symptoms, physical function, and the quality of life relative to placebo at week 24. Guselkumab at the 2 doses maintained improvement in joint symptoms through 1 year in patients with active psoriatic arthritis who were biologic naive or have previous experience to TNF blockers. Guselkumab or Tremfya significantly improved joint and skin symptoms, physical function, and the quality of life, and resolved enthesitis dactylitis at week 24. Mean change in total modified SHARP score at week 24 were significantly lower for guselkumab every 4 weeks and numerically lower for guselkumab every 8 weeks versus placebo. And guselkumab shows sustained improvement in joint and skin symptoms, inhibition of radiographic progression, and improvement in physical function and the quality of life through week 52. And guselkumab was well correlated with no serious adverse events at week 24, 52, was consistent with the previous safety data published in psoriasis trial. This was my last slide, and thank you.
Thank you very much. That was very insightful. We have one question from Dr. Hanan Salah. She's asking about axial involvement. Is it affected by drug?
Axial involvement, actually, there's one nice sub-analysis done by Philip Hollowell and last Euler. Is published sub-analysis from a pool of patients from Discover 1 and Discover 2 who already have an X-ray evidence, radiographic evidence of sacroiliitis before the starting of the trial, and showing that those patients already have a significant improvement in ASDAS score and BAS-DAI score. So there is a claim that this medication work well for those group of patients with psoriatic spondylitis. But we cannot extrapolate this information to all patients because this patient already included initially for psoriatic arthritis, not for an axial disease. But based on that, could happen that we have a significant value or benefits for patients if have peripheral arthritis and axial spondylitis at the same time. So the medication could work for both domains.
Sure. I think we don't have any more questions. I have a couple of questions, Ahmed, for you. One is, what do you think is, I think I asked this yesterday, but I didn't really get the answer. What do you think is the reason for this differential effect where IL-23 inhibition works for axial manifestations in psoriatic group of patients, while the previous studies with ustekinumab did not show any response in axial spondyloarthritis group? What could be a possible reason for this?
A very big question. Nobody knows what is the cause of this. Actually, there was a great expectation with interleukin-23 inhibition to work for spondylar arthropathy in general. But the failure of different trials not showing superiority in such group of patients. But again, this sub-analysis shows some benefits for psoriatic spondylitis. I think that could be the difference is the population of T cells present at this incisions in axial and the peripheral enthesitis. Most of our data showing that the cells and the resting cells and the peripheral incisions are responding well to interleukin-17, 23 dependence pathway. But it seems, according to the data published, that the population of T cells and the axial incisions in spondylar arthropathy are responding well to interleukin-17 alone, not for interleukin-23. This could be just a stage of disease. We're applying, the group of patients was already at end stage, so we are not responding well to interleukin-23 blockers, because interleukin-23 blockers acts mainly in upstream situations. That could be an answer. Type of cells differential could be another answer. Again, for the subgroup analysis done by Philip Hillowell for Discover and Discover 2, also we cannot generalize this data because who knows that if you select a patient with isolated psoriatic spondylitis, is it going to work again or just work with the same pathogenesis that have peripheral arthritis and spondylitis?
Yeah.
So difficult answer, but...
I agree, but I think you've done a good job in getting closer to that. We have another question from Dr. Ahmed. He says, nice talk. Is there a difference in using upstream or low stream inhibition in early versus established disease? And that's specific for psoriatic arthritis.
Yes, theoretically, yes. If you are going to use the upstream medications, you have to use it early. Because at early onset, that could have a good benefits to our patient before expansion of the vicious circle of the autoimmunity. So it's better to do it in the upstream. So it's better to use the upstream early. But again, if we look to interleukin-23 blockers, the data showing that acts very fast in comparison to the upstream.
Yeah.
All of us are expert in ustekinumab, and upstream are waiting a couple of months to have a significant effect.
Sure,
yes.
Definitely.
But I think we are waiting to have a clinical experience with these medications to see if it works like 1 month to have a significant difference.
Yeah.
If you have an upstream medication who's acting in 1 month, so it's a good advantage to our patients already.
Sure. I think another question, well, we're waiting for some questions coming up here, but what do you think are the salient differences between ustekinumab and gozalkumab in terms of, clinical, benefits?
That's a good question. You know that already we have the B40, ustekinumab is a B40 antagonist, and gozalkumab is targeting B19. The main, both of them are already 23 blockers. If you come back again to the meta-analysis, you have a comparison between Summit 1, Summit 2, and Discover 2 regarding the level of interleukin-17 inhibition and level of the CRB and interleukin-22 levels after and before application of ustekinumab and gozalkumab. It's showing that the percentage of decreasing interleukin-17 level in the serum after applying 1 dose of gozalkumab is significantly higher than what is going to happen with ustekinumab. The answer is could be the affinity. The affinity to the interleukin 23 blocking from guselkumab is too much higher than ustekinumab. So it blocks hardly or significantly blocks the interleukin 23. That's why it gives a high reduction in interleukin 17 level in comparison to ustekinumab. This is actually his answer. It is the same, or it's supposed to be the same mechanism of action, but it's different molecules, different affinities.
Yes,
so
of course. Yeah.
we're expecting different results.
Sure. Let me ask you another difficult question.
Okay.
Well, I think a practical question, really. You have a patient with psoriatic arthritis and cutaneous psoriasis. Now, you've got to choose between ustekinumab and guselkumab. Which one would you go for, and why? Janssen's?
I will go for Tremfya. And this happened 2 days back. No, actually, I think all of us believing that ustekinumab is underdosed. The dose of ustekinumab to have is a good drug, but the dose is very low. And you know that all of us are fighting with insurance to get approval for our medications. So we're happy to have ustekinumab in a very high dose and short frequency, as like every 2 months, but it's not a scenario for most of our patients. But we are hoping, all of us hoping that be the answer with Tremfya. It's already well designed, the dose is fine, and the data is showing a good result. So Tremfya will be actually the priority.
The preferred. And one last question. Yeah, I think we're nearly done, but one last question. So unlike rheumatoid, for psoriatic arthritis, literally every single mode of action is a contender. TNF inhibitors, you have IL-17s, you have IL-23 inhibitors, you have JAK inhibitors coming over. So would you consider the IL-23 as a first-line biologic, and which patient would that be?
That's already, again, difficult question, Bhavna.
Sorry.
All of us knowing that psoriatic arthritis is very heterogeneous. And till now, we don't have one answer for all our patients. We are happy to have more molecules. I think sometimes we are saying our molecules more than our patients. But we are seeing patients fail 1 and 2 and 3 and 4 of mechanism of action rather than rheumatoid. Rheumatoid already most patients may be stable for medication for a long time, but not in psoriatic arthritis.
Yeah.
With each new mechanism of action, we have a new hope for our patients. And already, I think for the coming years, interleukin 23 inhibitors will have a good place in psoriatic arthritis.
Thank you so much.
Okay.
And we really enjoyed your talk.
Oh, thank you.
And the illustrations, of course. You're going to give me a crash course on that.
Yes, inshallah.
Thank you. And so that's the close of this session. I think we're going to start with the ACR session soon. Thank you.
everybody to the afternoon session of ERA, which is going to have actually a very busy program. Each lecture will be 30 minutes. So I'll start with our first speaker, who is Professor Peter Nash. Professor Peter Nash is a professor at School of Medicine at Griffith University, and he is associate professor in the Department of Medicine at the University of Queensland and director of the Rheumatology Research Unit on the Sunshine Coast. He was involved in many therapeutic trials involving biologic treatment and other molecules. And he has more than 200 peer-reviewed papers and 5 book chapters. He's recently been recognized as the Australian rheumatology research leader with the most citation of the top 20 journals in rheumatology over the last 5 years. His special interests include metabolic bone disease and novel therapeutics. So welcome, Dr. Peter Nash, and the floor is yours.
Thank you very much for the kind invitation to share some thoughts. Waleed asked me to update you on new molecules seen at ACR Convergence and Washington. And the first one is with rheumatoid. What's new is the filgotinib study, the safety study. I'd love to have argued with Waleed over his presentation about JAKs. I think he put evidence-based medicine back 25 years. But so at ACR, they presented 10-year safety data with tofacitinib, 8 years with baricitinib, 3 years with upadacitinib, and this was the filgotinib safety. And the most interesting thing is that this particular JAK1 selective molecule doesn't have the same zoster signal or VTE signal that you see with the other JAK, and it's a shame that the Americans have rejected it. So what about what's new in giant cell arteritis? Most interesting is this molecule mavrilimumab, which we were involved with in studies in rheumatoid arthritis. It's an antibody to GM-CSF. It had really reasonable safety. There was an issue of alveolar proteinosis that we didn't see in rheumatoid patients. But this is testing it for the first time in giant cell arteritis, where it's GM-CSF is an upstream mediator to Th1 and Th17, both are pathogenic in giant cell arteritis. This was a smallish study with about 70 patients. They had biopsy or imaging positive disease. And what was interesting, they could show a reduction in new onset of giant cell arthritis. They should show reductions in relapsing refractory giant cell arteritis and reductions in the time to flare and percentage of sustained remission. So it looks like we might have a new treatment choice for giant cell arteritis. This will now move forward into bigger studies to try and prove what this study showed, which was really a proof of principle. So look forward to anti-GM-CSF receptor monoclonals in giant cell arteritis to come down the line. What's new in vasculitis? Well, there was a very interesting molecule called avacopan, which is oral. It's an antagonist to the C5a receptor, the complement fragment receptor, and it was able to significantly reduce the steroid requirements. And this was looking at, in particular, renal disease in ANCA-associated vasculitis. And this was on the background of standard of care therapy. And they improved remission rates, they improved renal function compared to using corticosteroids. So any drug that is effective in reducing steroid requirements in difficult patients with ANCA-associated vasculitis looks like it might be of interest moving forward. They had significantly less glucocorticoid-related toxicity using avacopan instead of using corticosteroids. So we look forward to this drug moving forward into phase 3 trials to see if this improvement can be sustained. So what's new in lupus? Well, lupus, everybody knows about belimumab. Well, they showed belimumab blocked BLIS, which is it's an antibody to BLIS, lymphocyte B. It's targeting the growth factors for B cells, and the idea being that you can turn B cells off and therefore pathogenic antibody production in diseases like lupus. And they showed lupus and renal outcomes at 104 weeks, and they started to show some significant efficacy with belimumab on those lupus renal outcomes over 2 years with background therapy that is standard of care. And you could see that it didn't matter which particular background therapy or class of lupus nephritis or race, you could show that the odds ratio favored the belimumab on top of standard of care. They've had trouble showing belimumab significantly efficacious. Our government has not allowed us to use this drug because the efficacy wasn't there for cost. Perhaps studies like this will start to show a difference. Another lupus drug that we need to learn about is anifrolumab, which they put the efficacy data from the TULIP-1 and TULIP-2 studies that you would have seen at ACR. And the interesting thing is that this drug that blocks interferon signatures, really we should be thinking about treating lupus as a domain approach. There was significant benefit in some elements of the lupus, but not all. And I think that's why we've had great trouble finding drugs that work across the board in lupus. You can see here, for example, there was no difference compared to the placebo in CNS lupus, but you started to see differences in musculoskeletal and mucocutaneous skin and in the immunology that was significant. So I think we need to start thinking about our lupus therapies as a domain approach. You might have one drug very good for lupus arthritis, but not very good for lupus CNS disease. And I think if we start analyzing lupus studies and lupus drugs that we know that work, like mycophenolate and rituximab, which we've never been able to prove in clinical trials, we need a domain approach to bring out the parts of the lupus disease that novel therapies work for. And being an interferon blocker, we have to worry about herpes zoster signal. Now, another molecule that looks very interesting is obinutuzumab, which is an anti-CD20 like rituximab, but it's been modified, it's been engineered so that it increases the by 100 times effects on complement and the complement binding, and it just makes it a much more potent molecule. And they showed this nobility study. Again, they looked at lupus nephritis, they looked at bad prognosis patients, and they had very significant improvements in complete renal response. And they defined complete renal response there in that paper, improvement in EGFR, protein creatinine ratios, dsDNA complements, peripheral B cells, and you could see significant differences, but they really only had 2 infusions at baseline and 2 infusions at 6 months, and they were showing benefits out to 2 years. So this is like a supercharged rituximab, if you like. It'll have a great role in lymphoma, of course, in vasculitis probably, but it looks like it's going to be an improved drug for lupus nephritis as well. What else did they show in lupus? They showed a different form of cyclosporin, this one called voclosporin, and it, again, on background therapy of mycophenolate and low-dose glucocorticoids in lupus nephritis, shows significant improvement, time to reduction in protein creatinine ratios, over the renal response over 6 months to 12 months. And so this also looks like a new agent that will be testing further. And in particular, you'll see that patients had not so much different in side effects. We still have to be very careful like we are with cyclosporin. Now, you've heard a lovely talk on IL-23 and psoriatic arthritis. What else is new? There's a new JAK that binds to TYK2, which is really like a JAK4, but they call it TYK2. And it binds in a different way by binding to the regulatory domain rather than the ATP binding site, the active site where all the other JAKs bind. And in PSA, this is an oral agent for psoriatic arthritis. They had nice ACR 20, 50, 70 responses, and they had nice improvements in skin around the 40 to 60% ACR 70. So a kind of a TOFA, TNF, but nowhere near IL-17 or IL-23 on skin. But to be fair, rheumos don't see very severe skin. We mainly see severe joint disease. PACs improve MDA responses with about half the patients reaching MDA and quite a manageable safety profile. So this is the new TYK2 inhibitor for psoriatic arthritis, deucravacitinib. We have previously seen at EULAR upadacitinib in biologic naive PSA, again with nice ACR 20, 50, 70 responses, very respectable PASI responses with 30% getting PASI 100. This is with a JAK now. And also good improvement in enthesitis and dactylitis, but also they've showed reduction in X-ray progression. So you will be seeing upadacitinib in PSA at ACR 20. They presented the data in the TNF inadequate responder patient population and got a very nice ACR 20, 50, 70 response. And again, quite impressive skin scores in this much more difficult patient population. Enthesitis, dactylitis, and also a very reasonable safety profile. There was a zoster signal, as you would expect. They saw one case of VTE in the 15 milligram group and no cases in the placebo group out of 400 patients studied. So that's the JAK1 selective upadacitinib in psoriatic arthritis. What about in ankylosing spondylitis? As you heard Walid say, they presented some data of tofacitinib in ankylosing spondylitis, and you could see some pretty reasonable ACR 20 and 40 results. So that will come also in AN. Scleroderma is the hugest unmet need. This was an interesting drug. This drug is an oral small molecule that is selective for autotaxin inhibition, and that's the enzyme responsible for lipophosphatic acid production, which is pro-fibrotic and pro-inflammatory. It's a lipid that works through the 6G protein coupled receptors. Here's a study just looking at cutaneous disease, and they were able to show the modified Rodnan skin score improved with compared to placebo. So again, they're going to take this forward and see if for the first time ever, there's some decent therapy, at least for the cutaneous manifestation of systemic sclerosis. And again, this disease should be, I suspect, tackled in a domain approach: arthritis, skin, separate to lungs, separate to kidneys, separate to heart. We know about the sclerostin story. We know about this new molecule, romosozumab, which is an antibody to sclerostin. And so this really looked at a nice study where they used romosozumab before versus after anti-resorptive therapy. And the best option would be to use this drug that improves bone formation, and that you can then follow it in a cycle with anti-resorptive, and you will then get the best changes in bone density. Of course, then we don't have fracture data, but they looked at bone density both at total hip and lumbar spine. And they also looked very carefully at the cardiovascular signal, was one of the things that was worrying the romosozumab. But in this particular study, they showed it's best used bone formation before you use your anti-resorptive. You get the most gains in bone density with sequential treatment in that way. Apart from scleroderma, osteoarthritis is also a huge area of unmet need. And there was a couple of molecules presented at ACR. This is an interesting molecule that's an angiopoietin-like free protein, and they looked in knee osteoarthritis. Now, the FDA, to license any drug for osteoarthritis, insists on pain relief and function improvement, as well as structural improvement. And the bottom line is that there isn't a drug that does both. So I've got a feeling that we're going to need to use medications that improve pain and function in combination with drugs that work on structure. This works on structure. These are just initial observations of very small numbers of patients. But this is an agent that seems to induce cartilage repair. So if you use a steroid injection or you used anti-inflammatories for pain and function and WOMAC, and you combined it with something that would help with chondrogenesis, that would help with cartilage repair, then that combination might be useful in the treatment of osteoarthritis. As to be fair, we really have very little or no treatment of value other than physical therapy, simple analgesia and anti-inflammatory, maybe a steroid injection, and a hyaluronic acid injection, and then joint replacement surgery. So the drugs seem to get into cartilage, and it seemed to work in a dose-dependent fashion, and it seemed using cartilage biopsies to demonstrate that you can turn some genes on and you might be able to look at chondrogenesis and cartilage repair. Another molecule that's being used is a monoclonal to nerve growth factor. And this has been used in a number of situations. But again, the problem is that it hardly changes osteoarthritis pain. And the dose that does help with pain, the higher dose, starts to get associated with a vascular necrosis of the knee, or where there is the main joint they've studied. So I'm not sure subcutaneous denosumab is going to be a great help in OA pain, because it's hard to show any difference for pain compared to standard and cheap anti-inflammatories. Hard to show any major differences in the WOMAC function, and you're starting to get what they call rapidly progressive osteoarthritis, but which excuse me, which I suspect is really AVN, avascular necrosis. So I'm not sure that denosumab is going to be the answer we're looking for. And lastly, there's an interesting study using intra-articular fibroblast growth factor in knee OA, and again, didn't seem to help with symptoms. It didn't help with pain. It didn't help with function. So you might need another agent to do that. But they were able to show that cartilage significantly didn't deteriorate over 5 years of being followed, even though the amount of cartilage that was actually gained was in the order of 1 millimeter or 2. At least there was no loss of cartilage over time. So again, early days, who knows where this is going to go to, but they're going to take this a little further and see if they can understand a bit more about how this fibroblast growth factor might work. So we've raced through, in a very short period of time, a large number of molecules. We've talked about some JAK inhibitors. I think avocapan looks very promising as a steroid sparer in lots of diseases, including lupus, especially diseases that need complement. We've talked about a new rituximab, a super rituximab, obinutuzumab, which I think will come to market because of the length of the effect. We've talked about a new cyclosporin called voclosporin that also looks very promising in lupus. We've talked a little bit about mavrilimumab in giant cell arteritis, and we all need better therapies apart from tocilizumab and steroids in giant cell arteritis. And we've talked about some experimental drugs in scleroderma and osteoarthritis. And I thank you very much for your
several categories of patients who respond, for example, to certain medicine in lupus, and they don't respond to the other one. So are there any updates about that, and whether these new molecules or new novel treatment have it been tested in other groups of patients or just one category of patients?
Well, the problem is if you're recruiting for a clinical trial, you try and get as many patients as you can as quickly as you can. And so they tend to get lupus patients with a whole mess of different domains involved. And then try and do a bilag or a lupus responder index, which takes all the different domains into account, and are surprised when they don't get a significant result compared to a big dose of steroids with a flared result. So I just think the problem is the metric and the outcome measures we use, and we should start to think about complicated diseases with an approach. Maybe I've got a drug for lupus arthritis. Maybe I've got a drug for lupus skin disease. But maybe this drug is no good for lupus nephritis. I'll have to look at something else. So I think the different target tissue is the reason why we need to think about different therapies.
Thank you. Just see if there are any questions. Doesn't seem that there are any questions actually. It doesn't seem that we have any questions for you, Professor
Excellent.
Nash.
So thank you so much.
There might be a question there. Oh yeah. So one of the questions here: what about turmeric and osteoarthritis?
Okay, so turmeric's a very interesting molecule. If taken orally, it is not absorbed. You have to have pepper mixed with the turmeric to increase its absorption. So anyone taking turmeric without pepper is just passing straight through. The evidence that it makes a big difference to the symptoms of osteoarthritis or to the structure of osteoarthritis are really lacking, and there haven't been much in the way of proper randomized clinical trials to answer that question. I've lived through ginger Zinac, New Zealand green lip mussel, slippery yam, Swedish bitters. Now it's turmeric turn. So if someone could please do a proper study, I'll be the first to use it once they can show me symptom improvement, function improvement, and we can worry about structure, because I don't think it'll change.
Thank you very much, Professor Nash. I don't think that we have other questions for you, so we'll pass on to our next lecturer and next speaker. Thank you very much.
Thank you so much.
Hi, good afternoon, everyone. It's Ahmed Zayat here, and again, we are continuing our best of the ACR cover, which is so fantastic so far. And we got really a fantastic speaker going to speak about a very interesting topic next. We have Dr. Dorok Erkan, who's an associated physician scientist at the Barbara Volker Center for Women and Rheumatic Diseases. He's an associated attending rheumatologist and clinical researcher at Hospital for Special Surgery and associate professor of medicine at Weill Cornell Medical College. Dr. Erkan has a long-standing research interest in antiphospholipid syndrome and lupus. After his internal medicine residency at Beth Israel Medical Center in New York, he completed his rheumatology fellowship at Hospital for Special Surgery in New York. Dr. Erkan has an MD degree from Hacettepe University School of Medicine in Ankara in Turkey, and a Master of Public Health degree from Johns Hopkins University School of Public Health in Baltimore in Maryland. Dr. Erkan has received several honors and awards from the American College of Rheumatology and the Arthritis Foundation for his research. He has published over 150 articles, including research papers and invited editorials, and he as well has over 30 book chapters. And I wonder how I got all this number, which is very well done. So Dr. Erkan is going to speak to us today about, update us about on the management of antiphospholipid syndrome, which hopefully everybody will be looking after for. Thank you very much. And the floor is yours, Dr. Erkan. Thank you.
Good morning, good afternoon. Thank you very much for this introduction, and thank you for inviting me to this meeting to talk about antiphospholipid syndrome. World is really small thanks to Zoom and internet technology. Right now, I'm seeing patients actually in our lupus and APS clinic together with our fellows. And I just told them that I need to be in Dubai for 30 minutes. And after then, we'll continue. So talking about the 30 minutes, this is going to be an update talk, and it's really impossible to update you on everything related to antiphospholipid syndrome in 30 minutes. These discussion points, each of them is really 1 hour at least. So what I'll try to do is just to give you the highlights of these topics. And I'm not going to spend that much time on the third and the fourth because I think the last bullet, there are more exciting developments on that. But you have my email address. I will be happy to send you references after the talk. And please email me with any questions. So let's start with the antiphospholipid antibody test profile and assessment. This is really critical. Like right now, if a fellow comes to my office and says, I have an antiphospholipid antibody positive patient, it doesn't really mean that much to me. We want to know about the type, isotype, level, titer, is it persistent or not? What type of a combination does the patient have? And what is the most recent test? Is it positive or not? Similarly, and more complicated, if someone tells us that the patient has positive lupus anticoagulant, really, I need more information. Was it done in a reliable laboratory? Did they follow all the recommended steps? Was the patient on anticoagulation? If so, what type? And what was the INR when it was tested? A quick note here is somebody on direct oral anticoagulants, it's definitely not reliable. On warfarin, we usually do not recommend, but if it is your lucky day that INR is very low, maybe it's more likely to be accurate. We look at the correction ratio. We also look at the history of elevated PTT, false positive syphilis test, and other antibodies. So it's really looking at the full profile, getting the details. And we all know that not every positive APL test is clinically significant. This is a recent New England Journal of Medicine review article. One table here summarizes the steps that we recommend for the assessment of APL tests. And basics, you all know about that. Yes, antiphospholipid antibodies, we use them as a diagnostic marker, but at the end, antiphospholipid antibodies is one of the risk factors for clinical problems. It's critical to look at the non-APL risk factors while assessing these patients. And we all know that transient APL positivity common during infections, usually low levels. Oh, sorry about that. And then we look at the APL profile. The way I look at it is really high risk, moderate risk, low risk. And again, just this slide can be discussed for an hour, but kind of like a clinical assessment point of view, a patient with positive lupus anticoagulant test with or without moderate to high titers, I see it as a high risk. Negative lupus anticoagulant test, only moderate to high titer, ELISA, moderate risk, and negative LA with low titer, low to zero risk in my mind. And we usually define moderate to high titer as above 40 units, and that's based on the ELISA systems, and low titer 20 to 39. Again, as a reference point for research, our cutoff is always 40. So research is different, which we'll talk about this in a second. But while you are making diagnostic decisions, you really need to use judgment and think twice. If you have a lupus anticoagulant test performed on anticoagulated patients, if the APL profile is APL profile is low risk, if you have only one-time positivity, especially low titer, and then IgA, even IgM, you need to think twice. This week, actually, I saw a young lady with central retinal vein occlusion, and at the time the event happened, she was on birth control pills and she had uncontrolled hypertension. Managed by ophthalmology, 2 months later, hematologist saw the patient. The only positive test was anticardiolipin IgM 41, and she was started on anticoagulation based on that. When I repeated it, I just got the result, it's 21. So you need to be very careful when you have these kind of patients. And this brings us to the diagnosis and classification bullet, that if you have a moderate to high risk APL profile patient, they may have no symptoms, obstetric APS, thrombotic APS, catastrophic APS, you know about these things. And I usually put microvascular APS as on a separate category. And then there is non-thrombotic APS, such as patients with thrombocytopenia. And microvascular APS is really a subset from a mechanistic, pathologic, and treatment perspectives. We'll talk slightly about this at the end. But this is what I mean when I say diagnosis. This is the complex equation that we go through while making the diagnosis. We look at the APL profile, we look at the clinical symptoms, and we look at the other risk factors. Think about the young lady just I gave as an example, an unusual event, multiple risk factors, very low risk profile. And our goal is accurate diagnosis. APS is a disease that we see a lot of patients with missed and misdiagnosis. On the other hand, there are a lot of patients with overdiagnosis. There aren't so many diseases like that. Once somebody gave me the example of Lyme disease, maybe that's true, but APS is really interesting that both problems are equally important. So no diagnostic criteria for APS. We need to use our clinical judgment. That's the art of medicine as a physician to make diagnosis. We have classification criteria, and it should not be used for diagnosis. It's acceptable as a guide, but you need to be careful. This is an excellent review comparing classification to diagnostic criteria. And the bottom line is, with classification criteria, your goal is to capture a well-defined study sample, representative of the majority. You want a homogeneous group, and you are not trying to capture the entire universe of possible patients. With diagnostic criteria, your goal is to capture all the patients as much as you can. And classification criteria, it should not have any impact on billing, reimbursement, treatment. We should not use current SAPORA classification criteria to make major diagnostic and treatment decisions in theory. And I know, as there are no diagnostic criteria, that's not the case all the time. So this is the SAPORA criteria. You all know that there has to be one clinical event that's arterial venous or small vessel thrombosis or a pregnancy morbidity, and then a positive APL test 12 weeks apart, LA, ACL, and anti-beta-2 GP1. And also, lastly, I want to tell you that currently there is an international effort going on, supported by ACR and EULAR, to develop a new classification criteria. We just published phase 1, phase 2 efforts, phase 3 completed, phase 4 currently in the analysis phase, and we are hoping that in a year or maybe less than a year, hopefully there will be an announcement about the new classification criteria. So let's move to the third bullet. I'm just going to give you the summary slides of the 1 hour talk, But when we talk about the primary thrombosis prevention, this is where we are trying to prevent the first clot. First, who is at risk? You know, I just talked about the high risk profile. We need to look at the risk profile first and move on to the second part. What is the role of additional non-APL thrombosis risk factors? I can easily tell you that 50% of APS patients with vascular events have additional risk factors when they have an event. And then, what's the thrombosis rate? No good studies, but if patients have no other autoimmune diseases and no other risk factors, it's somewhere between 0 to 1% per year. So what do we do? I mean, the most important strategy here is assessment of other risk factors, risk stratification, and eliminating all the reversible risk factors as much as you can. Low dose aspirin, I know it's commonly used. However, that's based on the general population, weak data, and retrospective data. No prospective studies supporting the role of aspirin. And what I do, I basically follow the general cardiovascular disease guidelines. And if patients have other risk factors, age, smoking, hypertension, you can Google the risk calculators and get some advice on that. That's what I follow. And if there are any questions, I'll be happy to answer. The second point, again, summary slides, secondary thrombosis prevention. What is the optimal strategy? Optimal INR, optimal duration. Same thing, risk stratification, eliminating of other risk factors. And I want to make the point that high intensity anticoagulation is not supported by randomized controlled trials. High meaning INR 3 to 4 compared to INR 2 to 3. I think we all agree that venous thrombosis 2 to 3 is acceptable. For arterial thrombosis, there are different opinions. And for INR 2 to 3, aspirin is recommended sometimes, or INR 3 to 4. And again, I'll tell you what I do. My goal is INR 2.5 to 3 for everybody. Anyway, I don't like the 2 to 3. It's such a broad range. And I add aspirin in patients with arterial events, especially if they have other risk factors. Not one slide or two about the DOACs. Again, there are a lot of things to cover, but the bottom line is they are not recommended at this point for APS patients. Just to mention the TRAPS trial by Dr. Vittorio Pengo. This was a prospective randomized open label study. It was a non-inferiority trial. Only triple APL positive patients were included with history of venous and arterial thrombosis, and they compared rivaroxaban to warfarin. The primary outcome was cumulative bleeding and vascular death, and rivaroxaban group of 59, 11 patients, warfarin of 61, 2 patients, and again, based on the arterial events. But don't forget, there were also bleeding events in this group. So especially with triple APL positive patients and arterial events, definitely no. For others, it may be considered if warfarin is not feasible, and I think that more studies are needed, for instance, venous thrombosis with single APL, but it needs to be like a case-by-case decision, and patients should know the data behind our recommendations. A meta-analysis also supporting the triple APL positive patients, a fourfold increase of thrombosis. Obstetric APS, it's really one slide. Asymptomatic APL positivity to prevent a pregnancy morbidity. It's usually no treatment or low dose aspirin, but nowadays low dose aspirin is generally used in these patients. Obstetric APS, low dose aspirin and prophylactic dose, and thrombotic APS with or without obstetric APS. we usually give higher dose, low molecular weight heparin. So this is the point I really want to cover. These are the patients we see in our clinic with microvascular disease. An APL positive patient, kidney disease, history of unprovoked DVT, no history of lupus, mild hypertension and diabetes related kidney disease, and then admitted with pulmonary symptoms, liver erythemosa, skin ulcers, low hemoglobin but no schistocytes, low platelets, creatinine up, chest x-ray showing opacities, ground glass, and patient has alveolar hemorrhage. And this is the group that I have been trying to explain. Catastrophic APS is usually in the unit. Microvascular is mostly in your clinic, but microvascular can be part of catastrophic APS too. This is the classification criteria for CAPS that you all know, 3 or more organs with microthrombosis happening very quickly. Microvascular, I gave you an example like diffuse pulmonary hemorrhage, but there are others like skin ulcers, APL nephropathy, cardiac microthrombosis. An APL nephropathy, keep in mind, it can be acute, such as TMA, and it can be chronic with other arterial changes here. And then we already talked about non-thrombotic APS, including valve disease. And these basically brings the discussion to the thrombotic microangiopathies. You can also call it scary APS, which is an endothelial injury-related thrombosis with thrombocytopenia, microangiopathic hemolytic anemia, and an organ disease, which is usually a kidney disease. And when we talk about TMA, there are many other diseases under this group. This table summarizes the causes of TMA, and you see it can be hereditary and acquired. And both under hereditary and acquired, you see complement-mediated TMA. And this complement-mediated TMA is actually the new name for atypical HUS. And what is the definition of atypical HUS clinically, which is, I just mentioned, thrombocytopenia, microangiopathic hemolysis, not typical HUS, so Shiga toxin is negative, and then organ involvement. Look at this picture. I mean, we see this commonly as part of catastrophic APS spectrum. And in atypical HUS, there are genetic mutations, but they do not really correlate with the clinical presentation, and only 50% of atypical HUS patients will have genetic mutations. Can it be the case in catastrophic APS too? Is it possible that some APS patients have genetic mutations? That's why they present with a severe clinical phenotype. These two papers are interesting. They are lupus with or without APS patients, and some also APS patients presenting with TMA syndrome, which is the definition I just showed, and responding to complement inhibition. And then with microvascular APS, one point I want to make is that it does not respond to anticoagulation well. So what do we do? I mean, we usually use catastrophic APS like management. Sometimes we use anticoagulation. If they are really severe and it's like CAPS-like, we use the traditional, what's called triple therapy of CAPS, which I won't get into the details, but we also try immunosuppressive as much as we can. Why? This is a very simple cartoon of why immunosuppressive can work. And you see this is the endothelial cells, and the negatively charged phospholipids are on the inner layer. And when there is an injury, they move to the outside layer. There is beta-2 GP1 binding. Beta-2 actually has two structures. And when it binds to the surface, it opens up where there is antiphospholipid antibody binding, complement activation, coagulation factor activation, and then you get the clinical problems. I will be happy to send you some papers about the mechanisms But really, currently, where we focus on anticoagulation with immunosuppression, the goal is, can we move the treatment to the left of the slide, clearing APL, B cell inhibition, complement inhibition, and maybe other more specific treatments. This patient basically received steroids, heparin, rituximab. On day 3, platelets were going down, started on IVIG with some improvement and discharge on day 10th of the admission. Again, this is just to give you an idea of what type of patients can benefit from immunosuppression. I know I want to finish in 25 minutes. So anyway, I deleted some of the slides in this detailed discussion of immunosuppression. Hydroxychloroquine in lupus patients, most of the registries support the idea that it decreases the risk of thrombosis. There are animal and in vivo models that it can interfere with APL-mediated thrombosis, but there are no good clinical studies in primary APS patients. So it's an add-on treatment when you have a difficult to treat APS patient. Same with statins. Some studies showing that it can decrease pro-inflammatory and prothrombotic markers in APS, but there are no clinical outcome studies. Add-on treatment if you have a difficult patient. Traditional medications, only case reports. I have good luck sometimes with azathioprine or mycophenolate mofetil for thrombocytopenia, hemolytic anemia. We use it in APL nephropathy too, but definitely we need studies. Very quickly about the mTOR pathway inhibition. This is sirolimus, and you know the vascular endothelium of proliferating intrarenal vessels. It was shown that there is mTOR activation here, and then patients receiving transplantation on sirolimus did better compared to who did not. This was a New England Journal of Medicine paper in 2014. What is mTOR? It regulates cellular growth, proliferation, and responsible for endothelial proliferation, which is the key word here. And we have endothelial proliferation in patients with microvascular involvement. And that's the basis of this new term that we hear more and more, APL vasculopathy. More data needed. This is what we said when the table was published. There are at least 2 papers or reports of sirolimus use in APS patients. And again, can be considered in, we have few patients in severe APL nephropathy or other severe microvascular disease. Rituximab B-cell inhibition, definitely there are mouse model data to support its use. There are case reports, and many years ago, one of our pilot study for 19 patients showed that it may be helpful for some of the what we call non-criteria, or more specifically, for patients at thrombocytopenia, 50% improvement. This is livedoid vasculopathy, skin ulcers, and cognitive dysfunction. We did not notice any change in APL profile, so I don't think rituximab should be used to decrease the APL for, like, you know, sometimes I hear before the surgeries it's used, but still it may be effective for microvascular disease. And the last point is about the complement inhibition. I'm not going into the details of how complement inhibition can be effective based on mouse models. Eculizumab is a medication approved for complement-mediated TMA or atypical HUS, as well as PNH, which binds to C5 and blocks its cleavage into C5a and C5b. And we all have these case reports. Now, keep in mind that there's publication bias here, no systematic studies, and many of these reports actually use patients after the kidney transplantation when there's a renal rejection. And as I mentioned in these papers, eculizumab use was relatively effective when patients present with a TMA type of syndrome prominently, in addition to CAPS or without CAPS. So these are like basically when there's scary APS, we use immunosuppression more and more. We need more studies. We need new pathways. I will be happy to send you these articles if you want to read more about that. And please feel free to email or ask or call for any questions you may have. Thank you very much.
Thank you very much, Dr. Erkin, for your excellent presentation. It's really, really interesting, and was a fantastic update about the APS and everything related to it. I have a couple of questions. I'll start with a couple of questions from Dr. Ibrahim. The first question says, what's your views on what we call seronegative antiphospholipid antibody syndrome?
Okay, so we need to be very careful when we talk about seronegative APS. I think even if it's used for different concepts, seronegative APS means clinical APS symptoms with negative traditional antibodies, but there are some other non-criteria antibodies positive. Okay, not everybody thinks that that's the case. Okay, so and one position may call seronegative APS is every single APL profile or APL test negative that's available in the world. Okay, but clinically they think it's APS. So then the question becomes, what's my view on these non-criteria APL tests? Okay, so non-criteria APL tests, yes, there is one or two which is more promising than others, but they need to be studied better in well-defined populations from a clinical point of view. For example, the lady that I gave as an example with central retinal vein occlusion, I mean, she should not be in a study, okay? And we need to better understand how they add to the diagnosis while looking at the levels and titers and persistent, everything so carefully. So my view is, without getting into the full 1 hour details, we need to be very careful. We are in a world that we are trying to define what APS is and what are the importance of IgM or low titer IgG. So you need to be very careful to call it seronegative APS. Independent of what you call it, as a physician, you need to do what is the best for the patient. So you need to treat the patient with anticoagulation if needed. What you call it, it's basically based on what you think. I do not use the term seronegative APS.
I can see you mainly focus on IgM and IgG, but there is some data about the IgA as well. And do you think if we face some of these seronegative, we should test for IgA? And do you think if we got somebody with antiphospholipid syndrome-like features with IgA antibodies, would you consider that as a positive antibody?
So again, I think there are two discussions, and we should never mix these discussions. One of them is for research. The other one is for clinical practice. Okay, so I read these things that IgM is important in this cohort. It should be part of classification criteria. These are like two separate issues. Yes, I have very high titer IgA patients, and mostly with other risk factors too. Do I do something different for them? I mean, not really. They are on anticoagulation. But if it's the IgA, the way I assess that patient is really different than the way I assess triple high titer positive patient. I'm just trying to be careful all the time. And if they have other risk factors in the setting of IgA, which is very controversial, actually, yes, there are studies supporting that IgA can be important, but there are studies showing that IgA is not important.
So would you test for it?
I have to test it because it's part of the panel, and IgA is positive. I don't deny it. IgA is also more positive in lupus patients, but does it add anything? It's isolated IgA positivity without lupus anticoagulant is extremely rare.
Okay. I have another question about the, from Dr. Ibrahim as well, about what's the mechanism of antithrombotic effect of hydroxychloroquine. As you mentioned, it might have a role in antiphospholipid.
So I have actually a lot of slides, but first of all, it has antiplatelet effect. And interestingly, like many years ago, it was used after hip surgeries to prevent prophylaxis, to prevent thrombosis. So that's one. Jacob Rands from New York basically has some studies that annexin A5, it's a protective layer. Hydroxychloroquine may interfere with that. And then, with the platelets, these antibody binding creates further receptors for platelet aggregation. So hydroxychloroquine can also bring that down. This is just some of those, but I will be happy to send some articles.
Thank you very much. I have a question from Dr. Nouran. In lupus patients with white matter changes in the brain and symptoms as amnesia and headache, is this part of microvascular symptoms of APS?
So lupus patient, microvascular changes and headache. Is it part of microvascular APS?
Yes.
I think this is a very good question. The short answer is yes, it can be, but both headache and microvascular changes are very common in general population. Migraine patients can get microvascular changes. Lupus patients can get it independent of APS. Why I said it can be part of it, I have primary APS patients, no lupus, no migraine, nothing else. They have severe cognitive dysfunction with white matter changes.
Okay. Okay, thank you.
I think that those are the type of patients.
Thank you very much. For the matter of time, I got a last question, which is from me. What level of platelets would you stop giving the anticoagulation in patient with APS-associated thrombocytopenia?
If you ask rheumatologists, it's around 50. If you ask hematologists, it's around 30 to 20. So as these patients are generally followed by all of us, around like 30, 40. Also important if they are on aspirin or not, if they have a risk of bleeding. But definitely 50 starts to make me nervous. I can go down to 30 if a hematologist is holding my hand.
Thank you very much for your time and for your excellent presentation that answers the question. That concludes this talk, and we're going to move to the next talk, so bear with us. Thank you very much, Dr. Erkan.
Bye-bye. Thank you.
Okay, so it is a pleasure to present our next speaker, Dr. Richard Silver, who completed his internal medicine residency at the University of North Carolina, Chapel Hill, followed by a clinical fellowship in pediatric rheumatology with Dr. Barbara Ansell in London, UK. Dr. Silver then completed a fellowship in rheumatology with Dr. Nathan Weiler at the University of California, San Diego. In 1981, Dr. Silver was invited by Professor Carwell Leroy to join the faculty of Medical University of South Carolina. He succeeded Dr. Leroy as director of the Division of Rheumatology and Immunology in 1995, serving in that role until 2018. Dr. Silver's research interests include pathogenesis and treatment of scleroderma and interstitial lung disease, as well as environmental exposures and the risk of systemic sclerosis. He has trained many fellows in rheumatology, and he is going to talk to us about
evaluation and treatment of systemic sclerosis, ILD, in a new decade. So the floor is yours, Dr. Silver.
Thank you, Dr. Ibrahim, and want to thank the organizers of this conference for kindly inviting me to speak. I regret that I couldn't come to Dubai, but I hope in the post-pandemic era we can all meet together in Dubai, a city that I very much would like to visit. So let me start out by saying I've been at the Medical University of South Carolina now for 4 decades. And as you know, we are a scleroderma center, so I've seen many patients with scleroderma and seen many changes in terms of management, beginning with the introduction of captopril, which made a huge impact in terms of the management of scleroderma renal crisis. And now I believe that we're on the cusp of a new era in this decade where antifibrotic agents may become a very important part of our toolkit for treating these patients with ILD. These are my disclosures. And in addition, I would say that I am going to discuss some drugs that are not FDA approved for the management of scleroderma interstitial lung disease. These are some of the references I would refer you to. These are fairly recent review papers by leaders in the field, which would, I think, give you some insight in terms of how we approach the patient with scleroderma ILD. And these are my learning objectives, which briefly are to discuss the diagnosis and provide an algorithm for who and when to treat. And I refer back to one of my mentors from my fellowship years, Dr. Nathan Zweifler, who said, you can't treat it if you can't diagnose it. So we will spend a little bit of time talking about the diagnosis before we get into the treatment. And my other objective is to review the design and outcomes of the major randomized controlled trials for systemic sclerosis ILD. And I base this on a quote from a British author who said, if you do not know where you come from, then you don't know where you are. And if you don't know where you are, then you don't know where you're going. And if you don't know where you're going, you're probably going wrong. So we need to know where we've been and where we are now if we're going to then figure out where we're going to go from here. So I borrowed this slide and modified it somewhat from Dr. Metzger at University of Pittsburgh. And it shows on the y-axis the skin thickness and on the x-axis time. And it illustrates the 2 different trajectories of patients with either limited cutaneous systemic sclerosis, shown in the light blue here at the bottom, as compared to those with diffuse cutaneous systemic sclerosis in the red. And you see, of course, the patients with the diffuse form have a very high skin score that plateaus in the first few years of disease and then may begin to recede even without treatment. That's the natural history of the disease. Whereas patients with the limited form of disease have a much slower trajectory in terms of skin thickness. And ILD can occur in either subset. There is a misconception among some people that patients with the limited form, or what used to be called CREST syndrome, do not get ILD. They certainly may get ILD. It tends to be milder in general and may occur a little bit later than in the patients with the diffuse form of disease. But those patients with diffuse systemic sclerosis may get ILD early in the course of their disease, and it can, of course, be quite severe, and now is, of course, the leading cause of death among patients with scleroderma. So we really should suspect ILD and look for it in all of our scleroderma patients. And this is an algorithmic approach, which seems logical to me, which I would recommend to you when you're evaluating any new patient with scleroderma. So you want to take a careful history particularly in terms of the lungs, inquiring about cough or breathlessness. You also want to find out about any occupational or other types of exposures which could contribute to cough or dyspnea. On physical examination, of course, you're listening for those bibasilar inspiratory crackles that are typical of patients with restrictive lung disease. Autoantibody testing is essential and can help identify some patients who are at highest risk for scleroderma ILD, particularly those who test positive for SCL70 or topoisomerase 1. And pulmonary function testing and HRCT chest scans are essential in the evaluation of every new patient with scleroderma. I'll show you in a moment, but the spirometry is usually typical of a restrictive pattern with a low DLCO. And we'll talk a little bit about the CT scan as well. So if in this evaluation you find radiographic evidence on CT scan for interstitial lung disease, and the patient has symptoms, dyspnea or cough that cannot be explained by another cause, that is enough evidence to treat that patient for their ILD. If there is if there's radiographic evidence for ILD but no symptoms such as dyspnea or cough, but the forced vital capacity is less than 70% predicted, we know from many studies that these patients are at high risk for progression, and that alone is enough evidence to treat those patients for their ILD. If there is some radiographic evidence of ILD, but no symptoms attributable to the ILD, and the forced vital capacity is greater than or equal to 70% predicted, then these patients may not require treatment, but they do require close evaluation with PFTs and exams every 3 to 6 months, particularly early in the course of their disease. And should they develop a significant or sustained decline in FVC or show radiographic progression of ILD on follow-up CT scans, then these patients, of course, would be those who we also would want to treat. So who do we treat, when do we treat, and how do we treat? So the who, this is a patient of mine, a 48-year-old male who presents with dyspnea on exertion for 12 months. He's referred to the rheumatologist and noted also to have Raynaud's phenomenon, symptoms of gastroesophageal reflux, and he's found to have skin tightness. The ANA is positive at 1 to 640, and the SCL70 antibody is positive. So this patient illustrates a number of risk factors for scleroderma ILD. We know that although scleroderma is more common in females than in males, that males tend to have a more severe course, particularly in terms of interstitial lung disease. So this is a male patient who's already had symptoms for a year. He has diffuse disease, and he has SCL70 antibodies, another risk factor for scleroderma ILD. So this patient certainly warrants high suspicion for ILD and the need for further evaluation. So spirometry was done on this patient, and although his forced vital capacity is not terribly low, it's 73% predicted, his diffusion is also low at 65% predicted, and it does tend to correct when adjusted for the alveolar volume, which would suggest that the low DLCO is due to a restrictive matter rather than a pulmonary vascular matter. And in fact, his baseline CT scan, as shown on the left here, shows ground glass opacification and some reticulation and traction bronchiectasis here, all consistent with scleroderma ILD. The radiologist will normally read this as an NSIP pattern, nonspecific interstitial pneumonitis pattern, which is the pattern seen most commonly in patients with CTD ILD, but in some patients, a UIP pattern may be seen. So this is exactly the type of patient that one would want to treat, even though the forced vital capacity is not terribly low. It's still probably lower than it was a year prior if you had access to spirometry at that time. So when we've made the decision to treat, then the next question arises, how do we treat it? And historically, I think these are two of the most important studies that one should be familiar with. This is scleroderma lung study 1, which was published 15 years ago in the New England Journal of Medicine. And at the bottom, scleroderma lung 2, which was published 10 years later in Lancet Respiratory Medicine. So let's just go through these studies to hit the highlights so that we know where we've been and where we are now. So this was scleroderma lung study 1, where patients were selected on the basis of symptoms, that is dyspnea and cough, and they had to have some evidence either by bronchoalveolar lavage or by CT scan of interstitial lung disease with increased neutrophils or ground glass opacification on the CT scan. And they were randomly assigned to get daily oral cyclophosphamide or placebo for 1 year, and then they were followed for an additional year off of therapy. I'm going to show you the frequency distribution of these patients in SLS1. So anything above this line in the middle is an improvement. Anything below is worsening of the forced vital capacity. The cyclophosphamide treated patients on the left and the placebo treated patients on the right. So you can see in those patients who received cyclophosphamide compared to placebo, they were more likely to have an improvement in their forced vital capacity, and the magnitude of the improvement is shown here. And you can see that it was modest, but in some patients it was quite robust. Conversely, those patients who received placebo were more likely to worsen compared to those patients who received cyclophosphamide. So this study, SLS1, met its primary endpoint and showed that treatment with daily oral cyclophosphamide for 1 year improved the forced vital capacity by several percentage points, and the difference between that and placebo was statistically significant. There were a number of secondary endpoints which also supported a role for cyclophosphamide in these patients. So, for example, the total lung capacity improved significantly. The dyspnea score improved significantly. In those patients who had diffuse skin disease, the skin score improved in the cyclophosphamide group compared to this placebo group. And a number of different measures of quality of life also tended to favor the cyclophosphamide-treated patients. As I said, these patients were treated for 1 year and then followed for another year off of treatment. So this is the course of the forced vital capacity percent predicted over time. The primary endpoint, which was met, was at 12 months. And you can see here that the patients on cyclophosphamide in the open circles had a significantly improved FVC compared to those treated with placebo in the closed circles. They then were off therapy and followed for another year. And these curves tended to separate even more up to 18 months, where the cyclophosphamide patients were significantly better in terms of FVC than the placebo-treated patients. But this effect collapsed by 24 months. So 12 months after stopping cyclophosphamide, the patients were back to where they started. And so this would suggest that treatment is required for greater than 12 months with cyclophosphamide, and therein lies the problem, because cyclophosphamide, as you know, can be very toxic when used for long periods of time. This then led to scleroderma lung study 2, which had no placebo arm, but had 2 arms. One was treatment with mycophenolate mofetil or CellCept for 24 months. The other arm was treatment with cyclophosphamide for 12 months, and then placebo for another 12 months. And these patients were seen at every 3-month intervals, where they were assessed in terms of their lung function, and quality of life. And the results of SLS2 are shown here on the left, mycophenolate in the blue, cyclophosphamide in the red, and you can see that both treatment groups at 12 months and even at 24 months were very similar. Both of them showed a slight and statistically significant improvement in forced vital capacity, and there was really no difference between 1 year of cyclophosphamide or 2 years of mycophenolate. I think the most striking finding from SLS2 is shown on the right, and this is a curve showing the survival probability, not the survival of the patient, but the ability to stay on medication. And in the dashed lines, you see patients on mycophenolate. The solid dark line is patients on cyclophosphamide. And you can see that patients were able to tolerate mycophenolate for longer periods of time due to fewer side effects. And based on this and other studies, mycophenolate has really become pretty much the standard of care as initial treatment for patients with scleroderma ILD. The next big advance came just a year or so ago, which was the publication of the CENSIS trial. CENSIS stands for Safety and Efficacy of Nintedanib in Systemic Sclerosis. Nintedanib is a tyrosine kinase inhibitor that was approved by the FDA for the treatment of patients with idiopathic pulmonary fibrosis about 5 or 6 years ago, along with another antifibrotic drug, pirfenidone, which was approved at the same time, also for patients with IPF. The CENSIS trial was designed to look at this antifibrotic agent, nintedanib, in patients with systemic sclerosis, and the results were published late 2019 in the New England Journal of Medicine. This was a very ambitious study. In fact, this is the largest randomized controlled trial ever performed in patients with systemic sclerosis. And you can see that there were over 280 patients in each arm, nintedanib for 1 year versus placebo for 1 year. The groups were well matched to one another. And I would just point out this factor here at the bottom of this table. About 50% of the patients in each arm were receiving an immunosuppressive background medication, most often mycophenolate, and in some cases methotrexate. And these are data from that New England Journal of Medicine paper, which led to the FDA approval of nintedanib for the treatment of patients with scleroderma ILD. So the primary endpoint was the annual rate of decline in forced vital capacity at 1 year. You can see in the dark blue, this is the rate of decline in FVC in those patients receiving nintedanib compared to these patients, the light blue bar, those patients on placebo. And you can see that that the patients on nintedanib had a slower decline in FVC compared to those on placebo, the difference being about 41 milliliters in the first year. The graph on your right shows the course over time. And so the dark blue, again, is the patients receiving nintedanib. The light blue, the patients on placebo. And you can see after beginning around 6 weeks to 12 weeks, the curves begin to separate. And those on nintedanib have a much slower rate of decline in FVC over 1 year compared to those on placebo. Now, as I mentioned, about half the patients were on mycophenolate. And so when you look at patients who were on mycophenolate compared to those who were not on mycophenolate, the difference, the decline in forced vital capacity was less, which in those patients on mycophenolate, which again is evidence supporting the conclusion from the SLS2 study that mycophenolate is effective in treating scleroderma ILD. But even in patients on mycophenolate as background therapy, if nintedanib was added to their regimen, it did tend to slow the rate of decline in forced vital capacity at 1 year. I think it's important, rheumatologists are very familiar with using mycophenolate and cyclophosphamide and less often familiar with nintedanib, as opposed to our pulmonary colleagues who've been using it for 5 or 6 years now. But the most common adverse events or GI effects, so 75% of the patients on nintedanib had diarrhea, about a third of them had nausea, and about 10 or 12% of the patients had significant weight loss, which can, in some of these patients, limit the use of this particular antifibrotic agent. But again, this was a very important clinical trial, which led to the FDA approval of nintedanib as another agent in our arsenal in treating patients with scleroderma ILD. Now, scleroderma lung study 3 is currently underway. It has been hampered, like many clinical trials, because of the pandemic. So enrollment has stopped. We will not get to the planned enrollment of 75 patients in 2 arms. But SLS3 is designed to look at mycophenolate alone or mycophenolate plus pirfenidone, the other antifibrotic agent approved for IPF, as combination therapy up front. We're not going to get to this robust number of patients, but hopefully with the number of patients already randomized to each arm, we'll receive some meaningful information about whether upfront combination therapy of mycophenolate plus pirfenidone will be more effective than mycophenolate alone. There are other treatment considerations that have not been studied as robustly as cyclophosphamide and mycophenolate and nintedanib, and these include rituximab and tocilizumab. So there are a number of clinical trials, not clinical trials, but case reports and small case series suggesting that rituximab may be effective even in patients who fail cyclophosphamide. But a much larger observational study from the USTAR group looking at patients receiving rituximab in various European countries did not find a significant effect of rituximab for scleroderma ILD. This is, again, just an observational study, and I would say that we desperately need a large randomized controlled trial before we can say one way or another where rituximab fits. And similarly with tocilizumab, in the recently published Fascinate study, where tocilizumab failed to reach its primary endpoint, which was skin score, there was a suggestion that those patients who received tocilizumab had a stabilization of their lung function. So we don't have strong data for either rituximab or tocilizumab. We definitely need more studies of these 2 agents. And then other treatment considerations, which I'll mention only briefly. There's stem cell transplantation, so autologous hematopoietic stem cell transplantation, which is used in some patients with severe scleroderma. The Scott study, which was published in the New England Journal of Medicine 2 or 3 years ago, did support stem cell therapy for patients with severe scleroderma, including some with ILD, where there was improvement in lung function. Lung transplantation, unfortunately, is not a very feasible treatment for most of our patients, in part because of the lack of organs and also due to the fact that many transplant centers will not consider scleroderma patients due to the systemic nature of their disease, and in particular due to the severity of gastroesophageal reflux. And then adjunctive measures are always important. We want to minimize reflux. We want to immunize our patients, certainly for influenza and pneumococcal disease, and now for COVID, supplemental oxygen. And another very important point would be pulmonary rehab for patients, and this can be very helpful. So this is the treatment paradigm now. This is not a treatment guideline that's been approved by any body of rheumatologists or pulmonologists, but I think it's just one way to think about how you approach treatment. So once you've made the decision to treat scleroderma ILD, you could choose monotherapy. And if the CT scan shows ground glass opacification with or without fibrosis, you would probably opt for an immunosuppressive therapy, most likely mycophenolate. If, however, the CT scan showed no ground glass, but more fibrotic changes, then you might elect to choose nintedanib. If they respond to either of these, you follow them every 3 to 6 months. If their disease progresses, you might add mycophenolate to nintedanib or nintedanib to mycophenolate. Another way that hopefully SLS3 is going to answer this question, but another way to approach some patients with scleroderma ILD might be upfront combination therapy with an immunosuppressive agent as well as an antifibrotic agent such as nintedanib. And if they respond well to this therapy, you continue to monitor them. If they progress despite this therapy, then you consider putting them in a clinical trial if they might satisfy the inclusion and exclusion criteria. You might consider rituximab or tocilizumab with the caveat that I mentioned before, that these haven't been studied as robustly as other medications. They may be a candidate for stem cell transplantation or lung transplantation. And sadly, some patients will either not be a candidate for one of these other studies or fail these other treatments, and then they would require palliative care.
I think, Dr. Silver, we're running out of time.
All right, so I will just put this slide up quickly.
Okay.
This is where we're going now. And I'll be happy to provide these slides as a PDF if anybody would want them. And I'm happy to answer any questions.
Yeah, thank you very much. I think we have time only for 2 questions. And the first question, is there any role of colchicine? Sorry.
So colchicine, I don't know at this point for a role for colchicine. I know many years ago, 50 years, 60 years ago, colchicine was used as an antifibrotic agent. I have not seen any more recent data on that, and it's generally not used.
And just one comment, I think it's not a question, but placebo in interstitial lung disease, how ethical is that? Just a comment.
I'm sorry, what was the question?
Placebo in ILD study, how
Yes.
ethical is that?
Well, now it is not ethical. When SLS1, the placebo-controlled trial, was designed, there was no treatment for scleroderma ILD, and it was believed to be ethical at that time. But once we had the data from SLS1 showing that we had a drug that was somewhat effective, cyclophosphamide, then all subsequent studies have been non-placebo controlled trials.
Thank you very much. And because of the time, I think we'll just move to the next speaker. Thank you very much.
All right, and thank you. And if you would like my slides, just send me an email. I'll be happy to provide them.
Well done. Thank you. Thank you.
Well, thank you very much for staying with us. Next, we have one of the leaders in the COVID-19 research and work. Today, we have Professor Dan Barak from Beth Israel Deaconess Medical Center in Harvard Medical School. Professor Barak has received his PhD in immunology from Oxford University and his MD from Harvard Medical School. He's currently the William Bosworth Castle Professor of Medicine and professor of immunology at Harvard Medical School. He's a director of the Center for Virology and Vaccine Research at Beth Israel Deaconess Medical Center. He's a member of the Reagan Institute of MGH and MIT, and his laboratory and Harvard, and part of the Bill and Melinda Gates Foundation collaboration for AIDS vaccine discovery. His laboratory focus on studying the immunology and virology of HIV-1 infection and developing novel vaccine and eradication strategies. His group has also applied their vaccine expertise to preclinical and clinical studies of other infectious diseases of global significance, such as Zika virus, tuberculosis, and most recently, SARS-CoV-2, sorry. Welcome very much. Welcome today. And today, Prof. Barak is going to speak about developing, deploying, and distributing COVID-19 vaccines and about the challenges and opportunities for rheumatology patients. And here the floor is yours, Professor.
Thank you very much. It's a pleasure to be here. I'm glad I can join you today. So first, I'll say that I'm not a rheumatologist. And there's not a lot to say actually yet about COVID-19 vaccines and rheumatology patients because that patient population was not included in most of the phase 3 vaccine studies. So I'm not going to have a lot to say about opportunities for rheumatologic patients except to implore the rheumatology communities to study these vaccines, and us from the immunology communities would be happy to partner with you. What I'd like to do today in the next 20 to 30 minutes is to give you an update of where we are thinking about COVID-19 vaccines in a broader sense, and also more specifically our own experiences developing or helping to develop one of the, I would say, many COVID-19 vaccines that are now close to approval. So our involvement with SARS-CoV-2 started on January 10th of last year with the sequencing of the SARS-CoV-2 virus by the Chinese researchers. And on that day, I recall news articles showing that from Wuhan, China, there were reports of approximately 41 cases and 1 person died. Just think of it, a year ago, 41 cases and 1 death. Now we have over 100 million cases and over 2 million deaths. Truly astonishing how this virus can spread through the world and impact each and every one of our lives personally and professionally. So during the SARS-CoV-2 pandemic, the WHO estimates that there are over 200 vaccine candidates under development, which is a truly astonishing response from the scientific and vaccinology community. These span all the platforms, DNA, RNA, protein, vectors, and activated viruses. The timeline to show clinical efficacy is not the most relevant timeline, in my opinion. The most relevant timeline is the timeline to produce and deploy billions of doses of vaccine worldwide. Clearly, this will have to be an international collaboration of unprecedented scope, with multiple vaccine manufacturers throughout the world all working together to provide the supply needed for the world. In the United States, the first vaccines that reached approval were the RNA vaccines from Pfizer and Moderna. And of course, there's an inactivated virus vaccine. There's the adenovirus vaccine in Russia and the ChAd-Ox vaccine in the UK and Brazil as well. The RNA vaccines are being rolled out in the US under emergency use authorization, and we hope that additional vaccines will become available soon. These are the 5 vaccine programs in the United States. There's approximately 12 throughout the world. These are the 5 in the United States: the Moderna and Pfizer RNA vaccines, the AstraZeneca ChAd-Ox1 vaccine, the J&J Ad26 vaccine, which is the vaccine that our group participated in the development of, and I'll talk more about, and the Novavax protein-based vaccine. So we started our research on SARS-CoV-2 in the early part of 2020 by asking some basic research questions that we thought would be relevant for vaccine development, really for all vaccine programs. So first, is there natural protective immunity? Will individuals who recover from COVID-19 be protected against re-exposure? And second, is there vaccine-induced immunity? And if so, what are the immune correlates of protection? These are clinical questions that are being addressed in large-scale clinical trials. In the spring of 2020, we started to adjust these questions in a proof of concept fashion, and we developed the rhesus macaque model of SARS-CoV-2 infection to help answer some of these questions quickly. The initial data for these questions we published in a pair of papers last May, and I'm just going to show you one slide from each of these two papers. In the first paper, we developed a rhesus macaque model of SARS-CoV-2 infection. We inoculated 9 monkeys by the intranasal and intratracheal routes with SARS-CoV-2. And here on the first graph, we show viral loads in the lung that peak on day 2 and then generally are resolved by about 2 to 3 weeks. Well, the experiment that we did was then a re-challenge experiment. We re-inoculated these animals with a second dose of the virus and showed that there was very robust protection following re-challenge. And this is one of the first examples of natural protective immunity. In our first vaccine study, which was published very early on, we used not the vaccine that we took into clinical trials, but rather a prototype DNA vaccine that we used essentially as a research tool to get a sense as to what protection might look like. And one of the most important early results from last spring is that we showed that the antibody titers induced by the vaccine inversely correlate with peak viral loads in bronchoalveolar lavage and nasal swabs. And we reasoned that if a simple serologic correlate, such as a neutralizing titer, could be a correlate of protection, and if it were cross-platform, and ideally if it also were present in humans, then it could be a very powerful tool, not just for our vaccine program, but for all the vaccine programs throughout the world. So the vaccine candidate that we helped develop was based on a replication incompetent common cold virus called adenovirus serotype 26. We initially cloned and vectorized this this serotype of adenovirus in 2003 to 2007. And it was part of not a coronavirus research program, but rather our HIV research program, in which we were searching back about 15 years ago, we were searching for new vaccine technologies and helping to develop new vaccine technologies. So the Ad26 vector was actually constructed as part of our HIV vaccine program way back when. And our HIV vaccine program involving Ad26 is still ongoing after about 16 years of work. And right now, the Ad26 HIV vaccine is still in efficacy trials worldwide. We then applied Ad26 to our first pandemic experience in 2016 with Zika virus. And for Zika virus, we show that Ad26 raised neutralizing titers in monkeys after a single shot that were protective, which was really quite surprising for us. So we did this clinical trial shown here. These data will be published in the next few weeks, in which we looked at the Ad26 Zika virus vector together with our industry partner at Johnson & Johnson. And we looked at a low dose and a high dose version of this vaccine and a single shot or a 2-shot version. What we saw is that a single shot of this vaccine raised neutralizing antibody titers in essentially all participants. Individuals that got a single shot vaccine had essentially stable antibody titers for over a year. And for individuals who got boosted on day 57, these did increase by about a log. So what we learned from the Ad26 Zika experience is that this vector for a well-behaved virus like Zika virus raises neutralizing titers with a single shot. These are durable, and they're also boostable with a second shot. So in January of last year, we decided to pursue an Ad26-based COVID-19 vaccine, really because of our experience with Ad26 vaccine vectors for HIV and Zika. And our industry partner at J&J also developed a very effective Ad26 Ebola virus vaccine and also an Ad26 RSV vaccine. Pre-pandemic, Ad26 vaccine vectors have proven to be safe and immunogenic in over 110,000 people. J&J obtained regulatory approval for their Ad26 Ebola vaccine in Europe. And also through that program, they developed or they demonstrated mass production capacity and global distribution feasibility. In particular, they developed formulations that did not require freezing and that could be kept essentially in a simple refrigerator in liquid form to be stable for many months. And that was necessary because the Ad26 Ebola vaccine was then distributed in Central Africa. Also, with the Ad26 RSV vaccine, there's pediatric experience down to babies 6 months of age. So we think that if the Ad26 COVID vaccine is approved for adults, it should be relatively straightforward to age de-escalate into pediatric populations. So we thought that the Ad26-based COVID vaccine could offer globally the potential for a single shot vaccine with no frozen cold chain, which we hypothesize would be relevant and straightforward for a vaccine rollout. So this is what we did. On January 10th of last year, the Chinese researchers released the sequence of the virus. We started working on it essentially that same day. And we looked analytically at the sequences over the weekend. So on Monday, January 13th, when we were back in the lab, we were ready to start producing synthetic genes and actually designing and constructing prototype vaccine constructs. By the end of January, we signed a collaboration agreement with J&J, with whom we work very effectively for Ad26-based vaccines for HIV and Zika and other pathogens. In February, we started to immunize mice and rhesus macaques with prototype vaccine constructs. And by the end of February, we had produced a viral challenge stock. So in early March, we could start to establish small and large animal models of disease. We established the Syrian golden hamster for small animal models and macaques for large animal models of disease. By the end of May, we published our first data on natural and vaccine immunity in non-human primates that I showed you. By the end of July, we started our phase 1/2 clinical trials, and we published the protective efficacy of Ad26 vaccines in non-human primates. Less than 2 months later, on September 21st, is when we initiated our single-shot phase 3 clinical trial with J&J and the NIH. And on November 16th, we started a second phase 3 study to test a 2-shot version of this vaccine. And the exciting news just last week on Friday, so a week ago today, J&J released the interim safety and efficacy data for this vaccine. And last night, actually, last night, J&J submitted for emergency use authorization to the US FDA. If approved, then J&J has a commitment to produce and deploy 1 billion doses of this vaccine with a global focus all throughout the world during this calendar year. So I will show just a few slides from our paper from July, in which we showed that a single shot Ad26 vaccine protects against SARS-CoV-2 and rhesus macaques. We produced not 1, but 7 different versions of this vaccine together with our Janssen colleagues. I'm not going to go through all of these, but I'm just going to show you, I'm just going to concentrate on the last one because that ended up being the clinical vaccine. We call it in this paper S.pp construct. It's a wild type leader sequence, a full length spike, a furin cleavage site mutation, and a diproline stabilizing motif. The study we did involved 52 rhesus macaques, mixed gender. We did a single shot vaccination at week 0 with 10 to the 11th viral particles of Ad26 vectors expressing 1 of 7 of the spike protein variants, and sham controls. And at week 6, we did a challenge with 10 to the 5 TCID50 of SARS-CoV-2 by the intranasal and intratracheal routes. These are neutralizing titers in the monkeys following immunization. And by week 4, all the vaccines were immunogenic, but the SPP vaccine gave the most robust neutralizing antibody titers and was therefore selected for clinical development. Following challenge, we saw robust virus replication here in the bronchoalveolar lavage in the sham control animals, and there was complete protection in the SPP vaccinated group shown here. The other 6 vaccines in this study also did relatively well with 0 to 2 breakthroughs per group, but I think you'll appreciate that the breakthroughs, even in these suboptimal vaccine constructs, were lower in magnitude and shorter in duration than the controls. In the upper respiratory tract, we looked at nasal swabs. There was robust virus replication in the sham control group in nasal swabs that lasted about 10 to 14 days. In the SPP vaccinated group, 5 out of 6 monkeys had no virus and 1 animal had a low blip of virus. The other 6 vaccine groups showed intermediate protection with 1 to 3 breakthroughs per group. And you'll notice that the breakthroughs are generally higher and more prolonged in the upper respiratory tract compared with the lower respiratory tract. So we also looked at immune correlates of protection in this study, and we were able to reproduce the immune correlates that we saw with the earlier DNA vaccine study, in that the neutralizing antibody titer induced by the vaccines inversely correlated with peak viral loads here in the bronchoalveolar lavage, and similar data that's shown in the paper into nasal swabs. So we were really able to reproduce the immune correlates now with a second platform. So this study shows that a single shot Ad26 vaccine resulted in complete protection in the lung and near complete protection in the upper respiratory tract. We reasoned that a single shot vaccine would have major advantages over a two-shot vaccine for mass immunization and pandemic control. However, we also reasoned that a second shot of this vaccine would likely, and we know, would increase neutralizing antibody titers substantially. So we thought clinically we should test both a single shot and a two-shot version of this vaccine. We also showed that neutralizing titers were the strongest correlative protection, consistent with our prior DNA vaccine study. And so the development plans for the Ad26 SPP vaccine, first it was renamed for clinical development Ad26-CoV2S. So this is what you'll see in clinical development reports. Phase 1/2 studies were started on July 22nd in 1,000 individuals. And the first single shot phase 3 study was initiated on September 21st in 45,000 individuals. So I'll review briefly the clinical data, and then hopefully there'll be time for some questions. So we reported a first look at the clinical data back in September in medRxiv at the start of the phase 3 trial. And a more fleshed out version of the phase 1/2 studies were published several weeks ago for Ad26-CoV2S. Here we show the binding antibodies by ELISA. The design of this study was a randomized, double-blind, placebo-controlled clinical trial that involved 5 groups. The first group were placebos. The second group had a low dose of the vaccine, 5 times 10 to the 10th viral particles, as a single shot or a two-shot vaccine, or a higher dose, twofold higher, 1 times 10 to the 11th, as a single shot or a two-shot version of this vaccine. A few individuals at baseline were seropositive. We think these are individuals who were probably infected during the spring surge. But virtually all individuals were seropositive by day 29. So a single shot of this vaccine raised binding antibodies in essentially almost all individuals by day 29. And this actually went up slightly to include really all individuals at week 57, at day 57. The 2 groups that did receive a boost, here shown in the dark green and the dark blue, who received a boost at day 57 had a 3 to 4-fold increase in the titers. So if you look at the summary plots here, then a single shot of the vaccine raised binding antibodies in nearly everyone. For the single shot vaccine recipients, these were stable or even increased slightly from day 29 to day 57 to day 71. And for the individuals that did receive a boost, there was an increase of about 3 to 4-fold post-boost. Cohort 3 was an identical cohort to cohort 1A in this study, except involved elderly individuals over 65 years old. And we showed that elderly individuals had antibody responses that were really very similar to younger individuals. These are neutralizing titers in the same study, and you can see a very similar pattern. Nearly everyone raised a neutralizing antibody titer after a single shot vaccine. For the individuals that received a single shot vaccine, shown in the light blue and light green, these were stable or increasing slightly over 10 weeks. And for the individuals that received a boost, these increased about 3 to 4-fold between the day of boost and 2 weeks later. Similar neutralizing titers were seen in elderly individuals as younger individuals. So the phase 3 study, we had 2 phase 3 studies. The one that just read out is a single shot phase 3 study, and the one that's still ongoing is the 2-shot phase 3 study. So COVE3001 is a phase 3 randomized double-blind placebo-controlled trial to test the efficacy and safety of Ad26-CoV2S. It was fully enrolled with approximately 44,000 individuals in December. There was a 1-to-1 vaccine placebo randomization, and this tested a single shot version of this vaccine, 5 times 10 to the 10th viral particles. Critically, the study was done as an international study with substantial enrollment in 3 major geographic regions: the United States, South Africa, and Latin America, including Brazil. The reason why this is so important is because, unbeknownst to us when we started the study in September, South Africa and Brazil ended up being places where there were a large circulation of resistant variants that emerged essentially around December, essentially as we started to collect efficacy endpoints. So as I'm sure people have heard in the news, we're in a very different pandemic today. There has been the clear emergence and in some case dominance of new SARS-CoV-2 variants that clearly threaten vaccine efficacy, because multiple investigators have shown a substantial reduction of neutralizing antibody titers against some of these variants, particularly the ones that originated in Brazil and the ones that originated in South Africa. There's also more transmissible, more contagious variants that likely also increase mortality and increase pathogenicity. Regardless, it's clear that the pandemic is much more complex today than it was several months ago. So particularly for a vaccine trial that specifically enrolls in regions that involve resistant variants. So the results of the phase 3 study that were announced last Friday, I think were really quite striking. The study was conducted in multiple countries at the time of the peak global surge, including in South Africa, that has 95% circulating virus, the B1351 resistant variant. So it's really a completely different type of study than studies that were conducted, say, several months ago without any complications of these variants. The efficacy results involved protection against any symptomatic infection, severe disease, and hospitalization. The protection against any symptomatic infection was 72% in the US, 66% in Latin America, and 57% in South Africa. Protection against severe disease, which we think is the most important result of the study, was 85% in all geographical regions, including really no decrement of protection in South Africa, which we found to be astonishing and a very interesting result. So this vaccine, single shot vaccine, provided 89% protection against severe disease in South Africa, despite the fact that virtually all the viruses in South Africa are the antibody resistant variants. Also, there was 100% protection against hospitalization and death. So there was moderately good protection against mild and moderate disease and outstanding protection against severe disease, hospitalization, and death. The second phase 3 study that's ongoing now is still enrolling. The target enrollment is 30,000, a 1-to-1 vaccine placebo randomization, and this is testing a 2-shot version of this vaccine, the same vaccine given at weeks 0 and 8. And this study is being conducted in multiple countries throughout the world, shown below. So the current status of Ad26-CoV-2S, we've demonstrated safety and efficacy in a global phase 3 study, including in a very challenging geography of US, Latin America, and South Africa. I don't think that any a vaccine study has been conducted simultaneously in these 3 areas so far. High efficacy has been shown against severe disease in all regions studied, in all subgroups, demographic subgroups, including against resistant variants. Also, we believe that a single shot vaccine with no sub-zero freezing may be useful practical features to facilitate mass vaccination, not only in the US, but globally. And J&J has a very clear commitment that they're committed to providing this throughout the world on a nonprofit basis. This slide is 1 day out of date. J&J actually submitted for emergency use authorization last night. And so we hope that the FDA review will occur in the next few weeks, and they may reach a decision on this vaccine potentially by the end of the month. So I'll conclude with a few perspectives, and then I think we have time for a few minutes of questions. Vaccine development for COVID-19 is proceeding faster than for any pathogen in history. Safety and public trust are absolutely critical with vaccines. Because if we have a vaccine that's not trusted and not used, then it will fail in its mission to end the pandemic. We also feel that multiple vaccines are needed to be implemented in parallel, since we need to accelerate the vaccine rollout in the US and the world. Viral variants clearly require further study. Vaccines may need to be updated, and additional variants will likely emerge. Probably the strongest reason to accelerate the vaccine rollout throughout the world is that not only to protect the individuals and their communities, but also to help reduce the amount of virus in the world to prevent the emergence of more worrisome viral variants in the future. Because, and the solution for COVID-19 has to be a global solution, because the virus replicating unchecked anywhere threatens people everywhere. Because any region of the world that doesn't have control of the virus could be the source of the emergence of a new variant that could then reignite a pandemic throughout the world. Also, finally, there are 7 billion people in the world, and we therefore need multiple vaccines to be successful to end the pandemic. So finally, in our own country, we're still having over 100,000 cases and over 2,000 deaths per day. And so for us, our short-term future is going to be extremely challenging. But with the first effective vaccines now being deployed throughout the world, and we believe more vaccines imminently available, we feel that the midterm future looks hopeful. And the fact that globally, multiple groups throughout the world have been able to generate safe and effective COVID-19 vaccines in just a year, that's a stunning scientific accomplishment. And the ability of science to intervene in a global pandemic, and hopefully with powerful tools to combat the epidemic, we believe that makes the long-term future of our ability to use science to help global health. We believe the long-term future is very, very bright. So I'm often asked, when will the pandemic end? And of course, I can't answer that any better than any of you folks. But I do think that when historians look back on the COVID-19 pandemic, they will recall many, many terrible things. But I think they will also recall that science was a shining light, and biomedical research has been able to rapidly develop interventions that we truly hope are effective. Thank you. I'll take any questions, acknowledgements for the Ad26 vaccine studies in non-human primates. Sorry, I didn't show the adoptive transfer studies. But this is a picture of our research group at Beth Israel Deaconess Medical Center in Boston about a year and a half ago, prior to the pandemic. And we hope that with vaccines, before too long, we'll be able to congregate and take more pictures like this. Thank you all very much. There's not much to say about rheumatology patients yet, except that it's, in my view, a critical need to study all of these vaccines in rheumatology patients and to see whether different forms or different levels of immune suppression lead to different responses to the vaccine. And our hope, we're happy to partner with groups doing that. But I'll stop now and take any questions if there's time.
Thank you very much, Professor Barak, for this excellent talk that probably give us a bit of even more hope about the future of COVID-19 and how we're going to probably protect us, especially with the new variants and potential efficacy against it. I have a couple of questions from the delegates. Let's start with a couple of questions from Dr. Himira Bacha, who it seems she means about the AD26, that why not give 2 shots to boost efficacy?
So we are. So we're doing a study now, a phase 3 study, to look at the protective efficacy throughout the world of a 2-shot vaccine. We do think that a second shot will improve, what we know will improve immunogenicity and may improve protection. I think it's a question of practical feasibility versus what is scientifically optimal. So if the protection goes up minimally, then a second shot is not really worthwhile. If a second shot leads to a substantial increase in protection, then of course everyone will be getting a second shot.
Okay, excellent. I have another question about asking, some patients want to test for antibodies post-vaccination. What type of antibodies would you test or would you do?
Well, most of the clinical tests are simply binding antibodies. The vaccines certainly raise binding antibodies, but they also raise neutralizing antibodies, and they raise other functional antibodies as well. So it depends on, I guess, which tests are available. If you had at your disposal a research lab, then I would test for all of those. If you only have clinical tests available, then they're largely inadequate to monitor vaccine responses.
I have probably 2 questions, both about the same point from Dr. Abir Reed, who she asks, does the vaccine affect traditional PCR tests? And if no, which one can affect? And she has another question, same follow the first one, or probably answer it as well. Any vaccine affect PCR traditional test and make it false positive? And if yes, which one and how long does it last? So that's the same question.
Yeah, I don't believe that the vaccines should interfere with the diagnostic PCR tests. They will give a positive result for serology. They do raise antibody responses, and so they will lead to a positive serology. But they shouldn't result in a positive PCR swab tests, because the vaccines, neither the Ad26 vaccine nor any of the other vaccines, the RNA same, the Chaddox same, they're given as intramuscular shots, and the vectors, there's no replication, and so it shouldn't reach the nose. So a swab in the nose should not be positive for the virus. Also, most of the swabs don't actually, most commercial PCR tests don't actually don't actually amplify the spike protein. Most of them are concentrated more on the E or the envelope or the nucleocapsid genes, and the vaccines only include the spike protein. So for two reasons, I would be virtually 100% confident they won't lead to a false positive test. First, because the vaccine constructs themselves don't replicate and won't get to the nose. And secondly, even if they did, then they won't interfere with the PCR because the vaccines are based on spike, and most of the diagnostic testing is PCRing for envelope and nucleocapsid.
There are some anecdotes of patients who had a really mild COVID first time, and then after vaccine, they had a really severe infection that needs hospitalization and intensive care, like let's say weeks after the second dose. And this is with other types of vaccine, not yours, of course. But is that something come across to you before?
So quick clarification, do you mean they had a COVID-19 infection, or they had an adverse effect of the vaccine?
No, it's a reinfection of COVID-19. So the first infection was really mild. After the vaccine, they have reinfected, seems probably a second variant or something, and they got really severe form of infection.
That's very interesting. I'm personally not aware of those case reports. If you or the person asking the question could send them to me by email, if they're case reports or studies, I'd be very interested in reading them. Just hearing what you're saying, again, I'm not personally familiar with those cases yet. I would be happy to read about them, but I would immediately think that it might be one of the resistant variants. And I think what we'll see is that different vaccines may have different degrees of ability to handle the variants, because they do have interesting point. Why did the J&J vaccine still give very, very strong protection against severe disease in South Africa, despite the fact that neutralizing titers are vastly reduced? And we don't know the answer to that question, but I would raise a hypothesis that it could be due to CD8 T cell responses. And we know that advectors are one of the premier modalities for induction of CD8 T cell responses. So how other vaccine platforms that do not raise as robust CD8 T cell responses will fare against variants remains an open scientific question. I think there's simply no data on it, so we can't really speculate one way or another. But in the setting of variants that might specifically evade neutralizing antibodies, I do think the role of CD8 T cells will become more prominent.
Still having questions, although we are running out of time. Dr. Babin, I can ask, is there a role for revaccination with a different method at a short gap? For example, Moderna followed by GJ, etc. Like, I think this is like the British model, isn't it? That they suggested of revaccinating with different.
What's been called in the media the mix and match strategy. Scientifically, we would call it heterologous prime boost strategy. It needs to be studied. We know from 10 years of vaccinology for other pathogens that a heterologous prime boost with one platform followed by another platform, traditionally it's a vector followed by a protein, or a nucleic acid vaccine followed by a vector, or a nucleic acid vaccine followed by a protein. Those are some of the most powerful vaccine strategies we have. And for SARS-CoV-2, we're in the enviable position that virtually all the vaccines are focused on on spike, and in most cases, almost identical sequence of spike too, because everyone started with the Wuhan sequence. So it is theoretically possible that some of the best vaccine responses will be the heterologous prime boost. The problem is that none of them have been studied. So we don't know for sure the safety, reactogenicity, immunogenicity, or efficacy of any of those approaches. So that's why I think that it's a call for action for clinical trials. I know some are actually starting now to test heterologous prime boost regimens and to actually demonstrate safety and demonstrate immunogenicity. I don't think it's a great idea just to do it haphazard in millions of people in the clinic without following them, because we don't actually know about safety and efficacy of that approach yet. But I do think that short-term rapid clinical trials to generate that information would be very worthwhile.
Our last question, which is an interesting one, would you recommend a single shot to those who have been infected recently as a booster, and a double shot to those who haven't got the virus before?
So it's interesting because in our studies, we have noticed that people who have been infected previously have some of the highest responses after a single shot. And whether one shot after infection would be equivalent of 2 shots in a naive person, I think remains to be determined. I think from a regulatory perspective, it's really hard to have different indications. So from a regulatory perspective, I think the 2-shot vaccines, like the RNA and the protein vaccines, will be recommended as 2 shots regardless. The J&J vaccine is going to be recommended as a single-shot vaccine regardless. But I think things might change if we're able to show with our vaccine that 2 shots make it demonstrably better. So I guess the short answer is that makes sense, but from a regulatory perspective, it's not going to be the official indication.
Okay, thank you very much, Professor, for being with us today, and a very thought and intriguing talk today. And thanks for being with us from all the way there in America to Dubai here. And I hope you had see you again in future meetings.
Thank you very much. It was a pleasure. Appreciate it.
So it is my pleasure to introduce Professor Gossick, who is a professor of rheumatology in Sorbonne University and Petit Salpêtre Hospital, Paris, France. Professor Gossick has a half-time clinical position where she mainly sees patients with inflammatory arthritis, and a half-time teaching and research position. Her main research interests within outcomes research and epidemiological research are patients' reported outcome and quality of life, as well as e-health and big data in psoriatic arthritis, spondyloarthritis, and rheumatoid arthritis. Professor Gossick is a past chair of the Epidemiology Standing Committee of EULA. She is one of the editor of the Journal of John Boyne Spine. Professor Gossick has authored more than 350 peer-review papers. She is going to tell us, or her lecture title is "What Recent Data Guide Treatment Decisions in Psoriatic Arthritis." So the floor is yours, Professor Gossick. Welcome.
Thank you very much. Thank you for this kind introduction, and thank you for inviting me to give this talk. Now, compared to the previous talk, which was very recent information here, I've been asked to give you a talk which I gave at ACR 2020. So that's what I will do. So it won't be quite as up to date as the data we have just seen on the COVID situation. Next. So here are my disclosures. Next. And these are the objectives of this talk. We will look at the recently updated EULA recommendations for the treatment of PSA, and we will specifically look at the data which we used in the process of the recommendations and discuss the strategy trials which are available and the head-to-head trials as well. Next. So first, let's discuss the recently updated recommendations. Next. And these recommendations, next again, are published in in ARD. And the reason why we decided to update the recommendations, the previous version dated from 2015, was that we now have many drugs available for the treatment of psoriatic arthritis. And here I'm showing you the 5 main categories of disease-modifying drugs that we have. So on top of conventional synthetic drugs, we have 2 types of targeted synthetic DMARDs at the bottom, and 3 types of biologic DMARDs at the top. The most well-known one, of course, are the TNF inhibitors on the left, but we now have 2 other categories. And the drugs which I have put as italics at the bottom are drugs which are currently in development but not yet available. Next. And this slide shows you a little bit of a time frame for the development of drugs in PSA. And you can see that when we developed the 2015 recommendations, we already had the conventional synthetic drugs here on the, I think you can see my arrow maybe, maybe not, on the left part. And then we have the blue drugs, which are the biologics. And we have red drugs, which are IL-12/23 drugs. And you can see there are several other 23 drugs coming up, as well as now currently 2 green drugs, which are all 17 inhibitors, but we have 2 more coming up as well. And then we have also 1 JAK inhibitor, which is pink on the top, tofacitinib, and 2 more coming up, although the development of filgotinib has just recently been stopped in this indication. And so quite an exciting screen of drugs available or soon to be available in PSA. And in this context, we developed a 2019 update with the drugs that you see on the left of the red arrow. Next slide. So this is the updated recommendations. And I know we have Professor Smolin also on this call, who will be presenting to you very soon an update on RA and difficult to treat RA. But he was the convener of this initiative. As you see here, he's the last author. And of course, we have a very wide group of co-authors, as you can see on this slide. Next slide. So just a very brief update on these recommendations. We will look at it a little bit more in detail. But as you see, we always start with a clinical diagnosis of active psoriatic arthritis. And then next slide, you can animate this slide. We start with NSAIDs and local glucocorticoid injections, and then we move to a conventional synthetic DMARD, usually methotrexate. Next slide. And then we propose a step-up approach. You can click again, starting with biologic DMARD, which would usually be one of the biologics, either one of the 3 categories, or for predominant actual disease, then you would go to only 2 categories, the TNFs or the IL-17s, and then we move to the phase for switches. So this is what you can see on this slide, that I won't go into the detail of every one of the 2019 PSA management recommendations, but if we look as an overview of what has changed between 2015 and 2019, you can see that we have 1 more overarching principle on the left, and we now have 2 more recommendations on the right. And let's just look quickly at what has changed a little bit more in detail. Next slide. The first change that we can see is that the first-line DMARD is still a conventional synthetic DMARD in peripheral forms. So that has not changed. We decide to keep a step-up approach and keep as first-line DMARD a conventional synthetic DMARD. However, we now distinguish patients who have polyarticular disease here on the top from patients who have mono or oligoarticular disease here on the bottom. And what you see in the box is the exact phrasing of the recommendation. And what you see on the right part of the box is the level of evidence and the strength of the recommendation. So why we decided to have this distinction between polyarticular disease and mono or oligoarticular disease is that, firstly, many patients actually have mono or oligoarticular disease when they present with PSA. And we felt that it was important to address the specific subtype of PSA. And secondly, that we have some data now on the prognostic factors. And we know that the main prognostic factor for structural progression is the number of swollen joints. Therefore, it makes sense that when you have polyarticular disease, you start a conventional synthetic DMARD rapidly. And if you have mono or oligoarticular disease, your overall prognosis is a bit less severe. And in that case, you take a look at the other prognostic factors which we have listed in this slide and which are also at the bottom of the slide. And you can see that one new prognostic factor which we have found here is nail involvement. And another one which has been confirmed is dactylitis. And if you have one of these signs, you have more risk of structural progression, and you should probably start a conventional synthetic DMARD more quickly. Next slide. Then, after a conventional synthetic DMARD, we propose to go for one of the three biologic drug categories, which you see here as the colored boxes on the top. And we propose that this should be the initial proposal after conventional synthetic DMARD, rather than a targeted synthetic DMARD such as a JAK inhibitor or a targeted synthetic DMARD such as a PDE4 inhibitor. Next slide. And so this is what the phrasing looks like, that if you have inadequate response to at least one conventional synthetic DMARD, you should start with a biologic DMARD. And we now propose that any one of the three categories of biologic DMARDs, TNF inhibitors, IL-17 inhibitors, or IL-12/23 pathway, could be proposed. However, if there is relevant skin involvement, and relevant is defined as either extensive or patient important or patient relevant, such as leading to an altered quality of life, then in those cases, you would prefer an IL-12/23 or an IL-17 inhibitor. Next slide. We also propose a place for JAK inhibitors, which of course were not there in the 2015 recommendations because we did not have a JAK inhibitor with an authorization for PSA. And this is the place we propose for JAK inhibitors, that it would be for patients after at least one DMARD or when a BDMARD is not appropriate. And this would include, for example, cases where there are contraindications to a BDMARD or cases where, for example, patients do not want to have injections, and then you could consider a JAK inhibitor instead. Next slide. We have kept a place for apremilast in these recommendations, but we have detailed it a little bit more, and we propose that apremilast should be given for patients who have mild disease, which was not previously the case. This is because apremilast has not shown efficacy for structural damage. And we propose that apremilast could be given in patients for whom neither a BDMARD nor a JAK inhibitor is appropriate after a conventional synthetic DMARD. Next slide. So this is basically an overview of the main changes in the recommendations with this last recommendation, which is a new recommendation about tapering of drugs in remission. Next slide. And now let's look at the data which has allowed us to come up with these recommendations. Next slide. So in the process of EULAR recommendations, we always perform a wide literature review. And this is what was done here by Andreas Kirschbaumer from Austria. And in this systematic literature review, we looked at, as you can see here, patients with PSA who were taking any one of the drugs of interest, glucocorticoids, NSAID, conventional synthetic DMARDs, biologics, or targeted drugs. Then in the next column, you can see we looked at randomized controlled trials. And if they were not available, we looked at long-term extensions on the right only for safety. And we looked at many outcomes. And these were for publications from 2015 to 2018. Next slide. This is what the literature review showed us. We had 76 publications which were relevant, as you can see on the top. Most of them refer to efficacy or safety. We also had 11 studies specifically dealing with prognostic factors, since we wanted to update our list of prognostic factors. Very briefly, all of the trials of original drugs met their primary endpoint, which in all cases was ACR 20, and we will come back to this a bit later. Now, looking more at the detail, you can see that between 2015 and 2019, there were no new trials at all about NSAIDs, nor glucocorticoids, nor conventional synthetic DMARDs. And then we had some trials for TNF inhibitors or TNF biosimilars, several trials published for apremilast. And then in the second column, you can see quite a few trials for IL-17 inhibitors, IL-12/23 inhibitors, new drugs which are in the IL-12/23 pathway, but which address the IL-12/23 P19 subunit, and then IL-6 also, and JAK inhibitors. So that gives you a short overview of these trials. Next slide. It's very difficult to synthesize these trials because meta-analyses only allow comparisons towards placebo, and network meta-analyses have some limitations and difficulties in performance and in analysis, which means we did not perform a network meta-analysis. Here, what I'm showing you on this slide is just a brief overview of ACR 20 responses in the major randomized controlled trials. Top left is TNF inhibitor, which can be used as a sort of reference point if you want. The second column is for secukinumab. Then you can see ustekinumab on the top right. And then bottom left is apremilast. And then you have ixekizumab, which is also an IL-17 inhibitor. And then tofacitinib on the bottom right. And what I'm trying to show you with this slide is mainly the gray bar. The gray bars are placebo effects in terms of ACR 20 at the time point closest to week 24. And you can see that across trials, the placebo effect varies quite widely between 15% and 33% of placebo effect, which shows you that patients entering randomized controlled trials don't have exactly the same profile in recent studies as they had in older studies, such as the adalimumab trial on the top left, and also how difficult it is to perform direct comparisons, which indeed should not be performed when you're comparing different populations. Next drug. So what you can see here is this is the decision we took within EULAR, is after a conventional synthetic DMARD, we decided that all the biologic DMARDs could be proposed at the similar level. And this is based on the data you can see here, where, for example, the apremilast on the bottom left appears to have a smaller effect in terms of ACR 20, with all the caveats of this type of comparison. And this is one of the reasons we decided not to put apremilast at the same level as the biologics. Next slide. Then what I want to show you on this is other domains, because of course ACR 20 only addresses joints and patient-reported outcomes. It does not address skin, enthesitis, dactylitis, or radiographic damage, for example. And what was performed in the systematic literature review is we looked at the superiority compared to placebo, shown here in dark green, or a superiority without statistical difference, and so on, as you can see at the bottom. And basically, we can see that the drugs that we propose, you can click please, for use after a conventional synthetic DMARD. Next slide. Thank you. Are the three categories of drugs which you can see on the top, which all showed statistically superior efficacy compared to placebo on all of the domains of PSA. Next slide. And then what I'm showing you here are the new drugs which are coming on the market and or not yet available at least. And gray means not assessed or not reported. And you can see that these drugs have varying levels of effect according to the domain. Next slide. So when you're developing recommendations, it's also very important to look at strategy trials. Next slide. Unfortunately, in the field of PSA, to my knowledge, we only have one proper strategy trial, which is the TICOPA trial, which was published already several years ago in the Lancet by Laura Coates and colleagues. And so this is the only data we have really in terms of strategy, which is a pity because it's always difficult to develop recommendations when all you have are randomized controlled trials versus placebo. In the TICOPA trial, which I'm sure you're all aware of, this was a trial of 200 patients with early PSA who were DMARD naive. And they compared two arms, an arm which was called tight control, where patients aimed for minimal disease activity, MDA. And if they did not reach this status every month, they were pushed up in a rather complex treatment strategy. And the standard of care arm was patients who were assessed every 3 months and managed according to usual care. And what you can see on this slide is that the tight control arm here, the left column, did better than the standard of care arm. However, the difficulty is that patients who were in the tight control arm received 39% of them received a biologic versus 9 or 7% in the standard of care arm, meaning that of course, when you do a tight control study like this, what you end up doing is treating patients more in the tight control, and that's a little bit of a limitation for the interpretation of the trial. Next slide, which is shown here. Thank you. Next slide. How about head-to-head trials? When we did the recommendations, we were aware of one of the head-to-head trials, which was not yet published, but which was taken into account in our discussions. But since then, we have a second head-to-head trial. So let's look at these because these bring interesting and important information. This is the first head-to-head trial in PSA, which was the SPIRIT head-to-head trial of ixekizumab compared to adalimumab. In fact, both of the head-to-head trials in PSA use as comparator adalimumab, which is considered in a way the gold standard for PSA right now. What you see on this slide is that patients who were receiving ixekizumab here in the orange arm performed statistically better than the patients in the purple arm line, which is adalimumab, over 6 months. And of interest is the primary outcome used in this study, since Lilly, the firm who is developing and commercializing ixekizumab, chose to use an interesting and original composite outcome, which was the achievement of ACR 50, a harder outcome, of course, than ACR 20, but also a combination with a skin outcome, which is PASI 100 at week 24. Now, this is very interesting because we know from the field of psoriasis, where they have quite a few head-to-head trials, we know that both IL-17 inhibitors like ixekizumab or secukinumab, but also IL-12/23 inhibitors like ustekinumab and guselkumab perform better than adalimumab in head-to-head trials in the field of psoriasis. Therefore, using a composite outcome which includes joints but also skin, will put ixekizumab, in a favorable position. Next slide. This is the second head-to-head trial, which was published more recently in 2020. And the EXCEED trial compares again versus adalimumab, here shown in red. Sorry about changing the colors. It shows here secukinumab. And this was used with a primary outcome, which is the usual primary outcome, which is ACR 20, and this time at a longer time point, which is 1 year. And you can see that although the blue line, secukinumab, does slightly better, the statistical significance was not reached in this trial. Next slide. So this might be due also to the choice of the outcome measure, since here I'm showing you the efficacy on ACR 50 of ixekizumab on the left and of ACR 20 for secukinumab on the right. And you can see that, in fact, when we're looking only at joints with ACR 50 or 20, in fact, the outcomes are very similar using either an IL-17 inhibitor or a TNF inhibitor. So basically, these head-to-head trials do help us in a way because they show us, I mean, it's always interesting to have head-to-head information, but what they show us is that in terms of joint efficacy, it appears that the IL-17 inhibitors do quite similarly to adalimumab. And on the skin, this confirms that on the skin of psoriatic arthritis patients, IL-17 inhibitors do better than adalimumab, which confirms what we know from the field of psoriasis for patients who have psoriasis but not psoriatic arthritis. Next slide. So as you see, dear colleagues, we have a whole lot of drugs, and a whole lot of information as well, but I feel there's some very important challenges still in the field of PSA. Next slide. One of these challenges refers to the population, and indeed, currently, patients in PSA trials would not really reflect patients with PSA in our clinics. Some of these difficulties are, for example, comorbidities. We know comorbidities are very frequent in PSA, and some of these comorbidities are exclusion criteria for PSA trials. Another one relates to the disease activity, and in trials, there are usually limitations such as having at least 3 swollen and 3 tender joints, which maybe does not appear huge, three joints, but in fact, patients who are included in randomized controlled trials have around 10 to 14 swollen joints, which probably does not reflect our clinics. And then also, of course, concurrent medications or, for example, history of infectious disease or of malignancy. Next slide. And in fact, it's a real issue because in our clinics, most patients, this is what we know from some of the studies in real life, if you want, which unfortunately we still don't have enough of, but we know that most patients have the profile on the left, which is oligoarticular arthritis, whereas in clinical trials, most patients have symmetric polyarticular disease quite similar to RA. And then there's the whole issue of actual disease, which I cannot discuss at length in this talk, given the time limitations. Next slide. This is the reason why in the new EULAR 2019 recommendations, now, next slide, distinguish, as I've shown you before, the oligoarticular, can you click please? The oligoarticular disease from the polyarticular disease. Yes, can you click again, please? Thank you. Next slide. Another challenge is around outcome measures. And as I've shown you, in all the randomized controlled trials versus placebo, the primary outcome is always ACR 20. And we now have a head-to-head trial with another outcome, which is ACR 50 plus PASI 100, with the limitations of that outcome measure as well, of course. And now, of course, the ACR criteria, as we know, do not capture all the features of PSA. And for example, as you see here on the top right, we don't have dactylitis, enthesitis. We also don't have skin or nail in PSA. Next slide. But we're still working on the best outcome measure. And as you can see here, we have multiple outcome measures which assess different domains of PSA. And the multiplicity of these outcome measures show the difficulty of finding a consensus. Next slide. These are the two usually reported outcome measures which can be used to assess disease activity. On the top, the one called VLDA-MDA, which is a binary outcome, which assesses joints, skin, and disease, and patient-reported outcomes. And on the bottom, you see the only, to my knowledge, composite score, which is a continuous score, which is well validated for use in PSA, and that is DAPSA, which includes joints and patient global pain and CRP. Next slide. It's important what definition we use because in a meta-analysis, we showed that the frequency of remission here on the top or of low disease here on the bottom varies widely according to the definition that you use. So clearly, we need more consensus on what outcome measures to use. Next slide. And in our recommendation, we propose to target remission or low disease activity, as you see here. Next slide.
We have 2 minutes to finish.
And I'm finished. This is my concluding slide. So, dear colleagues, as you see, PSA is an exciting field with a growing body of available drugs and also a growing body of data on these drugs, including now 2 head-to-head trials, which I think is a great progress and which we have to integrate in our thinking, but also many challenges, including challenges on patient populations and on outcome measures. Currently, it's still difficult to define perfectly the treatment strategy, and this is also shown by the difference between the EULAR recommendations and the recently published ACR recommendations, which differ, in fact, quite widely in the approach proposed. But I hope that the EULAR 2019 recommendations will be helpful to you because they do integrate the available drugs in a graduated approach and do follow something which seems quite logical in terms of a step-up approach. Next slide. Thank you very much for your attention. I'll be happy to answer any questions.
Thank you very much. That's very informative. I think we have one question, which is, the methotrexate role in psoriatic arthritis.
That's an excellent question. And indeed was the object of quite a lot of discussion within the task force, since as you saw, we proposed still a conventional synthetic DMARD as first line for all patients with peripheral arthritis. You know, the data on methotrexate is quite poor in terms of randomized controlled trials. The only well-performed randomized controlled trial, the MIPA trial from the UK, was in fact negative for the primary outcome. However, we have data from registries and real-world evidence, if you want, showing that firstly, methotrexate is widely used, and secondly, that methotrexate has good long-term maintenance, which shows that to our mind, that methotrexate is a useful drug. We also felt within the task force that the benefit-risk ratio of moving straight into a biologic or a targeted synthetic drug for patients does not make sense as a first-line treatment. And therefore, we have kept with this rule of methotrexate as first-line treatment. But indeed, we are aware that it can be the object of discussion.
Thanks. For us as rheumatologists, I find that we do not actually concentrate on the nail changes as much as we do actually for the skin. So when somebody comes to you with a skin problem, you concentrate more on the skin than the nails. Although sometimes the nails that can be of trouble and causing a lot of problems to the patient.
Yes, that's true. I agree. I think there are two reasons for this. I guess on the one hand, being used to it and assessing systematically the nails maybe is not something that has really entered our checklist, if you want. And the other aspect is the aspect of treatment, is that not all treatments are very efficacious on the nails. It's quite difficult to clear the nails compared to clearing the skin, and it takes a lot of time as well. So I guess maybe we as rheumatologists, feel that we're already doing pretty well if we're doing skin and joints. Also, I feel that we as rheumatologists, I guess we keep our main focus on the joints anyway, because that's what we are knowledgeable about. And also we're worried about structural progression, because that would be very bad for patients. And therefore, I think that's why we don't assess the nails. Yeah. I have to say in my clinics, I always write the number of nails involved. I try to have it in my checklist, but I would not take a decision based on the nails because I don't feel that's my field of expertise as much as the joints or the skin.
Right. And when we talk about the comorbidities, shall we include them if we are assessing actually or checking the patient for low disease activity? Do you think we should, include controlled blood pressure, controlled diabetes, low uric acid, as well as the other low disease activity scores? Or
yes, absolutely. Yeah, it's very important nowadays to have a holistic approach to these inflammatory diseases. I mean, if we cure, the left wrist, but the patient has a heart attack, I don't think we'll be very happy. Right, so, right. Of course, it's now really important to take into account these risk factors. And it's, in a way, I feel it's transformed us into internists even more than we were before, because we now have to know about statins and know about aspirin and everything. But of course, that's really important. What we can do firstly is control the inflammation, because inflammation is responsible for part of the increased risk, cardiovascular risk, I mean. And then, of course, it's more of a global approach to the other risk factors. And that seems very important to me indeed.
Thank you very much, and thanks for this valuable lecture. Thank you.
Thank you very much for your invitation. It was a great pleasure.
And welcome to the last lecture of the before we go to the symposium. And I have the pleasure to introduce a very well-known rheumatologist to most of the rheumatology community, who's Professor Joseph Smolin. Everybody knows that Professor Smolin is Emeritus Professor of Medicine at the Medical University of Vienna in Austria. He received his MD degree from the University of Vienna and trained there in immunology, medicine, and rheumatology. He's an author of several hundred original publications and lead investigator of many clinical trials. His major scientific interests concern elucidation of the pathogenesis of rheumatic disease, translational research, outcomes and epidemiological research, as well as novel therapies and therapeutic strategies in rheumatic diseases. Professor Smolin served as a president of EULAR from 2003 to 2005, and he was also president of the Austrian Society of Rheumatology and Austrian Society of Immunology, and treasurer for the International Union of Immunological Societies. Professor Smolin is a member of the Austrian Academy of Science, the German Academy of Science, an honorary member of several national rheumatological societies. He's a fellow of Royal College of Physicians in London, an honorary doctor of Lund University in Sweden, and Leiden University in the Netherlands, and St. Louis University in Hungary. So it seems like we're speaking to somebody from the United Nations, Professor Smolin. He's a coordinator of the textbook Rheumatology, who probably every rheumatologist know, and he's in preparation of its 8th edition. He currently serves as editor-in-chief of Annals of Rheumatic Disease, and I think we all know what Annals of Rheumatic Disease is. So welcome, Professor Smolin. He is going to speak to us today about the refractory rheumatoid arthritis and how to deal with the COVID-19 crisis in rheumatology. Here, the floor is yours, Professor.
Thank you very much for the kind introductory words. You know, it is always up to the moderator to select what he or she wants to select from a CV. And that is obviously you selected a lot. But, you know, it really doesn't matter, except for one thing, that I'm not anymore the head of the department. That's Daniel Areta. I'm now emeritus professor of medicine at my university, and it's also a very nice situation. So thank you very much for the very kind invitation to be here with you today. I think I can speak also for Laura and others today that it would have been much nicer to be seeing you in person in the warm Emirates, and discussing with you refractory RA there. However, c'est la vie, and we will try to manage it the way that we do this since about 9 months, which is also an interesting endeavor. So here is my disclosures, and let me start by saying that since about a decade, the treat-to-target way of addressing rheumatic diseases in general and rheumatoid arthritis in particular has paved its way. It has been updated, it has been adapted for several other, and not only RA, but also spondyloarthritis and other disorders. And the main thinking behind it is that what we want to achieve for our patients with active disease, and I'm dealing with RA, is a life that is as close to normality as possible, a normal life. And a normal life can essentially best be achieved if patients get to remission. There is an alternative in patients with long-standing disease, namely low disease activity, and we get there by adapting therapy according to disease activity, using composite measures of disease activity, and adapting treatment at least every 3 months, and trying to reach this state by 6 months. Obviously, maintenance of the state is at least as important as reaching the state. Now, this concept, and Professor Gosek has very importantly supported this concept and helped this concept to be included in several recommendations. This context has been taken up by the major international organizations such as EULAR, and as you can see here, the target is to be achieved at 6 months, but improvement of at least 50% has to be seen at 3 months. And this is true for the earliest phase of treating rheumatoid arthritis, where we say start methotrexate combined with glucocorticoids. We can discuss this in a minute, but also for later phases. Because, as I said before, if you cannot reach remission, you at least have to get to low disease activity. Anything about low disease activity is unacceptable for our patients. And as EULAR proposes, when you fail the initial phase of methotrexate treatment, ideally with glucocorticoids, is to add, not to switch to, is to add a biologic or a JAK inhibitor. But if we look at the overall gestalt of the responses, and I've chosen here the ACR 70 responses because this is an approximation to low disease activity, at the overall responses in the context of clinical trials, then we can see that it is only between 20 and 30% that our patients in many of the older clinical trials can reach this situation if they have been insufficient responders to methotrexate. But if they are insufficient responders to TNF blockers or other biologics, then this is even worse. They don't get much above 20%. So overall, even in the more modern era, where we get somewhat higher response rates in the clinical trials, we can clearly state that much less than half of methotrexate insufficient responder patients and less than 1/3 of biologic DMARD insufficient responders reach the treatment target. Does this mean that these patients have become refractory? Well, you know, this is a very interesting situation because many years ago, when I was trained, and even later, when I took over my department, we didn't even dream of, oh, well, we dreamed of remission. Well, we had no patients in remission. Maybe one or the other, but this was not a general rule. And today, we are thinking about patients who are refractory to reach the state that we want them to be in. And refractory treatment resistance disease, difficult to treat RA, has become a very interesting subject of research at the present time. But let us first try to see what is refractory, what is difficult here. Well, A, it can be the presence of comorbidities, which may preclude advancement of therapy. Well, this is not refractory RA. There is other reasons why we cannot reach the treatment target. But then, more importantly even, is the lack of adherence or persistence by the patient. This, again, is not refractory RA. It is refractoriness of the patient's attitude to get to remission. And this is not infrequently due to the lack of us physicians to inform the patient sufficiently and to adhere to a shared decision. And then, equally importantly, there may be lack of adherence by the rheumatologist. The rheumatologist is refractory to attempt to treat the patient properly. Why? Rheumatologists don't do joint counts, they disregard management recommendations, including treat to target, they leave patients for long with moderate to high disease activity just because the patients have somewhat improved for long. And we see that when we look at patients who enter clinical trials today with high disease activity on methotrexate. So these patients have frequently 6, 8, 10 years of disease duration, and they had only 1 or 2 or 3 DMARDs. This is refractoriness of the rheumatologist. But then there is truly refractory disease, where despite all the adherence to treatment and treatment strategies, one cannot reach the targeted goals of remission or at least low disease activity. I mentioned before that this has become a focus of research in more recent days. And indeed, EULAR has very recently, just a few months ago, provided a definition of difficult to treat RA. A definition which is a working definition, to try to really focus on such a population in future research. This activity was informed by a survey of people, asking them what is the characteristic of a patient with RA who is difficult to treat. And as we can see here, about 50% of the people that were surveyed said, well, if a patient had 2 or more conventional synthetic DMARDs or 2 or more biological targeted synthetic DMARDs, then the patient is refractory, which I would subscribe to personally also. And then the question was, what should be the definition? And here, as you can see, 50% of the people said signs suggestive of active inflammation in a patient with a DAS28, even of low disease activity, or a patient with DAS28 more than 5.1, or presence of signs suggestive of active inflammation. Now, all this uses the DAS28. It uses another definition, which is a little bit interesting, because why do we need a dual definition? This is because the DAS28 is inappropriate to define remission and sometimes even low disease activity, especially also when you use JAK inhibitors or IL-6 receptor blockers, and we have 2 of these and 4 or 5 of these. And that's why we use the clinical disease activity index. And let me show you what I mean. Here is a group of clinical trials where I've selected DAS28 remission, ACR 70 and ACR 50. And if you look at this one here, for example, you will see that more patients fulfill DAS28 remission criteria than 50% improvement by the ACR criteria, and almost 3 times as many patients in DAS28 remission than ACR 70, where DAS28 remission should be 100% of patients, and therefore very low, 100% with 100% of improvement, and not 70% of improvement. And you can see that in all these clinical trials, there is much more in DAS28 remissions and 70% improvement. And all these studies deal with sarilumab, tocilizumab, against sarilumab, tofacitinib, they target IL-6 or IL-6 pathway. And if you don't do that, such as in the reflex trial, where rituximab is being used, you will see the truth of remission, because you will see that the same number of patients, the same proportion achieves ACR 50, the same proportion, even on the number, achieves an ACR 70, but more than 3 times as many patients on an IL-6 blocker achieve DAS28 remission than on rituximab. And this, more patients, 3 times as many patients with a 50% response than with remission, and 1.5 times more patients in ACR 70, this is something that we can grasp. But let me close here. The 20 to 60% of the patients in DAS28 remission will not even reach 70% improvement. And therefore, remission defined by DAS28 misleads clinicians, trialists, and regulators. And I think it's to a large extent the fault of regulators, especially in Europe, that this is still used, because despite the fact that this is not remission. Well, the EULAR task force actually took account of that in that they at least added the CDAI of 10 or more as signs suggestive of active progressive disease, defined as 1 or more of these 5 items. And treatment according to the EULAR recommendations for managing RA, failing at least 2 biologic or targeted synthetic DMARDs after having failed at least 1 conventional synthetic DMARD. And ultimately, management of signs and symptoms perceived as problematic by the rheumatologist or patient. Importantly, all 3 of these criteria need to be present. Now, Manuel Becerra and Daniel Aretaja tried to look, they used a slightly different definition, because this was before we did the study, before the EULAR difficult to treat RA definition came out. And as you can see, that was published a year before that. We looked at a patient's which we called refractory RA or RARA, and compared them with treatment-amenable RA or TARA. Here, patients who reached the target within 2 DMARD. Here, patients who had at least 3 DMARDs and at least one of those a biologic DMARD. So they either failed 2 conventional and 1 biologic DMARD, or at least 1 conventional and 2 biologic DMARD. And lo and behold, when we looked at these populations, we saw something devastating to us, because it seemed that the refractoriness is a consequence of longer recognition, longer start of treating RA. Time to treatment almost 3 times as much in the refractory than in the treatment-amenable RA. And consequently, these patients had also high disease activity, which overall means that there are diagnostic delays, and it's very hard to understand why this is still occurring today. And there are delays of adapting therapy with continually active disease. Why is that still occurring today? So overall, we need to reiterate the importance of rapid diagnosis, prompt DMARD initiation, and treatment to target with rapid change of therapies if the target is not reached at least within 6 months. And that's all not so easy understandable, because we have many efficacious drugs. We have 4 conventional synthetic DMARDs. We have 5 biologic modes of action. We have 5, befisitinim only in Japan, but we have 5 targeted synthetic DMARDs, and we have therapeutic strategies. So overall, in light of the many available options, continuing insufficiently effective therapies is not appropriate, and rapid switching to any one of these other agents, and we have so many, is warranted and usually not more costly, because usually it's not more costly to go from one to another biologic DMARD or targeted synthetic DMARD. So refractoriness today is not acceptable. However, we have other problems today. We have SARS-CoV-2, we have COVID-19. And so the question is, with all these therapies and with all the issues with our patients, how are we going, how should we be going around that aspect? Again, EULAR has provided provisional recommendations, and again, Professor Gosek was part of that group. And as you can see here, published last year in the Annals, as you can see here, we conclude that to date there is no evidence that patients with RMD with rheumatic and musculoskeletal diseases face more risk of contracting the coronavirus than individuals without rheumatic diseases, nor that they have worse prognosis when they contract it. And our patients who do not have suspected or confirmed COVID-19 should be advised to continue the treatment unchanged, any one of these treatments and for any aspect of their disease. And if a patient with a rheumatic disease has symptoms of COVID-19 and is chronically treated with glucocorticoids, at least at low dose, this treatment should be continued. If they experience mild symptoms, potential treatment changes in DMARDs should be discussed on a case-by-case basis. Now, the ACR has also published the guidance. Now, this is version 3, and they are a little bit more strict than we are here, because they say following exposure to the virus, hydroxychloroquine and immunosuppressants, non-IL-6 biologics and JAK inhibitors should be stopped temporarily, and in selected circumstances, IL-6 receptor inhibitors may be continued. And they also say that if there is documented or presumptive COVID-19, all the drugs, with the exception of IL-6 receptor inhibitors, should be discontinued. I'm not absolutely sure. This is obviously, you can see here, moderate consensus, moderate to high consensus of the task force, and level of task force. I'm not so absolutely sure how much this is based on evidence. The story of IL-6 receptor blockers is still discussed. They are very good, apparently, for very severe disease, patients with a cytokine storm-like disease on the intensive care unit. But I'm not a COVID-19 expert, and I'm just showing you what the guidance of the two major societies is. But just last week, Anja Strangfeld and Pedro Machado published a paper from the Global Rheumatology Alliance register on factors associated with COVID-19 related deaths in people with rheumatic disease. And they looked at inflammatory joint diseases, connective tissue diseases, including vasculitis and other diseases such as gout or others, and they looked at all types of therapies. And in that register, there were 3,729 patients with all information needed, and there were 390, so a little bit more than 10% death. And they divided this into patients with CTD, with 147 deaths, and inflammatory joint disease with 211 deaths, of whom there were 166 deaths in the RA subgroup. And as with all other patients who suffer from COVID-19, age is an issue. Look at this. Over 65 to 75 years, this is all patients in the black. RA patients are in the orange. CTD patients are in the blue. Other inflammatory joint diseases than RA is here. So overall, there is a threefold increase in death in patients 65 to 75, but there is a sixfold increase in death in those above 75. We know that from the general population as well, so there is no exception here. Male sex, we also know that from the general population, is about 1.5-fold increase. Interestingly enough, here, smoking does not appear to be such a high risk, at least not as high a risk as having uncontrolled disease, even moderate disease activity. So we are coming back to what I said before, that is unacceptable. This is an unacceptable situation also for COVID-19 risk, to leave patients with moderate disease activity. Look at this here, twofold increased risk. But what about the various medications? Now, to me, the biggest surprise was that when you have no DMARD, you are at a pretty high risk, twofold risk compared to antimalarials. So you see the notion by the ACR, I'm not so sure, or influnomide is not so risky. Sulfasalazine appears to be risky, and immunosuppressants, obviously, such as cyclophosphamide, tacrolimus. TNF inhibitors are not. Abatacept is not. IL-6 inhibitors are not. IL-17, 23 inhibitors are not. Targeted synthetic DMARDs may be, but it's overlapping with one. The one that stands out here is rituximab. Well, that's not surprising us, because rituximab interferes with the B-cell response and thus interferes with the immune response to the virus, reduces immunoglobulin levels, and so on and so forth. So this is a drug that I would really suggest that should be postponed as long as possible if a patient is at risk of contracting COVID-19. But as I said, the surprise to me was that the no DMARD patients had a higher risk than DMARD patient, twofold. And then the story of glucocorticoids at 1 to 10 milligrams for the CTD patients, apparently a risk, less so for the other populations, but at more than 10 milligrams, it is essentially also for all patients here in the black. Now, what are we doing today? We've just heard a half hour ago or 40 minutes ago a talk on vaccination, and this is exactly what we hope that will resolve the issue. And again, EULAR has provided points to consider for COVID-19 preventing vaccinations. It's on the homepage. And a question, for example, do I need to be vaccinated? It is wise for everyone to be vaccinated. Do I need to get an urgent vaccination? Well, there is no need for urgency. If you have comorbidity or are older, like more than 65, you should be prioritized just like the general population. And this is country-specific situations. Is one vaccine better for me than another one? We don't actually know that. There have been no head-to-head trials of vaccines, but regardless, any vaccination is better than no vaccination. I had COVID-19 and recovered from it. Should I be vaccinated? Well, yes, there is no data on that, but clearly vaccination is considered to be safe and potentially confers additional protection in patients who have already had COVID-19. Can I get the vaccination if I take my anti-rheumatic or immunosuppressive drug? Yes, you can. The only exception is rituximab. Then it should be postponed. Rituximab should be postponed. There's not a risk for side effects, but a high risk of less efficacy. Do vaccines interfere with my medication? No. What about side effects? It is rather early for a definite answer, but the vaccines are remarkably safe. What should I do in case of flare? Contact the rheumatologist. And what about long-term effects? Rather early for a definite answer, but the vaccines are tested and remarkably safe, as we said before, for the side effects. Does the vaccine activate my illness? Well, we don't have enough experience. There were not so many patients who were already vaccinated, but this is highly unlikely. Other vaccines also don't do that. That brings me slowly to an end. Let me come back and include here, in the best care, our approach to having patients at risk for COVID-19 and patients who have to be vaccinated. Primary target of RA, remission or low disease activity. Treatment should be goal-oriented and governed by a strategic treatment approach. Patients should be closely monitored using composite disease activity measures, and treatment should be adapted if the treatment aim is not reached within 3 to 6 months. And for example, CDI reduction by 50% at 3 months and the target reached at 6 months. And best care also includes counseling of our patients, making shared decisions with our patients, counseling our patients in all regards. Professor Gosek was mentioning comorbidities before, and now also with respect to COVID-19. With that, I would like to thank the people who have contributed to the research. Daniel Aretaha on the one hand, Emmanuel Bezzeri on the refractory area, but obviously all the various ULAR task forces from the RA management task force to the task force on what to recommend for vaccination. And I thank all of you for your kind attention. I'm happy to entertain questions.
Thank you, Professor Smolin, for this very excellent talk. It was really interesting to follow all the way through, covering both important aspects of refractory disease and later on COVID-19 and what's going on. Unfortunately, we only have a time for one question. I'm going to choose that myself, which is, in terms of the vaccination here, we've got the killed vaccine, and we have the recommendation that to avoid if the patient has uncontrolled autoimmune disease. Do you see that applies to our rheumatic diseases? And what should we say to our patients who still have an active lupus or rheumatoid or any autoimmune disease?
Well, don't vaccinate and try the disease. I think everyone should be vaccinated, and I guess that there is no reason, there is no risk of the vaccine. In my view, with anyone who has an autoimmune disease, the only risk that there could be is to have a lesser response, especially if you use rituximab, maybe also other immunosuppressants, not the immunomodulators that we use. So I don't see a reason to not vaccinate. I tell all my patients to get vaccinated.
Any risk of activating the autoimmune disease, make it more aggressive or something?
Why should it? Why should it? Do you have an example of a vaccine that activated in the past? Does the influenza vaccine activate the disease? Does the pneumococcal vaccine activate? Does the zoster vaccine activate the disease? No. they usually don't activate the disease. There's very specific immune responses, and I don't see that. Of course, our patients flare, 1 or 2 or 3% of them flare every month. So yes, incidentally, they may flare, then you have to control the disease. But I don't think we have any evidence that autoimmune diseases are activated yet. There are some past data that certain adjuvants may activate a broader immune response. Now, these have for years not been really used, but bear in mind that most of the drugs, most of the vaccines that we use today have no real adjuvants in there. Like the mRNA vaccines don't have adjuvants in there, to my knowledge.
Thank you very much for your time and for being with us today. And it's a pleasure to talk and see you again. Thank you very much.
Okay, I would like to welcome you all in this non-CMA session. This is symposium actually sponsored by Sandoz. As you can see in my slides here, the title of this symposium is about high-remote and expanding options for patient care. This is my disclosure. I have no conflict for this presentation unless this talk already sponsored by Sandoz. The objective of my talk will include 3 main objectives or 3 segments of this presentation. The first one, which is history of one major step in the management of rheumatic diseases. The second one will be one more higher step, which is the biosimilars, and I will say why it is more higher step. And the third one, which will be biosimilars regulatory pathways. If we go back almost about 50 years, we have changed our treatment for most of the rheumatic diseases, especially in rheumatoid arthritis, because of the high rate of progression of joint destruction and erosions in the first 1 and 2 years. That's why we start to implement what is called the inverted pyramid approach almost 40 years back by starting the immunosuppressives or the conventional DMARDs as early as the diagnosis, aiming to prevent or hold the occurrence and the progression of erosions and deformities. But unfortunately, this step was not enough to control the activity of the disease in our patients. This is based on the data presented by Joseph Smolin in 2003 in the EULAR, showing that this already conventional therapy at that time, 27% of patients only achieve what's called remission, and 51% of them remain in partial remission, and 21% remains totally active with no remission. So it was not enough to our patients. That's why the major step happening in the management of rheumatic condition or rheumatoid arthritis especially was a start to target the inflammatory cytokine as the most important. One of them is the TNF. As by start to control or neutralize the TNF, either soluble membrane bound, this allow us to block the intracellular signal and keep the nucleus factor kappa beta in quiescent phase and control the inflammatory cycle and prevents the inflammation and progression of the inflammatory arthritis. So biologics are very great. So how it is developed, the development of biologics. To develop a biologic actually starts in the lab first by analytical characterization to have a rationale of structure and a rationale of function of this molecule. Starting then again to go for non-clinical studies, usually in animals, to show safety, toxicity, and the behavior of these medications, and testing the proposed mechanism of action. The third point, coming to the clinical pharmacology, it's done in vivo to have the full pharmacokinetics and dynamics of the molecule and the dose finding, ending by a huge evidence and the study for each indication for the biologic will work for. Imagine that if you have one biologics, we need to 10 indication, you have to prove efficacy, safety, and immunogenicity for each indication of them, which is a huge work, very expensive process. Actually, the proposed cost of one new biologics about $1 billion. So it is a very expensive process, but it was effective for our patients. That's why biologics are very important. They change and improve the outcomes in several rheumatic diseases and have significant efficacy in patients who don't have adequate response to the old conventional synthetic DMARD therapy alone. So biologics are good, yes, they are good, but it is limited. Despite this good efficacy and marvelous control of inflammation with this medication, but the high cost is still a limiting factor for the prescription. And in front of this limited accessibility, we have inequalities of patient care between patients based on the severity of the disease. You can imagine that the cost of adalimumab or Humira in 1 year, 2017, cost about $18 billion in only in 1 year. And Remicade and etanercept, Enbrel, each one of them cost $8 billion only in 1 year for treatment of patients based on the guideline, which is already limiting the prescription of these biologics. So we have achieved one major step in management of rheumatic diseases, which is the biologics, but now we have to move one more higher step, the biosimilars. Starting from 2013, actually, most of the highly effective biologics coming out of patency, so which give a window for making similar products at lower cost with different pharmaceutical companies, which allow already us to profit more patients as the expected cost was lower than the brand or the reference biologics. Biosimilars already running now to cover multiple molecules, starting from adalimumab, etanercept, infliximab, and even rituximab has been approved in different countries, and already there are many coming in the pipelines, and even the EULAR recommendation lastly showing a preference and privilege for lower cost therapies, especially if they have similar efficacy and safety. So biosimilars are supported by the EULAR recommendations, as it is good for our patients to save the money and already allow us to serve more patients. So we have a biosimilar impact. The impact of biosimilars mainly about the reduction of cost. Reduction of cost, for example, here in the UK, already in 1 year, from 2020 to 2021, the expected or estimated cost saving is about 200 to 300 million British pound or UK pounds only in 1 year. And this amount is supposed to be reinvested again in patients' care and allow already to extend or expand the biological covering for most or bigger number of patients, which is totally very good to our patient to have a better cover and easier access to such an effective medications. Another example for the efficacy of cost reduction by biosimilars coming from the US and Europe, as the expected saving from biosimilar medicine totally in 2005 to 2020 is about $107 billion in this 5 years. And interestingly, the 21% of this cost reduction or cost saving coming from the anti-TNF alone. So already it's a big, huge amount of cost saving, which already can be redirected and invested again for patient care. Another important evidence published in the RMD Open in 2016 showing the impact of anti-TNF biosimilars alone in Europe in 2016. As you can see here, by each reduction of the price of the anti-TNF, there is a correlated increased percent of prescription of biologics to cover our patient. For example, totally in Europe, in the left column, you can see a reduction of 30% of the cost of biologics is associated with 19% increased prescription and covering of biologics to patients. So the biosimilars have a good profit to our patients. So we did the good step by biologics, and already now we have to move to a one higher step, which is the biosimilars. But before moving, we have to have an established, well-defined process. What is the biosimilar, at least? What is the known, well-defined definition of biosimilars? If you are going to compare the brand or reference drug to another drug, we have 3 options, either to be the same or similar or totally different. This is the 3 options that we have. In this presentation, we are looking for the similar. We are looking for the biosimilar. And in the similarity itself, we need to understand more. What is the similarity? Is the similarity of the structure, composition, or a structure in the shape, just similarity in the structure, or what is called the identical twins similarity. So it should be already identical to each other. What kind of similarity you need? That's why we need a well-defined definition to understand what is biosimilar. When we speak about medications, so we have the originator, which is already the brand molecule, either conventional or biologics. This medication have established clinical benefits and risks, well understood and investigated pharmacokinetics and those finding studies, well studied in vivo, showing safety and efficacy, and they have acceptable quality profile. This is the originator. If you're going to have a copy from this originator, which is already a synthetic DMARD, conventional DMARD, it's easy. You have a generic. Generic just to have, don't require to have clinical established efficacy, don't require to have in vivo safety and efficacy, just to do a bioequivalent study and have a good quality profile, so you can register your medication as a generic for a conventional medications. So what is the situation for biologics? We have three options, either to be biosimilar, biocopies, and biobetter. So we have to know what is these three definitions involved. For biosimilars, actually, which is the main objective of this presentation, we have three accepted international definitions coming from the FDA, from the EMEA, and from WHO. According to for the FDA, defined biosimilars as a biological product that is highly similar to a reference one with notwithstanding minor differences in clinically inactive components, no differences from the reference product in terms of safety, purity, and potency. As regards the EMA definition, defines a biosimilar as a biological product that contains a version of an active substance of an already authorized original biological medicinal product, demonstrates similarity to the reference product in quality, biological activity, safety, and efficacy. And this already similarity based on comprehensive compatibility exercise. Coming to the WHO definition for biosimilars, defined as a biotherapeutic product that is similar in terms of quality, safety, and efficacy to an already licensed reference biotherapeutic product. Decision making regarding this similarity based on scientific evidence. So we have in the definition, we have fixed component in all three definitions. We have similarity components. We have the reference product and bioequivalent products similar to each other in efficacy, safety, and the purity. And this similarity already proved based on a scientific evidence. This is already the contents of the all three definitions of the biosimilars. So what about the biocopies or biomimics? Biocopies is just a version or copy of the therapeutic protein that is not developed based on the quality assessment or similarity assessment, and not assessed in line with scientific principles as a comparative development program against a licensed product. So it is not tested and prove similarity in the quality, safety, and efficacy in comparison to a reference product. So it is not trusted to be replacing a reference or brand product. For example, in this, if you are comparing biosimilar and reference products, you can see here in gel A and gel B using a common test used to assess proteins under sodium and anode, who can differentiate and analyze two different layers and steps, what is called gel electrophoresis. If you look for the column right and left, it will be similar to each other in gel electrophoresis, which already is the expected similarity from the biosimilar and reference product. But if you look for this second slide, you can see the reference product in the blue square, and the other columns here for biomimics or biocopies. You can see this already. These proteins already behave very differently from the different reference products under the cathode and anode. So that's why it is there is a big differences between the biocopies and the biosimilars. What about the biobetter? Biobetter is a biologic with the same target mechanism of action from the reference product, but have some changes regarding structural changes or bifunctional changes, or just improved formulations, like from intravenous to be sub-Q, or from sub-Q to be intravenous. At that time, it cannot be considered as a biosimilar, just a change in the formulations. and this already changing, expected to have a better clinical profile. And this medication actually undergoes the same registration product, looks like the brand biologic or reference product. So the registration of biobetters is totally different than the registration of biosimilars. So coming to the third segment now, we have passed through the first one major step in our management, and it goes to the second segment showing the higher step, which is called the biosimilar, and understands what is the definition of these biosimilars. Now going to the third step, which is the biosimilar regulatory pathway, how to form this, regulate the formulation of this biosimilar. Starting from 2009, the WHO issued the guidelines for evaluation and assessment of similar biosimilar medications and left the implementation to each country based on the local regulations. For example, in EMEA started in 2004, the first legislative pathway initiative for biosimilars, and ending 2015 by the latest non-clinical and the clinical guidelines, which is revised to how to develop and trust the biosimilarity process. If you speak about the steps of biosimilar development in comparison to the biologic development, here's the major step here in biosimilar, which is the analytic characterization, which already done in lab. You have to make sure that your molecule is proved the similarity to the reference product using analytical characterization in the structure and the function. And this already should be proved with different steps. I will speak in the next slides. Already, this is the major step and the most costly part of the process of biosimilar development. Second step, it is non-clinical studies. Again, in animal, looks like the biologic development, just to test the toxicity and show the behavior of the molecule or protein inside the body, inside the lymph nodes and the lymphoid tissue, looks like, compare it to the original or reference product. Coming to the third step, which is the clinical pharmacology, which is done already in vivo. To test the pharmacokinetics and pharmacodynamics, you have to compare the biosimilar to the reference product regarding the Cmax area under the curve and the how to be excreted and how to stay in the serum in comparison to each other to prove the similarity in behavior inside the body in pharmacokinetics and the pharmacodynamics. Ending by a very small part here in comparison here. This is actually a typical pyramid, and in biologic development was an inverted pyramid. Here the base is analytical characterization, and the base in biologic development was the clinical studies. In the clinical studies of biosimilar, you have to prove similarity, clinical similarity between the reference products and the biosimilar only in one approved indication for the reference product as regards safety, efficacy, and immunogenicity. And after that, we can extrapolate all the approved indications for the reference product to the comparable biosimilar product. So simple, usually short trial, just to make similarity between safety, efficacy, and immunogenicity, and it's not a must to have a big number of trials involving all indications for each indication for the reference product. Here, which is the extrapolation, as we said before, that biosimilar may obtain extrapolation to other indications for which the reference product is approved without specific studies of those indications, provided that the proper scientific rationale is provided for each indication which extrapolation requested. So in the biosimilar development, we have to prove analytical similarity, which is already non-clinical done in vitro. We have to prove that toxokinetic similarity, which is done in vivo in animal studies, which is non-clinical. We have to prove the pharmacokinetic similarity, which is done in clinical part in vivo. And finally, you have to prove the clinical similarity done in vivo. This is the actual 4 steps to have a trusted and evident biosimilar in comparison to a reference product. So we have the elements of development program, as we said, the 4 elements to have it. And after approval, we have to speak about how to start and how to maintain and switching. Actually, it was a big talk. Usually needs separate slides to know when to start biosimilar and how to maintain it. And it is legal to switch or not based on some references. I will limit only one slide for switching about UK experience in 2016 from York Trust Rheumatology Service. She investigated the switch process for etanercept biosimilar from the reference to the biosimilar etanercept SP4. They switched 363 patients switched for biosimilar etanercept, and 14 patients already declined, 4% declined the switching. After three months, 97% of patients report no change in these activities, so it is already the same response, similar to the reference product in clinical scenario, and 3% of patients has reverted to reference product lack of efficacy or loss of efficacy or some reaction or skin rashes could happen already with the reference product. So there's a big similarity even at the clinical level of switching. So what about the highly mode adalimumab from Sandoz, how it is developed and if it is already have the evidence for clinical similarity and analytical similarity or not? Highly mode already matches the reference adalimumab in terms of safety, efficacy, and equality, as we'll see in the couple of the coming slides, starting by the analytical similarity. The analytical similarity, actually, the Hyrimoz proved to be similar to reference adalimumab by different analytical exercises, starting by TNF-alpha neutralizations. You can notice that the curve for Hyrimoz is almost typical, comparable to the curve for adalimumab, either from US source or Arabian source, which indicates that analytical studies provide evidence for a high level of similarity between Hyrimoz and reference adalimumab. Again, second analytical exercises, which is defined to know the amino acid sequence or peptide sequence through the peptide mapping, and already shows as a great similarity between the reference product and Hyrimoz with comprehensive analytical similarity, showed already similar amino acid sequences and peptide sequences at folding and mapping. Coming to the third physiochemical studies to prove the similarity between Hyrimoz and the reference adalimumab using the spectroscopy to know the 3D dimensions and all shapes of the examined biosimilar, and analytical studies provide evidence for a high level of similarity between Hyrimoz and the reference adalimumab. So as regards the analytical studies, which already proved to be similar to the reference product, what about the clinical similarity? In the clinical similarity, actually, the Hyrimoz proved similarity with reference adalimumab in two indications. Not only one, we have two trials done to prove clinical similarity between Hyrimoz and reference product. First one done in chronic plaque psoriasis was called the AD-ACCESS trial, which actually a unique, innovative 4-time switch trial. Actually, I'm first time to see this design of switching, and it's already showing a trust in switching between the reference product and the Hyrimoz. The study design already having 3 phases. The first phase or treatment period was the first 17-week. Already there's just a parallel arm between Hyrimoz and the reference product. After the 17-week, each arm is divided by 2 to 1. 2/3 of the arm continue as a treatment, as the same treatment, like Hyrimoz continues the same Hyrimoz up to week 51, and 1/3 already undergoes frequent switching between reference to Hyrimoz and then Hyrimoz to references and references again, still week 35. After week 35, all arms reunite again to have the one arm of Hyrimoz and one arm of adalimumab continue up to week 51. Based on the AD-ACCESS results, the efficacy of Hyrimoz is equivalent to its reference medicine in moderate to severe chronic plaque psoriasis that achieves almost similar PASI 75 response between the two arms at week 16, which is the phase 1. As in Hyrimoz was almost about 67%, and in reference adalimumab was 65%. So there's no significant difference between both arms as regards the efficacy in achieving PASI 75. And as regards the mean change from the baseline in PASI score is also identical identical curve starting from 0 to week 50, 51 between the all groups, either between the group continue as the reference product or group continue as the high remove, or the two groups undergo frequent switching, which indicates switching doesn't affect actually the result or the curves related to each other. And the same already can be noticed again in PASI 50, 75, 90, and 100. As regards safety profiles, there is no clinically meaningful differences in number of or severity of adverse events between the reference product and the high remote. And the most important about the immunogenicity, which actually a good presentation representing actually the similarity in the products, that there is no significant difference between the immunogenicity of high remote and reference product adalimumab, which gets great similarity in the clinical behavior inside the serum. Coming to the second clinical similarity evidence from rheumatoid arthritis patients, the ADMIRA trial. ADMIRA trial using a standard two-arm comparison between the reference product and the high remote up to week 24. After week 24, the study period time in this is in the treatment active arm of the reference adalimumab switched to the high remote arm, and all the result collected at week 48, the end of the study, with switching, and the primary endpoint was assessed at week 12. Based on the ADMIRA results, the efficacy of high remote is equivalent to that is reference products in patients with moderate to severe rheumatoid arthritis. As you can see, the mean change in DAS28 CRB from baseline at week 12 almost similar, minus 2.16 in high remote and minus 2.18 in reference adalimumab. As well as the mean change at week 48, still also similar, almost identical, minus 2.9 in both arms of high remote and reference adalimumab. As regards the immunogenicity, again, there is no significant difference between the high remote and reference products, which indicates a high degree of similarity and antigenicity of both molecules. So we can conclude that the high remote development program proved to have the same amino acid sequence and same analytical similarity proved by many physiochemical exercises, and similar toxicokinetics and lymphoid behavior with similar pharmacokinetics equivalent study, and clinical similarity proved in two indications, rheumatoid arthritis and psoriasis, and of course it can be extrapolated to all different indications in which the reference adalimumab approved for. One last point which already mentioned by the company, that the sensory ready pen, which already known for us mostly for years, used this pen already for Cosentyx injection, which already has the same sensory ready pen with great tolerance and less pain, already accepted by patients, nurses, and physicians. Actually, this was my last slide. This is my references, and I can say thank you.